Уважаемые коллеги, уважаемые друзья, мы рады приветствовать.
Distinguished colleagues, dear friends, we're extremely happy to welcome you at the first International Multidisciplinary Congress, which is devoted to the patient blood management in clinical medicine, PBM in clinical medicine. So these 2 days, 2 busy days, would be devoted to very important issues of implementation, design, and application of PBM principles to the clinical practice. So today we will enjoy the presentations of the global leaders, international Russian speakers, and we will share our experience, our humble experience with all our colleagues, how PBM principles are implemented in the different medical areas. So we will speak about terminology, about definitions, about the principles of implementation, about the economical component, whether it's efficient, cost efficient or not, and how we are going to use the PBM principles in clinical practice. So the organizers and the initiators of the Congress is the National Association of Patient Blood Management and also International Foundation of PBM, also Australian Society on PBM, and many other professional associations that are promoting this initiative. And hopefully this Congress would be of use for all the clinicians who are working directly at patient bed, also to the healthcare organizers, to payers, because that is extremely beneficial, because specifically the structure, the organization, and cost efficiency clearly depend on the regulatory component here. Also, we will enjoy the presentations of financial guys and those who deal with economical outcomes, and they will show us how cost-efficient this approach is, how effective we can save physical, economical, psychological, and other type of resources. So I would like to wish all of you all the best to our Congress, because we are all very much excited. This is the first Congress and hopefully not the last. And we do believe that in the future our association would be a strong lead of promoting this concept in the Russian Federation. So all healthcare organizers, all stakeholders will be around us, and we will be able to promote PBM concepts in practice, because firstly and mostly we are focused at the patient outcomes, and hopefully it will reach the national level. Thank you very much and all the best. Enjoy the Congress. And now I think we're about to start and go directly to the agenda. And I'm happy to give the floor to one of the global leaders, best leaders, super leaders of the International PBM Foundation, Professor Ariya Shandor, who is the lead of resuscitation and ICU, pain treatment and hyperbaric medicine in the Anklewood Medical Center, New Jersey, United States of America. The floor is yours. You're welcome. So this is PBM definition, facts and myths. The floor is yours. You're welcome. Professor Ariya Shandor.
To participate in this most important clinical symposium. My topic is patient blood management in terms of the clinical medicine, but as you can see, I changed this to say a standard of care. This is the overview. We'll start off with addressing what is the standard of care. In that context, what is the aim of healthcare altogether, whether you're in Russia, whether you're in the United States, or any other country. Then we're going to address what is patient blood management through its definition, the current approach, as well as this, which is the standard today versus a medical model. And you will see that there's a discrepancy between what we do when it comes to managing neurological needs of patients versus what we should be doing. The issue of therapy versus disease management is one of the ways that we can explain that. And again, we'll go back to patient blood management as a standard of care, and then probably just a couple of words in terms of where we're moving in the future of patient blood management. So you can see there are historical developments in terms of the standard of care definitions. It was based upon custom in the beginning, but again, some people suggested that which was typically done is considered to be the standard of care, whether it was right or wrong, which again you can see will not do that. I think the 20th century definition by Helling and Carey, again, that which is customary done plus anything that seems reasonable, even if not typically done. So this now allows us to be a little more broad. And the modern definition, which you can see the people who've put that forward, is that which is minimally competent physician, the same deal will do under similar circumstances, which is not what we're looking for. So I think that the 20th century definition is the one that we will stick with. Now, whether it's anywhere in the world, the triple aim of healthcare, which is again making sure that the population is healthy, experience a good contact with any healthcare providers, including institutions, and of course, reducing or containing cost. What's of course missing, as you can see added to that, is the improved clinical experience by the clinicians, so that we also need to be accounted for when we're looking at this triple aim, so therefore it's a quadruple aim. And when you talk about the triple aim or quadruple aim now, is patient-led management improves outcome, reduces complications, increases the clinician satisfaction for all of you, and lower costs. So as you can see, it's doing everything that we ask it to do. In addition, it improves patient safety. A nice way of addressing this. This is one of many definitions of patient-led management, but this one again, like many others, is patient-centered. And it's defined as the timely application of evidence-based medical and surgical concepts designed to manage anemia, optimize hemostasis, and minimize blood loss in order to improve patient outcome. This is patient-focused. It's a medical condition or disease focus. We're not talking about transfusion. But again, as you can see, the traditional model, which is the current standard, revolves around transfusion, which is a therapeutic intervention, with blood components, which are products. So it really centers around the safety of the product, the availability of the product, the surveillance of risks after the product is being used, indications for its use, which are repeated over and over again. And again, there's no measure of outcome once it's used. We basically accept it as part of doing business of medicine on a daily basis. So this is product management and not an issue for patient management. Now, this is from the Blood Establishment, published in 2018 in the International Society of Blood Transfusion. As you can see, I just want to show you where we are. Blood transfusion, 1 unit too much or 1 unit too few, which strategy poses the smallest risk for the patient? We're talking about reducing risk. But you can see also that sufficiently powered prospective randomized controlled clinical transfusion trials for packed red cells in most clinical centers are urgently needed to reduce ill-founded clinical decisions and to base transfusion strategies on clinical evidence and scientific study results. We still don't have it in 2018. We're now in 2021. We're still doing the same thing. But this only talks about the risk to the patient. We never do something which is low risk to patients. I don't give antibiotics to patients because it's low risk. I do it because it has greater benefit than the risk of the antibiotics. And they're not addressing benefit of transfusion. So this brings us to the medical model, where this is patient-led management. What we do with patient-led management is what you do normally as a clinician. We identify the disease. As an example, we're going to be using anemia. You identify the potential causes, understand the epidemiology and the natural course, including social burden of a disease. Select the best treatment and therapy because that changes with the time and as the disease progresses. Address prevention. The one thing that is we need to invest in, of course, is prevention of a condition. And again, measure outcome of what we do. And patient-led management brings this all to the front because it is disease management is what we do. We don't manage products. Now, there are some who've put together, this is from our colleague Axel Hoffman and Shannon Farmer, where again, this is the 3-pillar, mostly for the surgical patient, but you can see above is patient-led management. You see the first, second, and third pillar. These are all very sensible steps in terms of identifying the hematological needs of the patient who undergoes surgery. But most important about this slide is on the bottom. This is multidisciplinary team approach. Where else in medicine do we work as a team? Well, here's where we should be working as a team. And the success of patient-led management clearly depends on working as a team. There's been another thing added, if you will, over time. As you could see, the 3 pillars of optimizing coagulation, interdisciplinary conservation, blood conservation modalities, management of anemia, these are all, again, explained in the first 3 pillars that we talked about before. But what we added also is patient-centered decision-making involving the decision of the care of the patient with the patient. This is something which is becoming much more prevalent, both in the United States and everywhere else. It doesn't mean the patient will make the decisions, but what this means is the goals of the patients for healthcare outcome is similar to the goals of the clinician for that patient. Now, as you could see, I highlighted anemia on the previous slide. Just want to give you the breadth of this disease, because while some people argue it's not a disease, it's just a condition that reflects the underlying disease. Well, if you can make a diagnosis and you can make it, and you could choose a treatment for it, why can't you call it a disease? That's why I would call it a disease. But you can see that worldwide, anemia is extremely prevalent. It is the highest risks in children less than 5. Women altogether, pregnant and non-pregnant women, make the largest group of individuals suffering from anemia. And of course, the elderly, that number is climbing. So you can see that more than 2.3 billion people in the world suffer from anemia. The global burden of anemia is one which we need to look at. So this looks at the prevalence of anemia on the left, but more importantly, it's the years lived with disability, or YLD, which is the burden of disease. And anemia is one of the 4 most burdenous conditions in the world. Cancer, diabetes, and heart failure or heart disease precede anemia, and anemia is number 4. What's interesting is the green here in all of these bars, because the green tells you that this is iron deficiency as the cause of the anemia. You can see that is the number 1 cause, which is easy to diagnose, easy to treat, and there is a high rate of cure. But what is the current standard? Well, anemia is often accepted or ignored. There's a long tradition of accepting anemia as a harmless problem that can be easily corrected with transfusion. For the medical community, transfusion as a treatment for anemia remains a default position. The new paradigm, which is what we're talking about today, is that anemia is an independent risk factor for morbidity or mortality, regardless of the level of hemoglobin or underlying disease. All you have to be is in the anemic range. And you can see this is on surgical patients. Anemia here, as depicted on the bottom, as your hemoglobin or hematocrit drops, the mortality rate, which is inversely proportionate and almost is linearly related, increases. And 40% of the surgical population have some level of anemia, putting them at this risk of adverse event. Now, one other way that we deal with anemia in the hospital patients is the fact that we collect enormous amount of blood. So you don't have to go to surgery. This is data, again, published in 2014, showing that each 25 milliliter of patient's blood is thrown into the waste containers annually in Europe. This, again, is 4 times more than the total volume of blood that is transfused each year. So we are actually causing an iatrogenic disease. And this data has been actually looked at by other investigators. And here you could see the different anemia, mild, moderate, and severe in this table. And then you could see that it has a significant impact. You could see that 74% of patients had hospital-acquired anemia on admission, and you could see how it's divided over the levels of the anemia. Mortality risks goes up as the anemia gets worse, length of stay goes up as the anemia gets worse, as well as cost to healthcare as the anemia gets worse. So when we do this, we need to think about why are we getting laboratory values every day on patients repeatedly. In fact, this data that was published looks at the fact that if you every day that you repeat the same tests, these are chemistry tests on the patient, you're going to end up actually reducing the importance or the data that you're getting being important by 20%. By 5 days, you'll be at 0. There are only 2 tests actually which have value doing them every day, and that is a type 1 diabetic or some diabetic who has a glucose issue, and the other is a patient who's developing renal failure where you need to follow their potassium. So we're taking blood, and the information we're getting from that is really not that important repeatedly. However, what we will do is cause anemia, which is associated again with a worse outcome. And this again suggests that if we intervene, meaning stop doing these tests, we can actually decrease the amount of anemia and therefore reduce the patient's exposure to allogeneic transfusion. So where are we today with patient blood management? Well, we can go back all the way to 2010, which is more than a decade ago, where we had Resolution 6312, which was the WHA and the WHO, and you could see provide guidance, training, and support to member states on safe and rational use of blood products to support the introduction of transfusion alternatives, including, where appropriate, autologous transfusion, safe transfusion practices, and patient blood management. And they're also asking, as you can see from the top, promote patient safety to promote the availability of transfusion. But again, we didn't see safety when I showed you the ISBT publication for 2018, but we do see again recommending patient blood management. In the US, this was publication in 2015. Again, National Patient Safety Foundation focuses on patient blood management. We recognize that transfusion is a patient safety issue, and we can answer this patient safety issue by implementing patient blood management. Another is that we use blood transfusion as a measure, but what a measure for patient blood management, if you recall one of the slides where we're looking at, again, improved patient outcome, here we're looking at length of stay and mortality, and this is by simply reminding doctors the current guidelines when they order blood. A California hospital was able to save money and lives. So we've gone from blood saves lives to save blood, save lives. And here's a 24% reduction when you could see reduction in mortality and average length of stay, which is essentially the cost to healthcare. So there have been a few publications asking, again, for us to put patient blood management as a standard of care, which makes a lot of sense. And these are some that you can review on your own, but you could see that they're in publications in different journals. Unfortunately, when we're looking at implementation and outcome, reduction in transfusion seems to be still the number one. But let me remind you that that is a sort of a byproduct of patient blood management. The important one is actually improvement in clinical outcomes and reduction in cost. And here is one reduction in cost analysis published in 2018. There have been others looking at this. And in addition to that, we know that there have been clinical outcomes associated with this. And this, again, is the key patient outcome from the Australian experience. In-hospital mortality is reduced by 28%, length of hospital stay down by 15%, infection rates by 21%, acute myocardial infarction and stroke 31%, but there was an increase in readmission unrelated to anemia. So we're looking at a large cohort of over 600 patients. And in addition to that, you could see on the bottom that there is economic outcomes, which is reduction in costs, which are counted in millions, actually, of Australian dollars. Other data shows, again, this is comparing patients without transfusion on protocol, meaning receiving iron and EPO as needed versus a transfusion compared to those patients just receiving transfusion. And you can see that in-hospital death, infection, thrombotic events, any morbid outcome or death were much higher associated with transfused patients than protocol patients receiving treatment for their anemia, as mentioned. And there's a simplified international recommendation for the implementation of patient blood management. Again, there's another patient blood management orthopedic surgery. But just to quote, the benefits of patient blood management programs, both for the patient and the healthcare system, appear indisputable. But they are not easy to implement, as several obstacles need to be overcome. But we can overcome each one of those obstacles if, again, we become resilient and stick to it. There are standards published here. This is from the Society of Advancement of Patient Blood Management, and standard quality guides. They're all there. The tools are there for your implementation, or again, for your review. So why patient blood management? Patient blood management extends to all patients' population from birth to death. Patient blood management offers appropriate therapy, not a single therapy such as transfusion for a disease or condition. Patient blood management is based on improving patient outcome, not in terms of reduction of transfusions. Anemia management is central to patient blood management. You can see that is a global epidemic. Patient blood management identifies anemia as a global epidemic. The first step in eradicating the epidemic is increasing awareness, which is what we want to do today for everyone. And all above are consistent with good clinical practice, or GCP, which is better or higher level than evidence-based practice. So with that, I bid you thank you and goodbye and good luck with this symposium.
So thank you, Arju, for this very important introductory talk. My name is Axel Hoffman. I'm affiliated with the University of Western Australia and the Institute of Anesthesiology at the University Hospital in Zurich, and I'm representing the International Foundation for Patient Blood Management at that meeting. So also from my side, welcome to all to the large audience from hopefully all over the world. So good morning to Moscow, but hello to all the other far and distant parts of the earth. So before we might continue, is there any burning question to Professor Chander's talk? I don't see any question in the chat box. So this being the case, and we're having still plenty of opportunities for discussion later on, I would like to introduce Professor Fedorova. She opened the Congress, so you have seen her already. Professor Fedorova is working at the National Medical Research Center for Obstetrics, Gynecology, and Perinatology, the Kulakov Center in Moscow. Her specialty is obstetrics, gynecology, and transfusion medicine. And she is the driving force behind the National Association of Specialists in Patient Blood Management, together with other colleagues, of course, but she is the current president. And so I'm very happy to introduce Professor Tatiana's topic under the theme Responding to the Urgent Need for Patient Blood Management, introducing the vision and mission of NAS PBM. Tatiana, the floor is yours.
Distinguished colleagues, dear Axel, dear international colleagues, dear colleagues who are physically here and those who are online, thank you very much for the introduction and the invitation. So today in my short presentation, I would like to speak about the challenges and the bottlenecks that we are facing in the implementation of PBM in Russian Federation. I have to say that the global task and the priority of the healthcare by now is definitely safety of the patients. And definitely we know that 194 member states, members of WHO, during the 72nd World Assembly of WHO established the Patient Safety Day. And the safety of the patient is the most important what we have now. So this is our global focus. And today, as we said before, many countries in European Union and also under the auspice of WHO are promoting the systematic approach to the patient blood management, which allows effectively use all the resources to increase quality and safety of treatment. And the whole world by now is saying that we need to optimize the level of erythrocytes in patients to minimize the blood loss and also optimize the physiological resources of the organism. By now, we are happy that we managed to establish the Russian National PBM Association, and also we are a part of the International PBM Foundation. The most important tasks are very well known to you. This is design and establishment of the international professional network of PBM leaders. And let me show here on the slide that in Russia we have our national leaders, and here they are, and you know many of them. So those who are promoting of PBM in cardiosurgery, in neurosurgery, in orthopedic surgery, in obstetrics and gynecology, rheumatology, ICU, anesthesiology, also the members of our association are financial economists, members, representatives of the Ministry of Health, and regulators. Definitely, we couldn't stay still when the whole world is focused on that concept and working with that. And by now, in order to coordinate our efforts to implement PBM principles in Russia, so all these leaders got together and established multidisciplinary National Association of PBM specialists. So first locomotors were obstetricians and gynecologists who are working in Kulakov Center, as it is the problem of PBM, especially in obstetrics. And especially in obstetrics is really very relevant because we know sometimes we face severe bleeds in the obstetrics and how important it is not to misuse blood components where it's not justified. That is why by now our National Association of Patient Blood Management is a truly multidisciplinary team that includes cardiovascular surgeons, obstetricians, gynecologists, transfusiologists, orthopedic surgeons, coloproctologists, anesthesiologists, ICU, blood management specialists, Foundation for the Healthcare Development, representatives of Ministry of Health and pharmacovigilance people. So today and tomorrow we will enjoy their participation, their presentations, and hopefully that will be very interesting to all of us.
During these few years, since our association was established and until creating this association, of course, we were not standing still. We were creating different guidelines, protocols on different blood components transfusion, on different methods of anemia treating, decreasing of blood loss, hemostatic control. You see on the slide how many different recommendations, books we created, and we use all of them today. And today, National Association for PBM, it is an information, education, and consultation site for initiative groups and PBM organizers. Today, our National Association is, and I hope it will be, the center where all the experts for PBM will be concentrated, and we will create joint protocols, joint clinical recommendations on the implementation and usage of PBM in the clinical practice in different directions. So during today's Congress, we have experts of all specialties, and tomorrow we will have sessions according to different directions that we mentioned. I mean, orthopedic, neurosurgery, cardiology, and so on and so forth. The purposes of National Association for PBM is uniting experts, the representatives of different medical fields, economists, decision makers, and stakeholders in PBM. And all this work is aiming to coordinate the activities of the main actions of experts for PBM, implementing the main principles of PBM to improve our patients' outcomes. Main directions of our work are presented on the slide. This is what we are doing, what we will do, what we have to do. We are creating national guidelines As I'm obstetrician gynecologist, I can tell you that we're creating about 30 different clinical guidelines using PBM principles. Same happens in cardiology, in neurosurgery, and in different other specialties. It is also important to have protocols, for example, to treat massive bleedings, to create different standards, information materials for patients and doctors, developing and implementation of system and plan of educational events for PBM. If we work only in our center, not touching other experts, we will never come to the national level, and we will not implement PBM in the Russian Federation. Because the main purpose of our association is that principles of PBM work not only in one center or in two centers, they should work in all medical establishments in the Russian Federation. It is also important to analyze epidemiology and economy benefits. We have experts of the High School of Economy and epidemiologists. They calculate the morbidity of anemia among pregnant women. We also coordinate our work with the Ministry of Healthcare and other bodies that define policy in the healthcare and social situation. It is very important to work to cooperate with ministers. And when our association was established, next day we signed a memorandum of understanding and cooperation with International Foundation of PBM, and Axel Hoffman, one of the leaders of International PBM Foundation, shapes PBM policy in the world. And this cooperation with International Foundation will definitely help us to be on the international level and to implement all our methods. And I hope that will happen, and we try to develop and to implement it. What happened during this time? We created our website, NAS-MKP, where main documents of the association are presented. We have here the purposes. So we describe here how one can become the member of association. Lots of issues that you can probably not understand during the lecture, you can check on the website. And it was recently, a year ago, European initiative with WHO suggested the European initiative for PBM. And in this document, we have the main principles of PBM and what should be done on the level of international and international work. These principles can be implemented both on international and national level. And we can use these principles in our clinical practice. We live in difficult time of pandemic. And of course, we face new challenges, sometimes with lack of blood components for surgical and therapeutical patients, and all the experts for PBM made a resolution, kind of call to implement PBM during pandemic. We demonstrated then when we use PBM principle, we see that the need for the blood transfused decreases, and we can use these saved blood components for those who really, really need it. The number of donors decrease because they are either infected or they are isolated. The donors are afraid of the virus, and they do not come to give their blood components. So today, in the circumstance of pandemic, the doctors who work in these really difficult circumstances implement PBM principles. Certain components are being transfused only, and when there is very clear indication with hemostatic control, with anemia control, What else? Our center and PBM group sent a letter to the Ministry of Healthcare of the Russian Federation on the must to implement PBM during the pandemic time, and our ministry, of course, supported. And we have Irina Podubna in our panel. She's one of the leading oncologists, and she supports the implementation of PBM in oncology. A committee was created for PBM implementation in oncology. Today, checklists and protocols for oncology patients are being developed. If we talk about erythrocontaining masses in anemia, when we need to transfuse red blood cell mouse and so on. Today, in the Russian Federation, we have lots of patients, oncological patients. We have long-term oncology strategy, and PBM can demonstrate its benefits. It also can improve economic benefits and improve, of course, the patient's outcomes. In our center as well, we have certain departments for oncology patients. We also start implementing PBM principles in patients of obstetric and gynecology profile. Comprehensive implementation of PBM in oncology is still underestimated, and it is underused. Only Australian National Institute of Blood implemented PBM into the oncology patient therapy, as well as ESMO created clinical guidelines for treatment of anemia and iron deficiency in oncology patients. I hope that in the Russian Federation we will create special model for PBM in oncology patients. As I mentioned already, a committee was established and the resolution was accepted in July of 2020, when we understand that there is need for call to implement PBM for experts for patients in oncology profile. Today, PBM works actively, and here is the list of sessions and events that were organized for reproductive gynecology in urgent states in obstetric and gynecology. All our experts participated in Academy of Iron. Then we participated in the 23rd International Congress for New Technologies in Diagnostic and Treatment of Gynecological Diseases. And in 2021, we started field work. We already visited cities of Orenburg, Tyumen, Irkutsk, and Khabarovsk. And we hope that our colleagues in other cities understand PBM and they will start implementing it on the national level. But of course, our main objective is not only following PBM in our center, but we need to be on the national level. So today, it's important that national strategy for PBM is implemented on the level of Ministry of the Healthcare. We are working now with the ministry, and we hope it will happen soon. PBM should step by step become obligatory in all the clinics, and they should be certified for PBM. It is one of our main objectives as well. While a clinic transits to PBM, individual programs for PBM should be created for each department based on multidisciplinary approach. PBM should be also implemented concerning the particularities of the situation. And for changing of therapeutic paradigm on the national level, PBM can become the key part of its development. And our main goal is to improve the clinical outcomes of the patient and to decrease their economic burden. Thank you for your kind attention.
Tatiana. I think this was a brilliant overview and a great presentation of the dynamics behind NAS PBM, and I think you are on a good trajectory, and we are looking forward to more of the achievements of NAS PBM and all the medical societies and institutions working together with NAS PBM. Before I hand over to Alexei Pirogov to lead the next session, I also want to thank the translators for their excellent service. So, Alexei, it's yours.
Thank you, Axel. Actually, I would love to thank everybody for coming. I see that people are coming more and more, and more than 7,000 people are listening to us online, and we have more and more people online, and that's why we continue patient blood management in clinic, part 1, and I would love to pass floor for the presentation to Professor for Department of Biological Science, to Professor John Hoon Park from South Korea. PBM in surgery, part 1, surgical role.
Good morning, ladies and gentlemen. It's an honor to be invited to such a meaningful international congress. Thank you, Chairman and officials. My name is Chong Park from Korea University Hospital. I'm an orthopedic surgeon and my specialty is orthopedic oncology. Today, I will give you a presentation on the PBM in surgical populations and the role of surgeons. The Hippocratic Oath is an oath of ethics historically taken by physicians. It is one of the most widely known of Greek medical texts, and it is often said that exact praise, first do no harm, is a part of original Hippocratic Oath. The other was the most important virtues in the healthcare is that the safety of patient. And this is probably the most important issue for surgeons as well. The universal thought of blood transfusion in the last century has been that blood transfusion saves lives. And this belief has lasted until recently as medical common sense. However, breaking this common sense, in the Nature 2015, an interesting article was published regarding saving blood would lead to save lives. The authors stated in the subtitle, transfusions are one of the most overused treatments in modern medicine. And this article stated that by reducing the blood used for transfusion by 1/4, not only saved $1.6 million per year, but it also reduced average length of stay for patients who received transfusion, and mortality among them also fell from 5.5 to 3.3%. What is the meaning of this study? Which completely overturns the existing concept published in the Nature. Most people weren't aware of it, but in fact, opinions about blood transfusions have been changed since decades ago. For example, according to Professor Span's research in 2008, transfusion of allogenic erythrocyte transfusion has also been found to be an independent factor increasing mortality in trauma, including trauma brain injury, burns, liver transplantation, intensive care medicine, and the treatment of acute coronary syndrome. The benefit of allogeneic erythrocyte transfusion has been shown in preterm infants, and the benefit is presumed in massive bleeding due to trauma or surgery. There are also many research reports using big data. This is a representative study that began to point out the problem of blood transfusion. This study is a retrospective survey of a total 227,425 patients. According to this study, postoperative mortality and morbidity in anemia patients is higher than non-anemic patients. An important thing is that the complications were much more in patients who had anemia corrected for blood transfusion. These results were beyond the common idea. There are also studies in the area of orthopedic surgery that mention the negative aspects of blood transfusions. A representative study from this point of view is a paper published by Clinical Orthopedic Related Research in 2008. Prior said patients receiving allogeneic blood transfusions were 2.1 times more likely to have a periprostatic joint infection develop compared with patients receiving no transfusion. This study is very meaningful to orthopedic surgeons due to the fact that postoperative infections would cause a fatal outcome in orthopedic surgery. Especially for oncology surgeons like me, the meaning can be felt serious more and more. This is because adjuvant chemotherapy cannot be successfully achieved in cancer patients after surgery. The problem is that most doctors do not yet properly recognize the problems of blood transfusion. Therefore, we are not paying attention to efforts to minimize blood transfusions. This slide is taken from the lectures of Professor Axel Hoffman. You can find how each doctor takes different stands toward blood transfusions in the same surgery. In the same total hip arthroplasty, 15% of patients underwent transfusion in Center 15, while 85% of patients underwent transfusion in Center 10. Isn't that weird? What is really strange is that most of the physicians don't feel awkward about this situation. Finally, in 2010, the WHO actively urged the use of PBM to minimize blood transfusions, yet there is still a long way to go. I have introduced the PBM since 2013 and applied it to all surgical patients. Briefly, it looks like this. Preoperatively, I tried to achieve target hemoglobin level up to normal range before the surgery by using preoperative infusion of IV iron and erythropoietin. Tranexamic acid was used perioperatively to reduce blood loss, and meticulous hemostasis and surgical techniques were used during operation. In the past, bleeding during surgery was not a major concern because it was only important to finish the surgery quickly. However, the interesting fact is that careful attention to reduce bleeding during surgery does not appear to be an extension of the operation time as I consider. In conclusion, careful surgical procedures to reduce bleeding and operative time were irrelevant. Post-operative plans included restrictive transfusion threshold and careful monitoring of vital signs. Moreover, preoperative embolization can be considered in case of hypervascular tumor. From 2008 and 2012, before the implementation of PBM, there were 10 osteosarcoma patients who underwent either limb salvage operation or amputation, and every one of them received allogeneic blood transfusion. average amount of transfusion during this period of time was 6.8 pints of blood for each patient. There are even 3 patients who have received more than 10 pints of blood transfusions. However, there have been only 0.2 pint transfusions in 7 osteosarcoma patients since 2013. In other words, there was a case of transfusion before the operation at the initial stage of PBM, and there was no transfusion during or after the operation. In fact, at first, I was a bit nervous about the possibility, but in conclusion, it was very encouraging. Let's take a look at a case with a successful patient blood management. 11-year-old male patient without any underlying disease presented with left knee pain that lasted for several months. Initial plan radiogram showed osteolytic lesion at the medial side of right distal femur metaphysis. After osteosarcoma was confirmed from incisional biopsy, we underwent wide excision and tumor prosthesis insertion. The preoperative hemoglobin level was 7.5 gram per deciliter. We applied EPO 10,000 units before operation and high-dose IV iron and tranexamic acid for reducing blood loss. 2 weeks after the operation, we got the hemoglobin level 11.2 gram per deciliter. I used no transfusion. As a result of spreading this effort to the entire field of orthopedics in my hospital, the transfusion rate of orthopedic surgery has decreased from 34.9% to 12.3% in the same period. A dramatic decrease, which was more than 65%, was observed. Thanks to this effort, the average transfusion rate of 46% total surgery has recently decreased to less than 3%. These results are equivalent to 1/10 of the average of large hospitals in Korea. In 1970, there was an Italian mountaineer named Reinhard Messner who first ascended Mount Everest without supplemental oxygen. The common sense was that when climbing Mount Everest, anoxic climber would be killed or suffered from serious after effects, so no one challenged it. But now Everest conquered by anoxic climber. This is the point of PBM when everyone thought blood transfusion was a good treatment. Some prophets thought it might not be, and now we are learning how to minimize blood transfusions. Again, the most important virtue of medical care is the safety of the patient. The paradigm of transfusion therapy has changed. And this is the spirit of the times that our doctors should keep in mind, especially surgeons. I often say, cherish the blood donation and do the blood transfusion carefully. Thank you so much.
Thank you so much, distinguished John Hoon Park, for your wonderful session. At the end of the session, we will discussion. We already have questions, and we will discuss them all together. And now, dear colleagues, I would have to pass floor to Professor Alexei Pyregov. He's the Director of Anesthesiology, Transfusiology, and Reanimatology of Kulakov Center, and he will demonstrate to us anesthesiologist view to PBM.
Distinguished Irina, dear Tatiana, dear colleagues, in fact, if we look through the prism of ICU management to PBM, it's very easy and very difficult at the same time. Because speaking about the anesthesiology support, we always take the preparatory stage to the surgery. We look at the surgical management, that means anesthesia itself and painkilling and post-op management. So I think ICU and anesthesiologists, they are initially PBM specialists, initially by their background, I believe. So as well as PBM is a red thread, is an important line through all the medical specialties, and everybody is involved in PBM, and those who are not yet, they will definitely start doing it right after our Congress today. And definitely anesthesiologists and ICU guys, they are definitely involved. So we already spoke about the most important pillars of PBM. We also mentioned that WHO, many regulators, many countries, they are actively implementing and supporting this concept. And if we speak about three concrete components, this is the optimization of the erythrocytes, minimization of the blood loss, and optimization of the physiological reserves of the patient's organism. So if we speak about the first component, then definitely anemia. Anemia, identification of anemia, and we need to set a question on the elective surgery that should be done properly, on time, postponed possibly if there is anemia, because anemia is a very serious challenge. Here you can appreciate that this triad actually worsening one after the other. So this is triad of independent factors. So that leads to the unfavorable outcomes. So this is initial anemia. This is also blood loss, and definitely this is hemotransfusions, which are indicated or sometimes not indicated, and they're also related to the risks of the secondary bleeds. You can appreciate the situation in the Russian Federation here. So anemia among adult population is about 8.5%. Among reproductive females, it's more than 23%. In pregnant, anemia rate is already 35+%, and last but not least, in postpartum females, that's again 25+. That means every fourth one after delivery does have anemia. So, and this is the number of surgeries. Almost 10 million surgeries, scheduled elective surgeries, which are provided annually in Russia. Here you see the prevalence of anemia in surgical patients. In general surgery, that's about 40%. Then thoracic surgery and non-cardiac, 34%. Then vascular, 33%. Cardiosurgery, 26%. And gynecology, 24%. Well, surely anemia negatively influences the perioperative outcomes. Here you see the 22% increase of hospitalization rate and length, then doubling of infection rate, almost quadruple higher probability of renal failure, 3 times higher probability of mortality, and again 3 times higher probability of hemotransfusions, that by itself sometimes having very severe complications. That is why it is very important to identify and to treat iron-deficient anemia as early as possible, before the surgery. So here you can appreciate the algorithm of the diagnosis and treatment of iron-deficient anemia in surgical patients. Not to lose time, I will try to skip my animation. And here I would like to speak about consensus that in the scheduled surgery less than 6 weeks ahead, so when we have less than 6 weeks before the surgery, we need to administer IV iron because we can very effectively reach particular level of hemoglobin, which is required here. The second component is minimization of the blood loss and the bleeds. Well, the bleed itself is an independent risk factor for the mortality. Here, like ICU specialist, I would like to speak about the selection of anesthesia support. And actually, a week ago, in our institution, we had the presentation of PhD by Dr. Korolev, by my leadership and by leadership of Tatiana Fedorova. And there you can appreciate that we have taken a very serious topic, placenta increta, and anesthesia in placenta increta sometimes creates lots of challenges because placenta increta, placenta previa. So these are really very challenging conditions. So we believe that regional anesthesia in this case can have multiple advantages. First, it allows the patient to be conscious, and this is the birth, that's delivery, that's important. So it improves the connection between the mother and the child. So we can avoid instruments. So for the delivery, and sometimes they're misused in obstetrics versus periregional anesthesia, and also it provides a very good post-op analgesia for the fast-track facilitation. Here you can appreciate that regional anesthesia in our case provided very effective pain killing, then adequate sensory block with a duration of surgery from 18 to 201 minutes. So now hemodynamic parameters shown here on the slide. So we had no problems with renal function, and also we had a dramatic reduction of the blood loss. So you can appreciate 80 patients here. 80 patients here, so from them, in 24 cases, we had more than 20% blood loss, and only 3 of them were switched to general anesthesia. So in case of acute massive blood loss in placenta separation, when there was a manifestation of hemorrhagic shock. This is lactate level. You see lactate higher than 5 millimole per liter actually indicated the massive blood loss and the need to provide hysterectomy. And actually these are the patients who were switched to the general anesthesia. Here you can appreciate our anesthesiology algorithm in such severe patients with placenta previa. Now about coagulation tests. We know that in obstetrics, even in case of massive blood loss, the standard coagulation tests like prothrombin time PT or activated partial thromboplastin time APTT, so even with a blood loss of 4,000 milliliters may not be changed. It's totally opposite. The fibrinogen, which is normal 1.5 gram per liter in surgery, depending on the indication. Well, in this case, fibrinogen of 2 gram per milliliter and lower is a marker of a massive blood loss and the need of surgical intervention. So the recommendation to use fixed ratio of components were definitely extrapolated from the battlefield surgery and trauma surgery, but actually the evidence-based data for obstetrical bleeds have not yet been accumulated. So that's very good work published in Anesthesia 2019, where they compared 4 years' experience of a rod-term guided algorithm for the treatment of coagulopathy in obstetric hemorrhages. And here you see that standard practice used to be shock back at the beginning of the massive obstetricial blood loss, and definitely the volume of components was dramatically reduced and also improved of the maternal outcomes versus the standard outcomes. Moreover, only 3 obstetrical societies actually mentioning protocol of massive transfusion with the limited information about the advantages of implementation into the obstetrics. So, and experts of hemostasis recently doubt whether it's applicable to use fixed transfusions from non-obstetrical indications. Also, if we speak about obstetricians, is plasma always useful? We know that it's a term pregnancy. So fibrinogen level would be 4, 6 or higher gram per liter. And our donors have the level of fibrinogen in plasma about 2 gram per liter. So, and actually the mathematical modeling has been carried out. Simulation showed that the transfusion of big volumes, for example, in DIC syndrome, we recommend 20, 30 milliliters per kilo. So it can potentially lead to coagulopathy. As a result, definitely you see that in our country, also in North America, in Australia, in the UK, so the drug of choice here is cryoprecipitate. But some countries also refuse from that because it comes from many donors, and we see again the risks, the additional risks here, and also uncontrollable effect of that. So because fibrinogen concentration cannot be varied from 2 to 30 milligram per liter. But the studies between the fibrinogen concentrate and cryoprecipitate have not been carried out in obstetrics. So very simple techniques. I wouldn't say that they're even anesthesiological. So this is systemic influence to hemostasis. So like overcooling or overheating of the patient, so warming of the patient, then correct positioning. And you see that unintentional cooling reduces platelet function, leads to the discoagulation, increased blood loss related to the rate of infectioning. So any methods of warming would be definitely welcomed in PBM. They would give us very positive outcomes. And there is a consensus that the particular components we need to replace to the blood concentrates and blood factors. Blood tranexamic acid, also in obstetrics, it's a woman study. That's publication of 2017, where we put all dots over the I's with a high level of evidence-based data. This is activated factor 7, which is off-label, but actually it is in our guidelines. We wanted to protect both patients and the doctors, and definitely prothrombin complex concentrate. So please don't forget that the use of all these drugs and in terms of thrombogenicity, thrombodanger, so the highest risk is fresh frozen plasma, FFP, so the use of all of them requires particular hemostatic control and also the administration of mechanical and medical thrombus prevention. And last but not least, this is the optimization of physiological resources of the organism. So if you speak about the acute blood loss, then definitely it is the hypovolemic shock. That's replenishment, hemorrhagic hypovolemic shock. So drug of choice here are crystalloids. So here are all the crystalloids which are currently available, but everything should be done properly. And actually many studies were carried out showing that the transfusion of big volumes again leads to the coagulopathy, dilution, and hyperhydration, increasing the risks of lung injuries. So what we need to do is to use colloids properly on time. Also everything which is registered, this is whatever you say about the starch, but still 6%, 130,000 Dalton, it's a good indication for hemorrhagic shock. Transfusion no more than 500 milliliters. Also gelatins and possibly best of the best colloids, which is actually limited because of its price. This is albumin. Vasopressor support, because we used to say that it should be as late as possible, because first we need to replenish the volume, and now we need to do it as early as possible due to the concept of phases in shock due to the high risk of hyperhydration. Then early vasopressor support, and the drug of choice here is norepinephrine. And actually erythrocytes, transfusion is not eradicated the reason of anemia and associated with particular risks. So there is no link with improved of delivery and oxygen consumption. So that's negative influence to the outcomes of treatment, more frequent infections in the post-op period. So there is higher rate of ischemic complications and prolongation of hospitalization. That is why even in the post-op periods, also IV iron represents much safer, more sustainable, and more economical alternative, best alternative of transfusion, specifically in hemodynamically stable patients. Thank you very much for your brilliant presentation. We will have questions at the end. And now let me give the floor to the next speaker. This is Professor Luca Veltert, who is our distinguished speaker from Italy. And we go to PBM in cardiosurgery. So he's the lead of statistics of the International University Camillus, which is in Rome. He's cardiosurgeon of the European Clinic in Rome. The floor is yours. You're welcome.
My name is Luca Paolo Velter. I'm a heart surgeon working in Italy and a so-called expert in blood management here in Italy, and as well a professor of statistics at the San Camillus International University. I'm deeply regretting not to be physically together with all of you. Here is where I'm recording this presentation, the European Hospital in Rome, and that's me sitting at my desk. I'm looking forward to times when we can finally be together again to share knowledge and experiences. Now, the topic I have been given, cardiac surgery and PBM, made me arise a question. These two topics seems to be natural-born enemies, and this is due to the fact that cardiac surgery is intrinsically connected with the hemorrhagic component, and as well it has to deal with extracorporeal circulation dilution, which kinds of kill all the efforts to spare blood. You know, extracorporeal circulation means complete heparinization and afterwards complete antagonization with protamine. It means activation of pro-inflammatory cytokines and complement and mechanical disruption of figured elements of blood. As well, all the structures in cardiac surgery carry some degree of bleeding risk. We have internal sutures like valves and rings that have actually no impact of bleeding risk because they are into the bloodstream. But then we have external sutures like vascular grafts, bypass, aortotomies, arteriotomies, ventriculotomies, which carry significant bleeding risk. And then again, we have cruentation surfaces like tissues divided to access the site of operation, which carry moderate bleeding risk. One other topic that is crucial is that while in the past we used to do many first-timers in heart surgeries, and this usually means no adherences, these patients are less prone to bleed. Nowadays we do many redo, which requires lesions of adherences and usually carries added risk. Now, put on top of that the fact that as an historical perspective, the heart surgeon is an ignorant person in terms of blood management, which reduces everything to the bathtub paradigm. If the patient gets empty by bleeding, just fill it up. And it relies on the silver bullet theorem. We have allogeneic blood, which is the silver bullet to treat every kind of bleeding problem. Now, in recent times, we understood that giving a transfusion is more like making an organ transplant than to give a pill. And the safety zone concept was introduced by Lohr, Koch, and Blackstone from the Cleveland Clinic, which basically means we have to have our patients stay in the yellow box over there, balancing anemia risk and transfusion risk. Now, this led me personally to explore everything I could do to stay in the yellow box. And this short presentation of ours is not gonna be a state of the art of everything that can be done in heart surgery nowadays. It's more a personal tale of what I do at my center and what I've been doing and researching the failures and successes in order to make a sort of bloodless cardiac surgery. Now, let's start. We have 3 chapters. Now, chapter 1. I use the sport metaphors to make it easier to follow. Starting in pole position is always crucial. Now, every procedure, in my opinion, is potentially doable bloodless as long as the available red blood cell mass can withstand a reasonable dilution and moderate inevitable loss. Now, what pole position means in terms of blood content for heart surgery? Well, there is no actually defined guideline, but the higher the better. If possible, we have to aim at 14 grams per deciliter and over. And what are the two ingredients to an efficient red blood cell factor? We all know that from the school time. It's iron bioavailability and it's erythropoietin pushing the synthesis in the bone marrow. Now, as regarding iron, we have a couple of topics, what to do and our timing problems. We know that red blood cell production does not happen instantly, so building blocks have to be available early. Our gold standard nowadays is intravenous iron, but unfortunately this kind of therapy is logistically complex. Our possible best approximation is suprasomal iron. And this is my opinion. I believe it so much that I designed a randomized study on suprasomal iron supplementation before our surgery, recorded it at the clinicaltrial.gov, randomized 1,000 consecutive participants to either administration of 2 pills per day or just control, and then check the preoperative hemoglobin level and compliance to the drug, of course, which is a problem with per os iron and cost effectiveness. This is the flow chart of the study starting in 2018 and ended on March 2020. This is the actual date of the study, but let's focus just on the key findings. This is how hemoglobin on the day of hospitalization turned out to be. So almost 14 in the suprasomal iron population and 13.2 in the control population. And this, of course, had its background on the iron contact, and you see here the data on the graphic. And this caused, in turn, no truly difference in relative terms as regarding hemoglobin drift after operation, but of course, starting higher, we had a big difference in terms of absolute terms, and this turned into this result. The average blood transfusion was halved, basically, and this remains true if we consider the average number of transfused blood units or the proportion of transfused patients, as you see here. On the other hand, we have an exceptional treatment of this, tolerability of this treatment. You see just 1% of the patients discontinued the treatment. And as well, in terms of cost, we had an extreme efficacy. Saving 1 blood unit means around 200 euros, while 2 cups per day, per third per day is just 66 euros. So you see, it's simple math, it's convenient. Now, on the other hand, we have the other leverage, the other two, which is human recombinant erythropoietin, and its component that is known to everyone in sport world due to the 7 wins of Lance Armstrong at the Tour de France, which was then revoked due to doping charges, exactly focused on this molecule. Now, he still is a great champion, but this is just to show that it's really something that's working. And to ascertain this, in the first decade of the next millennium, I designed another randomized study. This one, which I presented in Boston in 2009, that later became the one of the references of the joint guidelines on blood conservation practical protocols, and was held like that. I designed 320 patients to be randomized at either EPO or control, and they turned out to have 15.5% more hemoglobin on day 4 in the treatment population, with the sparing of half blood unit. However, the original protocol was still sort of complex. You see here the administration was fractionated over many days, and basically it required coordinated effort and may have relevant dropout, so it could have weak spots. This is why we updated it in 2011 with another protocol, 80,000 units of EPO 2 days before surgery, single administrations. And this is the study we presented, 300 patients against 300 patients, so 600 patients, and then compared in terms of unit transfusion and hemoglobin, and evaluated in terms of safety as regarding mortality and non-plasma events. So we had these results in terms of blood overall consumption, which were massive actually. Minus 65%, and of course, mean hemoglobin level was the same, and at no added cost in terms of risk. Now, let's jump up due to time reasons to chapter 2. Prevention is better than cure. We have to do all efforts to avoid blood loss, and we cannot expect others to solve our intraoperative hiccups in ICU. So the surgeon role in hemostasis is usually divided into two areas: prevention of bleeding and treatment of bleeding. Prevention of bleeding, as important as it is, because it's the very moment in which endothelial exposure starts, platelet triggering starts, and all of this stuff. It's something that can be done. It's taught in the school when you are starting to be a surgeon, but it's not very well explored. And if you make a search now in literature, you will find absolutely no published papers on this. There's maybe some room in the future for improvement, but there is a lot of research instead as regarding hemostatics. But even after all this time, it remains true what was stated by Ferraris in the blood conservation revision of 2011. It is still a class 2B indication, level of evidence C, which means it is not unreasonable to perform these procedures. So why it is so complex? Why our results are so poor? Well, maybe it's because it's a very complex structure. We studied it, coagulation, to be something like this, but nowadays we know that something more closely related to this, and maybe it is not even enough. And on top of this, now we know that it's a sort of a wedding between two procedures, the coagulation and the aggregation, which is intrinsically complex even itself. Now, treatment of bleeding implies a correct definition of the bleeding type. Is it oozing, low? Is it moderate bleeding? Is it high flow bleeding? And then the surface, is it flat parenchymatous? Is it convolute? Is it fat? Is it vessel? What is bleeding actually? And what's the origin? Is it microvascular? Is it venous? Is it arterial? Now, by making a proper classification at the OR table, the situations can be explored properly. In 2017, an international coordinated effort was done to obtain a bleeding scale, so to give a definition to a proper situation in order to make an informed decision, but this is still a work in progress. I just want to focus on this milestone paper of 2017 published on the Annals of Thoracic Surgery, which gave us this schematic, which is everything we need to know nowadays to understand what's available and what to use in what condition. Now, you see these two circles with some overlappings. We distinguish mechanical and hemostatic agents like oxidized cellulose, like collagen, and like polysaccharide spheres, which act like the name implies, by pushing against the bleeding source. On the other hand, we have synthetic sealants, either cyanoacrylate or bovine serum albumin with glutaraldate or polyethylene glycol. These are not hemostatics. They cannot be used to stop bleeding, because it can be used to prevent bleeding at the end of transfusions. Now, sometimes these two techniques can be combined, such as in hemopatch, which is a patch that uses both a collagen layer and polyethylene glycol, and that grants beautiful results. We'll have a closer look after. Then we have active hemostatic agents. We have a thrombine in its various forms. We have patches with the fibrin sealants, which are sort of an overlap between the categories. And we have a sprayable fibrin sealants. But last but not least, we have flowable matrix hemostatic agents, and I left those for last because they are really the gold standard. Nowadays, we have two products, Surgiflow and Flucy. Now, this short view gives you every tool that you need to treat what you have. It's, however, by the combination of fully seeing what kind of bleeding it is and knowing what's available that you will earn success. Now I want to share some personal experience. We do a lot of aorta surgery, and you see here our hemopatch with polyethylene glycol can be used to stop all that oozing from the last part of the process. And you see here instead a massive bleeding from the coronary sinus that was disrupted, and that is treated by just a position of a hemopatch. 2 minutes, pushing gently, and this is the result, totally solved the problem that could be life-threatening, and that led us to publish this on the Journal of Thoracic Cardiovascular Surgery. And as regarding specific hemopatch, we done a study comparing in a randomized patient the active bleeding control of these results, finding that 97.5 bleeding sources was controlled by hemopatch against 67% of sources that were controlled by just pushing against it. Of course, this has no direct impact on blood loss nor on blood transfusion. And we have always to remember that we cannot hope that we are transfusing because we are letting the patient actively bleeding, because the results will not be transfusion, would be death. Now, you see here what in terms of randomized study, where there you see the numbers are small, the results, however, are substantially the same, with implying an active hemostatic. Even when you use it properly, you will gain 1/3 of possibility of controlling your site. And let's rush up to chapter 3. We have just a few minutes. Not all is lost, and I'm referring to the 2013 America's Cup, when Emirates Team New Zealand was winning 8-1, just 1 point more to gain the cup, and instead Oracle made the remontada 9-8. Now, this means in our terms that even if we are losing, if we performed a not optimal hemostasis, we can still recuperate both intraoperatively and post-operatively with a closed chest self-saver. We planned that with a massive study of 1,000 patients. And the first thing we asked ourselves, which is a common objection to this kind of treatment, is this blood safe? And you see here we compare this in terms of IL-4, IL-6, tumor necrosis factor, and whatever. And yes, the blood, in simple words, is safe. It is worthwhile. Well, sort of. You see, you have a minus 40% allogeneic blood transfusion reduction if you use this kind of technique. So, to sum it up, this is our bring home message. Patient blood medicine is a clinical concept that goes to improve patient safety, that has 3 moments: comprehensive anemia management, minimization of iatrogenic unnecessary blood loss, and rational management of hemotherapy. It can be dealt up with many tools, but it's always to be remembered that it's a multimodal teamwork which will at last end in allogeneic blood independence. Thank you for your attention.
Thank you very much, dear Luca. And now, distinguished colleagues, beside online question, we would appreciate questions from the hall. So you are welcome. You can provide them here into Presidium. So very soon we are expecting discussion time. And now I'm happy to give the floor for the next presentation to Professor Bruce Spiess from United States, who represents the University of Florida Medical College Gainesville, United States of America, Virginia, Richmond. The floor is yours. You're welcome. PBM in critical conditions. Bruce, the floor is yours.
My name is Bruce Spiess, and it's a great pleasure to be here with you in Moscow. Here in Moscow, I'm recording this from University of Florida in the United States. But I've been asked this morning to talk with you about patient blood management in the intensive care unit. I'm not an intensivist, but I do cardiothoracic anesthesiology. I've been heavily involved in patient blood management worldwide for about 30 plus years. But as a cardiovascular anesthesiologist, I have the occasion to drop my patients off in the ICU, pick my patients up in the ICU, and I have tremendous interactions with our ICU or critical care doctors. So I feel a part of the struggle you all face every day. It is unfortunate that very often the critical care unit is the one place that is forgotten and is not brought into the fold of the PBM program as much as the decision whether or not to transfuse has really expanded in the last 10 or 15 years. And there is no doubt that there's a massive literature today in support of less is more. In other words, keeping your own blood, keeping patients from hitting those triggers that make physicians give allogeneic blood makes a tremendous difference in outcome. And as far as I'm concerned, it's a cause and effect. So the Bradford Hill criteria that were originally written as the actual criteria to prove cause and effect in medicine are something we ought to fall back on. I would point out to you that many of the detractors from patient blood management say that there are no randomized controlled trials proven and showing that blood is bad and that PBM is the way to go. But I'll also point out to you that 85% of randomized controlled trials can never be repeated and get the same outcome twice. So are they really truly cause and effect, or do we need to even go back and understand what those trials tell us? But there is a great deal, a huge amount of level 2 evidence, and level 2 evidence with enough of it can mean the truth and can mean that there is cause and effect and there is relationship. The standard one that always gets brought up is, have we ever had a randomized controlled trial to say smoking causes cancer and emphysema? It's never been tested by randomized controlled trial, but of course every one of us accepts the associations that are out there. And the one I particularly love is there's never been a randomized controlled trial of whether parachutes save lives when you jump out of a plane. Okay, so what about doing patient blood management and reducing the use of allogeneic cells? As far as I'm concerned, the conclusions are obvious. The data is massive, and allogeneic blood transfusion causes increased length of stay, particularly in the ICU and in the hospital. Increased length of stay in an ICU causes other chances for secondary, both human error, hospital-acquired infections, pneumonias, on and on and on. And there's a real relationship with increased mortality. Increased infection rate, as I told you. I'm convinced that allogeneic blood causes immunosuppression that can actually lead to cancer in the future, but it can also increase the chance of metastases. But the big one is TRALI, transfusion-related acute lung injury. And of course, that affects how long patients stay in the ICU. The worse their lung dysfunction, the more likely they are to stay in the ICU. Renal failure is the bane of anybody's existence in the ICU, and allogeneic blood, through a host of mechanisms, increases the chance of renal failure, renal dysfunction in the ICU, and same also with MI. So the data are out there. This is one of a very recent paper on a meta-analysis, 253,779 surgical patients, about equally split between the pre-PBM group and a PBM group, and look at the outcome differences. There is no doubt about it that those patients who undergo PBM do better, and they do better in the ICU, absolutely. And then there's from cardiac surgery, and this is a bit of academic doublespeak for you, but those patients who get 1 or 2 units of blood have a 16% increased incidence of mortality. They say decreased survival. They should have just said death. But I don't know what else in cardiac surgery, cardiac ICUs, et cetera, is associated with a 16% increase in death rate. That's the biggest effect upon death rate in any therapeutic intervention in heart surgery. So reducing use of blood, particularly in the ICU, will help your patients have a better outcome. And anemia is bad, we know that, but transfusion is actually worse. And so we need to keep people from getting anemic. We need to keep them from getting to those points at which a human physician pulls the trigger to order the unit of blood. And that's the key, because unfortunately today we still have the major trigger for transfusion is a laboratory value, not a really well understood oxygen supply demand ratio. And I said that I'm convinced, as is Neil Blumberg and many other people around the world, that allogeneic blood is by itself undoubtedly immunomodulating, and it downregulates the immune system's ability to fight infection, and it allows for a dramatically increased risk of perioperative infection and hospital-acquired infection. So the three pillars, or as I say, the four pillars of patient blood management involve optimizing red cell mass, treating anemia up front, minimizing blood loss during procedures, particularly surgical procedures, and harnessing and optimizing the physiologic reserve of anemia, and that means into the ICU. It also means that we ought to prevent patients from becoming anemic in the ICU, and that is vitally important. The last one is bloodless medicine or Jehovah's Witness care. We have had a number of patients here at our institution who simply can't take blood because they have HLA antibodies and such that they simply can't get a unit of blood. So those kinds of techniques all pull together to be what is a patient blood management program. But the one thing that often gets focused on is either minimizing blood loss and bleeding in surgery, or an anemia clinic, without bringing the critical care physicians into the fold and participating. And it's extremely frustrating if you've done the first two parts, but you haven't managed to have your critical care team involved with you and with a shared mental model that everybody understands and works together as a team across the entire university or across the entire hospital system to make sure that the patient gets the same output and outcome. This slide's by Axel Hoffman. I have to thank him for that. It's a wonderful slide. And if you look at 100 surgical patients, there are a number that are anemic on admission, probably about 37 or 40%. In my heart surgery practice here in Florida, we see upwards of that. We see 60 to 70% are anemic. So we don't have routine detection or correction, but so many are made anemic during their admission, probably another 20 or 30% we make anemic during admission, and eventually 57 to 60% become anemic during their entire hospital stay. And I'll put it to you that the majority of patients in the ICU either enter the ICU anemic or are made anemic because of our care there. And so it becomes a stimulus for physicians to go ahead and treat that anemia. And they treat it with the one thing they know how to do, which is to trigger a blood transfusion. And unfortunately, the most vulnerable get the transfused the most. In other words, those patients in the ICU are the most vulnerable to all the bad outcomes I just talked about. Cardiac disease, vascular disease, hypertension, pre-existing diseases, and immune compromisation are all things that are standard for most patients in the ICU. And surgical patients are diffusely inflamed, and that's that's just part of having major surgery. And in medical ICUs, you know, they're in there for other reasons. And very often it's ARDS or pneumonia or renal failure already. So you can see that they're already in a big problem. I think most physicians don't really truly understand critical oxygen delivery and about its complexity and how oxygen is extracted from hemoglobin, how dissolved oxygen works. And that's not the point of this lecture. But I think most physicians still today, unfortunately, trigger transfusions based upon their anemic level that they get from a laboratory value. So 60 to 70% of red cell mass lost in the ICU is iatrogenic. In other words, we know well that patients enter the ICU and they lose blood, and they lose 100 to 300 to 500 cc's a day, depending on blood draws, the kinds of blood draws that are performed, and how much wastage and how fastidious the ICU team is to not losing a single red cell. And you have to ask the question is, are every one of those lab values necessary to make a full and proper decision for that patient, moving them forward? And this is not new. As a matter of fact, back in the mid 1980s, I found one paper in the 1970s that talked about reducing blood loss from diagnostic laboratory tests in ICU patients. But it's only now in the last few years that people have begun to adopt it. And so I think we are beginning to understand how to make this be accepted across many, many different ICUs. I highly recommend you read this paper by Donat Spahn and Carlos Marcucci. It goes into great depths about all the various different things that can be done in the ICU. It's 4,900 patients, and they've found that the average transfusion trigger was 8.5 grams per deciliter. Now that, to me, is a group of physicians in ICUs have decided this is where we will transfuse our patients. But DO2 crit, or the critical level at which patients shift from aerobic to anaerobic metabolism, is so much lower than that. And there's no data to suggest that 8.5 grams per deciliter or 7 or 9 or 10 or even 6 is the right number for everybody. And so it's a surrogate marker that really doesn't tell us what we need to do. It seems that we need individualized oxygen supply demand understanding, education, and our ICUs to really pick up the scientific understanding of what they're trying to do. Unfortunately and systemically, most junior residents or housemen, as they're called in Europe, I don't know what you call them in Russia, are the ones who actually orders blood based on the lab values. So I don't think we're there yet for people to really understand what they do. So here's another great one from fairly recently, I guess it's now 15, 18 years old, by Fowler et al. It says they've been identified, these things to do have been very well identified, but they've not been adopted. So if in 35 or 40 years we've identified these things, but we're not changing, it really fits Einstein's definition of idiocy, which is to do the same thing over and over again and expect something different. So in ICUs, we need to educate and include the ICU critical care doctors in the shared mental model right from the very beginning. When you outline a patient blood management program, the ICU leadership must be at the table with the rest of the team. And the ICU can destroy your best PBM program if they're not there and if they haven't coordinated themselves with the entire staff. I tell you that new technologies are emerging and they can be applied to the ICU. These include coagulation enhancing drugs, but they also include these last two items, which I call point of care coagulation analyzers, the Quantra, and a new filtration device to be able to salvage blood if patients are actively bleeding in your ICU. I'll just point this one out to you. because it truly is point of care. It can be right next to the patient, and in 12 minutes, it can give you a tremendous amount of data about the coagulation of your patient. And if your patient in the ICU is bleeding, threatening to bleed, et cetera, deciding what to give them, deciding when to intervene can be driven by this technology. And we're just now publishing an algorithm to be able to drive that for you. It hasn't been widely accepted yet in ICUs. It's just been approved by the European Union about 1.5 years, 2 years ago, and in the United States about 1 year ago. But there's a lot of literature coming out about how important patient blood management is, transfusion and outcome. And so harvesting the patient's own blood makes a huge difference. And certainly for patients who have drains, we've done this just recently with chest tube drains in our cardiac ICU, that we can take the drainage blood, pass it through this low-tech, low-cost filter and be more efficient. I'll say that again, it's more efficient than is a fancy self-saver at hundreds of US dollars, and it gives you a great product back, which is packed red blood cells back to the patient that are clean, sterile, and free of a lot of inflammatory mediators. So PBM is a long haul, a long push, but the ICU has to be involved right from the very beginning. Its job is never done. And I hope that we have time at the end of this session for me to take your questions if I can. And these are the issues that need to be dealt with and wrestled with in critical care medicine. I thank you for your attention and look forward to the question and answer section. Thank you.
Спасибо, Брюс. И позвольте для следующего.
Thank you very much, Bruce. And as we're a little bit behind the schedule, now let me give the floor to Professor Mikhail Rybka, who is the Vice Director of the National Medical Research Center of Cardiovascular Surgery, named after Bakulev, Doctor of Medical Science, Professor. And actually, he will present the position from Russia about PBM, cardiosurgery, what is available in Russia. Dear colleagues, dear friends, distinguished chairs, well, PBM in cardiosurgery, what about Russia? What can we say? So in Russian cardiosurgery, we see very active development, especially in the recent decades. I mean, the increased volumes of care. So cardiosurgery is evolutionizing. And about 5 years ago, it reached 50,000 surgeries, open heart, annually. But nevertheless, we see that there is at least a triple potential of growth of surgery rates. If we look at the figures that is given by the healthcare Western countries, Europe and US. So in Russia, there are about 100 clinics working with open heart, open surgeries, and 16 of them are quite large. And more than 1,000 PBC are performed, CPB, cardiopulmonary bypass, CPB. That means open heart and CPB. So, but in my presentation, very briefly, I will not, let's say, comment on the English language publication, but I would like to be focused on particular important challenging issues that we need to resolve developing PBM. So the first pillar here, so this is correction pre-op anemia, pre-op iron deficiency. So that's a challenge. That's a challenge very well known. And as an example, I will give you the data of RECORD study, which was carried about 10 years ago. So here you see patients with acute coronary syndrome, where it was clearly shown that patients with anemia, they do have high chances for the unfavorable outcomes versus patients who are administered with normal level of hemoglobin. Also, there is another study, specifically from Pirogov Surgical Center, where the investigators looked at the influence of pre-op anemia and also the hemotransfusion rate and the influence to post-op outcomes in cardiosurgical cohorts. So all these studies were massively intensified for the last few years due to the active implementation of PBM practice. And we published 2 major articles. Again, I'm not going to refer to that because I'm just announcing it, because we will discuss it tomorrow at our session. So one publication is the analysis of pre-op anemia to the hemotransfusion rate, how it influences during the surgery, and what is most important, post-op anemia. So how baseline anemia influences the transfusion rate, influences post-op anemia and the dynamics of patients. And the second publication is the cost analysis, healthcare expenditures analysis, where potentially we proved huge option to save money and save lives if we implement PBM principles in the practice of coronary surgery in our country. But here we can face a challenge. So there is a particular challenge that requires particular solution. The point is the surgical and cardiosurgical care is reimbursed from so-called high-tech medical interventions. So that's a reimbursement channel, high-tech medical interventions. And this possible treatment of anemia or iron deficiency, which should be carried before that, should be done locally, few days before the surgery, preferably a few weeks before the surgery. And these are not simply different doctors. So this is also different money, different reimbursement channel. And actually, it appeared to be not easy to, very easy to implement in Switzerland. So here it's the same scale map. Here on the left you see the Switzerland and Liechtenstein, and here on the right you can see Russia. So you see Liechtenstein, very good network of roads and very close cities and towns, and then central part of Russia. You can appreciate the situation looks completely different. Population density is much lower, and there are quite reasonable questions popping up. Who will see the patient 2 weeks before the hospitalization? Who will make the diagnosis of iron-deficient anemia? Who will provide treatment? Who will pay for that? That's the most important. And the most important is who is interested in that. Because if a local outpatient doctor or cardiologist who is referring patients to the regional or federal cardiosurgical center identifies that his or her hemoglobin, let's say 117 gram per liter, then how? Based on what? What documents he or she should administer him or her infusion for pre-op preparation, or quite expensive tests that would identify iron deficiency status. And here we actually speak about the western part of the country, where half of the population is inhabiting. But if you look at the same map of Siberia on the right, this is Siberia. Or Far East, look at that. Switzerland on the left, Liechtenstein and Switzerland on the left, and Far East on the right. Oh God, the problem is much severe there. And the second pillar of component of PBM, that's minimization of the surgical risks. That means our surgical skills. And this is possibly most well-developed and most well-known for cardioanesthesiologists, for cardiosurgeons components that actually we were all focused on for years and decades. This is auto-donation and also managed hemodilution and thrombocytopheresis, cell saver, very active use of cell saver, then point-of-care diagnosis, checking of complement and cascade, so TAG, ROTEM, very actively implemented. Factor-based correction of hemostatic dysfunction, active use of recombinant factor 7A, prothrombin complex concentrate, pre-op precipitate. The use of different technologies, local hemostatic technologies, and bioglues that were very nicely covered and presented by the previous speaker. So all that, no doubt, is available in our practice. But what's the interesting illustration here? I appreciated the data of library.ru, which is electronic Russian scientific library, where we register all available publications made in Russia about the number of publications and the names of the leading surgeons here and anesthetists. in those 16 clinics that are carrying out more than 1,000 surgeries a year. This is annualized surgery rates. And you see publication activity is seen in 1/3 of clinics. In the rest, this work is definitely carried out. Principles are used, but most probably they are not the focus of research potential. And I would like to ask a colleague of mine, if I missed something, please, no offense meant. So this is just one database, elibrary.ru, and this is more or less screening search.
And I cannot but add something bad to this beautiful picture. In order to implement the second component, we need point-of-care diagnostics on modern ROTEMs. They have not been registered yet. We need fibrinogen that is not produced and that is not registered. As for precipitate, starting from 2000, you can see the dynamic on the chart, and it's quite obvious. The third component is also very clear for all cardio-anesthesiologists. In routine, we work with postoperative heart failure and optimizing the oxygen transport to the tissues of our patients. We can unload partially this cart using vasodilators. We can heat the horse with catecholamine. We can give some oat to our horse using phosphocreatine. But it will be the same horse. We can heat it, we can feed it, but after operating, she is not driving well. So, talking about specific and cardiosurgery thing is developing of supplementary blood systems. But we are only in the very beginning of this way. And to conclude, to answer the standard Russian question, who is guilty and what to do? In the first component, as the first component of PBM, we need to develop inter-level cooperation in our healthcare system so that municipal system has contact with regional system and they have federal contacts. We need regional programs for regional healthcare institutes because it is there we will have to have the main efforts to determine, to define iron deficiency, and we need also to create rules that would make interested both bureaucracy and physicians to deal with this issue, to look for patients with iron deficiency and prepare them for big surgery interventions. I think that big Russian register could help us with that. It could be a very good tool for analysis and clear understanding of the situation. Russia is a huge country, and different regions live in different climate zones. They have different climate situation, and iron deficiency situation can differ significantly. For full implementation of the second component, we need point-of-care diagnostic of hemostasis system, and so that we can understand where is the problem with one touch. Such instruments exist, and by no means we need to implement them. And I have to mention that fibrinogen is a must. The only molecule for hemostasis that is present in grams per liter and defines the creation of thrombus. And ventricular devices, small for short-term usage after surgery is also a huge need in cardiosurgery. That's all from my side. Thank you for your kind attention. Thank you. Thank you. Please take the seat at the panel, and I hope our international colleagues online with us. Now we have possibility to have very short discussion to answer questions that we have. And let me ask the first question to Professor Bruce Spies from the United States. It is a question asked by Victor Sturov. It is well known that allogeneic thrombocytes, allogeneic platelets, disturb the functionality of platelets. How to prevent post-transfusional thrombocytopathy and disaggregation of a platelet recipient? Bruce, are you with us? Is Bruce online? Are you with us, Bruce? It seems to us that Bruce is not here, Axel. Are you with us? Do you hear us well? Axel, do you hear us well?
What I can do, I can try to, there's a few technical issues here. We also have very poor resolution of the slides. The graphics are very bad. And sometimes we're breaking up. So I'm very sorry, but probably you discuss for now within your the panel of your Russian colleagues and experts.
Спасибо.
Well, thank you. Well, then we will ask ourselves, allogenic platelets disturb allogenic thrombocytes, how to prevent post-transfusion thrombocytopathy and disaggregation of platelets. Who can answer? Oh, we have an answer in the audience. Good morning, dear colleagues. Don't transfuse platelets. Very simple. Very well, I can give the same answer. That's the true. That's the true. The transfusion. If we analyze all the situations with platelet transfusion, unfortunately, only 10 to 15% are really justified. And of course, to transfuse platelet, there are very clear indications. Thrombocytopenia lower than 50,000 with continuing excessive bleeding. These are different hematologic diseases, but it is very often in obstetrics, you know it well. When we consult Russian Federation of Obstetrics, we see that even when it is HELP syndrome, when the platelet transfusion is contraindicated, the platelets are transfused. So the way to prevent the complications of platelet transfusion is limitation of its usage of modern filters, leukocyte filters for platelet transfusion, and of course, high-quality components production. And the Russian Federation can be proud of good quality of components. This is my opinion. Thank you. My opinion is the same. Platelet transfusion should be done only when we have a very clear indication. If it is autoimmune thrombocytopenia, we do not need any transfusion. And if there are complications, if there is disaggregation, we should control hemostasis that was mentioned by the last speaker, point of care, and it should be performed on rotem. and we can see what is the function of the platelet and what is the input of the platelets into hemostasis. So if we follow very strict indication, if we control hemostasis, we will not have any complications. As simple as that. We have one more question. Is there standard for platelet safety for parenteral iron drugs together with erythropoietin? Do we need anticoagulation? Well, there are no such standards, but anticoagulation should be performed according to the clinical guidelines. If you have risk factors, then we perform it. If we do not have risk factors, we do not perform it. The situation now is that it is organized for all the patients that are in the inpatient. The prevention can be different. Probably Irina Vladimirovna can say a few words about standards when we use parenteral iron medications. Well, there is nothing more to add because there is no standards existing now. And we understand now clearly that if we talk about our actions in Russia, we can rely only on the clinical guidelines. What is in the clinical guidelines is really valid. It's well thought through. So we just need to implement the clinical guidelines. They are absolutely adequate. Thank you. And we have more questions. The last question, because we have eaten half of our break. Mr. Kazirev asks question. Are there orders made or standards implemented on the legislation level? As for orders, the last order 798, it includes the principles of PBN, and the working group includes many members of our association. We made big input into the blood components transfusion in neonatal, obstetrics and gynecology, in cardiosurgery, and I think this order already contains PBM principles. As for standards, on the legislation level, we use only the clinical guidelines, including the guidelines on anemia and bleeding treatment, prepartum and postpartum, iron deficiency anemia treatment. These clinical recommendations are approved, and they are approved by our government. If we talk about clinical recommendations, clinical guidelines include also the recommendations for treatment. Yes, it is the same algorithm that works at the same way. We have the clinical guidelines, and we had anemia in oncological patients. They were approved in December of the previous year. They require additional working through, and half of the year we have to file the edited guidelines, and we are working on that. We will have soon very good clinical guidelines for anemia treating with all the aspects of oncological patients. Thank you, dear colleagues. We have lots and lots of questions, but I would ask the questions address particularly to the sessions that we have tomorrow. There are questions about cardiosurgery, cardioanesthesiology, questions about obstetrics, questions about gastroenterology, about critical state. Please, for the next discussion, don't forget. Now we cannot continue. Thank you, and we have 5 minutes break. 5 minutes break. Thank you to everybody. About PBM in clinical practice. And the first presentation would be done by Roman Shmakov of PBM in obstetrics and gynecology. Good afternoon, dear colleagues. PBM in medicine is a very important issue and of paramount importance in obstetrics because bleeding is one of the main reasons of maternity mortality. And PBM, preoperative PBM, prepartum PBM, and obstetrics, bleeding is a very important task for all professional society in obstetrics. You can see that 50% of all maternity death in 6 countries, India, Nigeria, Pakistan, Afghanistan, Ethiopia, and Congo. And the main cause is obstetric bleeding. And you can see here a good trend that maternity death decreases twofold in last 30 years, from 1990 to 2015. In Africa and Asia, it decreases. And this is also an important task for the Russian Federation, to decrease maternity death. And you see the same map, you see the same trends. And where do we often see anemia? These are countries where we have the highest maternity mortality. In the Russian Federation, each 5th woman during her pregnancy suffers from anemia. The main causes for maternity death in the developing countries is obstetrics bleeding. It is the leading cause of maternity death compared to developed countries, where the maternity bleeding is on the 2nd place as the death cause. And there are different causes, such as extragenital pathologies and embolic complications. In the Russian Federation, clinical guidelines for postpartum bleeding were prepared. The Russian Society of Obstetrics and Gynecologists and Russian Association of Anesthesiologists and National Association of PBM participated in the preparation of these clinical guidelines. Here, we checked a lot. And we changed a lot. We changed the transfusional tactics, pre-operative preparation, pre-partum preparation of our patients. It is very important, and I hope that these clinical recommendations will be an important pathway, important algorithm for many experts, mainly, of course, for obstetricians and gynecologists. If we check all the articles in PubMed, if we enter anemia and pregnancy, we'll see that interest is becoming more and more intense. It is a not invented problem. You see that anemia of pregnant is still a global problem, and only from 1995 it decreased twofold, but anemia decreased by only 5% since 1995 till today. Anemia is still a complication of 38% of pregnancies, and it is seen in 32 million of women in the whole world during pregnancy. Only 50% of pregnant women with anemia get iron medications, and in the developing countries where severe anemia is prevalent, standard treatment can mask the diagnostic of other diseases. What do I mean? The main reason for anemia is iron deficiency state, but it is not always. And we have timely asked hematologists about the diagnostic of different other causes that can lead to anemia. and indicating iron drugs for women without anemia that we can see in our country quite often can increase the risk of hypertension. When the doctors do not know the normal limits of hemoglobin, that can lead to different side effects that can lead to GI issues and so on. So these are big studies to understand what is postpartum hemorrhages, and we have early and late aligning with world data. We used to say that early PPH was 2 hours. Now early PPH is 24 hours after partum, and late PPH is after 24 hours. And we understand that the main cause of PPH is uterus hypertonia, and it can happen on the second, on the third, and on the first level. And we have to understand clearly that the possibility to provide medical help on the first level is very limited. It is discussed a lot. Should we use elastic bandage in postpartum hemorrhages? In our National Center of Obstetrics and Gynecology, we will not use this method because we have big surgery team. We have all the methods to stop bleeding. But on the first level, before the team comes, before the surgeons, the vessel surgeon comes, this method can be used. And of course, I would love to stress that uterus atonia can happen on any level, and bleeding can happen on absolutely any level. But to prepare, to predict it, it is difficult to predict PPH with uterus atonia. We still need to correct pre-operation anemia. And you see the consequences of PPH. Hypophysis ischemia, Sheehan syndrome, multi-organ failure. There is probability of hysterectomy, the necessity for IU, increased necessity to blood transfusion with possible consequences, cardiovascular failure or cardiovascular pathology, postpartum anemia, and maternity mortality. Multinational WHO survey demonstrated that severe pregnant anemia is associated with maternity death. Maternity death increases 43-fold if there is prepartum, preoperative anemia, severe anemia. If we cannot always control the developing of bleeding on different levels, but we can decrease preoperative anemia. We have to take these measures, these preventive measures. The next study is from China. And here's a big study. 6,000 women were included into the study. And the frequency of PPH is 2.2%. And there were 5 risk factors associated with PPH. Of course, placenta previa increases the risk of postpartum hemorrhage 10-fold, and anemia increases postpartum hemorrhage risk 4-fold. One more important study from Norway that demonstrates that anemia of the pregnant anemia along with antiplatelet therapy, you see antiplatelet therapy 5-fold increases postpartum hemorrhage, as well as pregnancy anemia increases massive PPH. And we should, of course, understand it and control it. We should control anemia in pregnant. One more study. Postpartum hemorrhage significantly influences maternity outcome with antenatal anemia. 589 women with severe maternity outcomes and 274,000 women. You see that there were 70% with severe preoperative severe outcomes and only 14% of women without preliminary anemia. So to conclude, main direct and indirect causes of maternity death are bleeding and anemia, and these two processes are associated with one another. Most of bleeding cases are due to anemia. Widespread antenatal anemia is seen due to the excessive iron consumption during pregnancy. In the world, we see the trend to increase of PPH frequency. Anemia increases risk of PPH, and it can decrease her possibility to survive after severe PPH. So the algorithm of diagnostic, and I think we will have lots of reports on iron deficiency anemia. Most important, we should follow ferritin level and differentiative diagnostics of different form of anemia. According to WHO, data is a widespread disease. More than 1.5 billion people in the world suffer from this disease, and 50% of cases is IDA. Oral iron therapy is first-line therapy in treating of iron deficiency anemia, while intravenous iron therapy is an alternative variant for the patient who do not respond oral therapy, who need to restore the level of iron and hemoglobin preoperatively. And if there are some causes that do not allow to differentiate and set the diagnosis of iron deficiency anemia, the patient should be sent to the other experts, and the cause of anemia should be differentiated. Blood transfusion should be performed only for the women who has further risk of heart failure and further bleeding. And it is very important to prevent perioperative anemia in obstetrics. Thank you for your kind attention. Well, traditionally, we will discuss questions at the very end, and the next presentation on PBM in pediatrics and neonatology will be presented by our colleague from the United States, Professor Susan Gubry.
Hello, my name is Susan Gubby. I work at Boston Children's Hospital, and I'm an associate professor at Harvard Medical School, and it's really a pleasure to be here today to talk to you about pediatric patient blood management. I don't have any conflicts of interest, and here are my disclosures. The objectives for my talk are to discuss the challenges of perioperative bleeding and blood transfusion in children, to outline recent international evidence-based guidelines for patient blood management for pediatrics, and to briefly introduce the concept of translating guidelines into practice and the goals of a pediatric patient blood management program. Well, children in our operating rooms are bleeding, and they're being exposed on a daily basis to blood products during major surgery. This diagram outlines one institution's practice, this is Boston Children's Hospital, and shows the percentage of episodes transfused by surgery type. The highest categories include major neurosurgery, liver transplant, major orthopedic surgery, craniosynostosis surgery, and also cardiac surgery, which is not shown here, with transfusion rates from 40 to 100%. So we're often exposing our infants and children to blood products preoperatively and perioperatively because they're bleeding. In many cases, this is clinically indicated and life-saving. However, perhaps we can improve patient care and outcomes by optimizing the use of patient blood management modalities in our children. So let's discuss the unique management challenges of anesthesiologists when they are caring for patients who are bleeding. These photos are presented with permission of the family and show a small infant who I took care of with an encephalocele. A small volume of blood loss can quickly cause hypotension and clinically significant hypovolemia. And really, there's only one main goal. That's to correct or avoid insufficient oxygen delivery to vital organs and tissues. Restoring and maintaining oxygen delivery to vital organs and maintaining hemodynamic stability and normal volemia is paramount. Hemostasis must be preserved while avoiding hemodilution, and it's also very important to avoid unnecessary transfusion or overtransfusion to avoid complications such as hyperkalemic cardiac arrest or TACO or TRALI. So a concerted effort must be made by all healthcare workers to avoid unnecessary and inappropriate transfusion in our pediatric patients. And it's not only exposure to allogeneic blood products that's associated with increased risk, but also the reason for transfusion and the volume of blood products given. In this report of over 110,000 neonates and children included in the American College of Surgeons National Quality Improvement Database, we show that children who undergo non-cardiac surgery, there is a transfusion incidence of 6% in pediatric patients in U.S. hospitals. Children who received a blood transfusion had an associated increased risk for 30-day mortality and complications such as wound infection, pulmonary, neurologic, cardiac, and septic complications. And even more interesting is that, as shown in the figure, while the transfused children in the black and the untransfused children in the gray, with increasing volumes of blood transfused, the percentage of children with mortality at 30 days increased significantly, the highest for those transfused over 40 mils per kilo. So therefore, a blood transfusion can certainly be life-saving or life-threatening. And I offer the following observation. On one hand, a blood transfusion may be clinically necessary for life and maintaining vital organ perfusion. However, alternatives to blood product transfusion in our pediatric patients may be the safest choice. The American Association of Anesthesiologists and the European Society of Anesthesiology, as well as other important societies throughout the world, have also agreed that bleeding and transfusion of allogeneic blood products independently increase morbidity, mortality, and length of stay and hospital costs. But there's no specific outcomes or recommendations for the pediatric patient in these guidelines. We can all agree that patient blood management is a win-win situation for the following reasons. Expert consensus and evidence-based guidelines show that using patient blood management can decrease variability in care, increase patient safety, improve patient outcomes, and decrease blood transfusion with better resource allocation and decreasing healthcare costs. I will highlight a few of the pillars of patient blood management in pediatric patients, as shown in this diagram. The Society for the Advancement of Blood Management recently published these aims to improve clinical outcomes by using multimodal conservation strategies. and avoiding unnecessary exposure to blood components in pediatric patients. And the reference for this article is included here. I will outline some of those guidelines. The very first, and I think one of the most important, is preoperative anemia. Anemia is often accepted as a variant of normal or even ignored in children presenting for surgery. Greater than 25% of our children have iron deficiency anemia, and this is World Health Organization data in industrialized countries. Failing to screen, diagnose, and treat anemia is no longer accepted. And here is recommendations from the Society for the Advancement of Blood Management that preoperative screening for anemia is recommended in children at high risk for blood loss at least 3 to 4 weeks prior to surgery to allow sufficient time to diagnose and manage anemia. And also the consideration of oral and intravenous iron and other modalities to treat preoperative anemia, and perhaps suggest that surgery may be postponed to optimize unless surgery is of an urgent nature or must be performed sooner. So what is the relationship between preoperative anemia and mortality in children? Dr. Ferroni and I sought to define the incidence of anemia in children in U.S. hospitals and to determine the relationship between anemia and mortality. We identified over 50,000 children with a preoperative hematocrit recorded in the NSQIP database, and we determined the primary endpoint of our study would be the incidence of all in-hospital mortality. We concluded that 24% of children were anemic preoperatively, and that there was a 60% higher odds of a blood transfusion among children and neonates with anemia. For children, mortality increased by twofold in the anemic group compared to the children without anemic. And for neonates, the incidence of U.S. hospitals was very high, 32%, as defined by hematocrit less than 40. We report that the mortality in neonates is high, with an odds ratio of 2.6 for those with preoperative anemia compared to non-anemic neonates. Not only should preoperative anemia be timely diagnosed and treated, but also in-hospital or hospital-acquired anemia should be recognized and prevented. And the following SABM recommendation specifically addresses hospital-acquired anemia. There should be specific measures to reduce blood loss and improve hemoglobin concentration. We recommend a minimum frequency and volume of blood sampling, and also a restrictive transfusion thresholds at all time, and this is supported by published evidence and expert consensus. One of those expert consensus guidelines is the Pediatric Critical Care Taxi Guidelines, and these were published by Dr. Valentine and co-authors in 2018. This is the result of evidence-based and expert consensus on the transfusion and to treat anemia and the hemoglobin threshold in critically ill pediatric patients. These are excellent guidelines that we can use. And for those patients with no hemorrhagic shock and a hemoglobin of 5 to 7 grams per deciliter, it's recommended to consider transfusion based on clinical judgment. If the hemoglobin is greater than 7 grams per deciliter in a hemodynamically stable patient, in most situations, no transfusion is recommended. Furthermore, we have good guidelines for neonates. Neonates are one of the highest transfused groups in pediatric hospitals. They develop anemia of prematurity, and they frequently require multiple blood transfusions. Up to 80% of premature and low birth weight neonates receive at least one blood transfusion during their hospital stay. There is good evidence that transfusion is associated with an increased risk of neck and retinopathy of prematurity and death, among other morbidities. And most evidence-based sources recommend restrictive thresholds, although the data wasn't clear and concise until we have the results now of this ETNO trial, which was just published in JAMA. And the conclusion is that among extremely low birth weight infants, a liberal blood transfusion strategy did not reduce the likelihood of death or disability at 24 months compared to a restrictive transfusion strategy. Let's move along to pediatric patient blood management monitoring guidelines. SABM guidelines recommend point-of-care guided transfusion algorithms for pediatric surgical and critically ill patients. And also there should be written guidelines for monitoring and managing perioperative bleeding based on evidence and expert consensus. And this may be in the form of transfusion algorithms. Furthermore, other recommendations from SABM are that there should be strategies to avoid hemodilution, maintain hemostasis, as long as adequate end-organ tissue perfusion and oxygenation is upheld at all times. Pediatric massive hemorrhage guidelines incorporating a massive transfusion protocol based on age and weight should be readily accessible. And this is one such guideline that we wrote for Boston Children's-based and goal-directed therapy. Our SABM guidelines also recommend the use of antifibrinolytics for all pediatric patients at significant risk of bleeding, including children undergoing major surgery. In addition, cell salvage is recommended, which is the collection and re-administration or auto transfusion for all pediatric patients undergoing moderate to high blood loss surgery. To give you specific TXA recommendations for children, we published in this article indications, contraindication, and certain adverse effects to keep in mind. The dosage regime is summarized here, and we use pharmacokinetic modeling and simulation to come up with this dosing regime where we recommend a range between 10 and 30 milligram per kilo loading dose up to a maximum of 2 grams, and an infusion of 5 to 10 milligram per kilo per hour for pediatric patients. We published a non-inferiority trial in the British Journal of Anesthesia and determined that there was no difference between high and low dose tranexamic acid regime in patients undergoing craniosynostosis surgery. There was equal efficacy in terms of blood loss and transfusion, and the plasma levels were kept above the minimum level, which is considered therapeutic. And so we summarized in this article that a dose of 10 milligram per kilo loading dose and 5 milligram per kilo per hour is adequate to decrease blood loss and red blood cell transfusion in pediatric patients undergoing craniosynostosis surgery. Now, most high quality research and restrictive transfusion strategies pertain to red blood cells, specifically in pediatric patients. And the non-red blood cell products such as FFP, platelets, and cryoprecipitate should also be not used liberally. And these guidelines are guidelines that we offer on decisions to transfuse platelets, FFP, and cryoprecipitate. They should be used considering a restrictive strategy, and also, of course, very important to consider the clinical status of the patient before considering transfusion of these agents. We certainly need more evidence pertaining to the non-red blood cell product transfusion guidelines in pediatrics, and I offer this current opinion article also, to follow up on this, coming in 2021 will be the TAXI-CAB recommendations, and this is Transfusion Anemia Expert Initiative Control Avoidance of Bleeding. And these guidelines are expert consensus and evidence-based guidelines pertaining to plasma and platelet transfusion practices in pediatric critical ill patients. I talked mostly about non-cardiac surgery. Specific evidence-based guidelines for cardiac surgery are summarized in this excellent article by David Ferroni and colleagues of NATA, and I would refer you to that for specific cardiac recommendations. So in conclusion, the takeaway message is that bleeding and transfusion is associated with increased morbidity and mortality in children. A blood transfusion certainly can be life-saving, but it can also be life-threatening. I implore you to use standardized evidence-based multimodal patient blood management guidelines in your pediatric patients, and evidence-based protocol-driven care can reduce variability, improve the quality of care, improve safety, and reduce costs. And we need future high-quality research in targeted patient blood management interventions focusing on patient-centered outcomes. And hopefully we will continue that way in the future. So I thank you very much for your attention. I'm looking forward to the questions in the questions section, and have a great day and stay safe.
Thank you very much indeed. This is a very important issue. Pediatrics, children, neonatologists, there are lots and lots of issues. And good clinical guidelines is a very good support for all practicing physicians. And we are moving to the next issue. I pass floor to Mr. Veselov. He will talk about issues of PBM and coloproctology. Distinguished colleagues, distinguished friends, I think coloproctology is also very sensitive issue as neonatology is. And of course, the task that we have from 2019 is to check and to analyze possibility to use PBM in coloproctology. Well, today we talk a lot about the concepts and consensus, and we talk about 3 pillars of this PBM concept. And we talk about optimizing of red blood cells, optimizing blood loss, optimizing physiological reserves, and of course, to optimize it, minimize blood loss for coloproctology is very important. Actually, first and foremost, coloproctology is a synthesis of different science. It appeared in the Soviet Union in 1966. It was called proctology. Now, it changed from 1997. We call it coloproctology, and lots of patients are accepted. We have more than 1 million patients, and we treated more than 155 patients treated in recent years. In clinic, most of the patients are patients with inflammatory bowel disease, ulcerative colitis, and Crohn's disease, diverticular disease, and colorectal cancer. 1/4 of all the patients suffering from colorectal cancer are hospitalized in coloproctology.
So today, Alexei already demonstrated this data, and we know that speaking about the abdominal indication, in the Russian Federation, we carry out more than 1.5 surgeries a year. In patients with colorectal cancer, we know that this is a huge risk factor for the development of post-op complications. So here in the study, you see the severe iron deficiency was directly linked for the risk factors of post-op complications in patients who had surgery about colorectal cancer. Speaking about GI tract abnormalities, so that may potentially lead to the development of the anemia of chronic disease, which is more typical for the inflammatory bowel disease. When we face development of iron deficiency, so iron deficient anemia, So that's related with the development of anemia of inflammation. And here is the prevalence of anemia in patients with inflammatory bowel disease, especially in pediatric population. That's about 70%, and almost half of the patients who are suffering from ulcerative colitis and Crohn's disease, they report anemia. But if you look at iron deficiency in patients with inflammatory bowel disease, then it's high rate. It's truly high rate. And the prevalence of anemia in inflammatory bowel disease in different categories of patients is very variable. So here you can appreciate the data from 6 to 74%. And mainly it is related to the group of patients who was assessed. So if this is a remission of the inflammation of the gut, or maybe this is the prolongation of the inflammation, let's say distal forms of the ulcerative colitis. In Crohn's disease, anemia is faced more frequently. We need to say that sometimes it's truly one of the most important reasons that forces us to examine, to check up the GI tract properly when we have anemia of unknown genesis, especially in younger patients, plus to that abdominal pain. So these are first two symptoms that require deeper examination, colonoscopy, possibly with the terminal compartments of the ileus. Only then we can make Crohn's disease diagnosis. Speaking about the components of patient blood management, so what is recommended by our international colleagues, so that's optimization of the red cell mass and then identification of anemia. From the process point of view, so all the patients who are hospitalized into our structure in coloproctology clinic, they should be checked pre-op set of lab tests, focus specifically on the hemoglobin as well. So that's clinical blood tests, including hemoglobin, but also there is a specificity for the service. And very frequently we see that those patients who have iron deficiency anemia, they are not hospitalized. And actually first they require to compensate anemia, and actually then they refer them for more or less regular surgical intervention. So minimization of the patient's blood. Well, technologies are widespread, so we have lots of minimal invasive approaches. If you speak about malignancy, so we actively use flex endoscopy with removal of very large hairy lesions, let's say squamous adenomas or wedge-like adenomas, and even initial precancerous stages. So very actively here we use transcranial microsurgery where the blood loss is less than 50 milliliters. And in fact, that's exactly the technology, and that's exactly the stage of patient blood management that can maximize values in coloproctology practice. Speaking about the third component, optimization of host resources, well, here we are mainly working with our transfusiology team and anesthesiology and ICU people, because again, when we started it, the first thing what we could do is to look at our own practice in our center and also other large coloproctology units, where we clearly saw that this concept of PBM in coloproctology is not actively used. And actually, we have lots of hemotransfusions in general around the country, specifically for the patients with ulcerative colitis, Crohn's disease, and diverticulum. But we tried to carry out our own study, and this is our data. So, because our colleagues speak a lot about clinical guidelines, but as I personally I have been involved in the adaptation of the guidelines with the Center of Medical Surveillance. I know what is needed. We need health economy assessment for any technology, So that's exactly what we started with. For 2018, we had about 44,000 patients already had surgical interventions. So here you see the data of very large coloproctology departments. So anemia in the structure. So here you see mild, 82%, moderate, 15%, and severe anemia was reported with HB less than 60. That was 2.7% from our sampling. And in fact, we calculated the damage with perioperative deficiency of iron and anemia. We were based on the European data mainly, and we compared. It's like benchmarking. So the options before PBM and after PBM, so just comparing the outcomes. And monetary equivalent here appeared to be very significant. So the efficacy was 74.6%. So that means we reduced costs three times reduced costs. So potential cost efficiency or preventing of extra costs due to the shortening of length of hospitalization was also demonstrated. Cumulative economy in rubles, about 46 million Russian rubles for coloproctological patients practice. And the same saving was shown when we reduced the transfusion rates. And actually, once again, I want to emphasize here that patient blood management, to us, it's quite challenging thing because we need to provide them with blood components, with plasma, and actually it comes from other financing, from other reimbursement money. So clinics now don't spend money for that because we used to spend on that, but not anymore. So if we speak about the economy for the healthcare system, here we see the real effect. But if we speak about health economy for specific medical organization, then the use of IV iron or peros iron provides, let's say, negative effect because blood components are given for free. And definitely patient blood management should be implemented in the coloproctology service because in the hospital stage you see many patients who were hospitalized with diverticulitis, colorectal cancer, ulcerative colitis. So up to 60% of these patients come for elective surgeries, and they do have iron deficiency anemia. So right now the most well-developed technology of PBM are all the efforts to minimize blood loss in our case. So what we need to do is to strengthen organization, methodological support for rolling out PBM technologies. And one of the tools here are clinical guidelines, and plus to that, the integration of coloproctology service into the association of PBM to do it more actively in practice in the treatment of coloproctological diseases. And our pilot study actually demonstrated economic effect, cost efficiency effect to the healthcare resources assessment and savings when we implement PBM technologies. Thank you very much for your attention. And the next presentation, patient blood management in oncology, the next presentation would be done by academician Поддубная. Dear colleagues, I'm very much impressed, just like you, because the first International Congress on Patient Blood Management is designed very properly by the organizers. So all these blah, blah, blahs that we are talking today, that we are talking about for about a few hours already, would be later on detailed in the specific sessions because we will speak according to a specialty. That is why naturally selecting oncology, because I am quite mature oncologist of Russia. So let me speak about the main things that should be the basis of the development of this direction, which yet is just starting in oncology, in our specialty. So why do we need to deal with oncology? Why do we need to apply PBM? But why oncology in general is becoming one of the leading challenges of clinical medicine in the world? And this is very clear. Well, first of all, huge rates of incidence and prevalence. So we believe that by 2030, we will have more than 22 million oncology patients. And actually, we see quite negative forecasts of WHO by mortality and morbidity by 2030. So both will increase by 30% by 2030. So oncological pathology actually is a very leading reason of losses, life losses in the planet, and actually it's becoming number one by mortality reasons, so almost everywhere. So yet in Russia it's number two after cardiovascular diseases. So this is exactly the pathology that mainly covers elderly patients. And here you see, so this is the real and estimated data, because you can see here how incidence and prevalence are increasing, specifically in elderly patients. What is elderly patients? We know very well. So what spectrum of comorbidities we see, how polypharmacia starts, which prevents from specialized treatment, and most important, the consequences of this polypharmacia is drug-drug interactions that leads to adverse event rates. So if you appreciate this publication, you will be very much impressed, just like me, because here from 1990 up to 2017, so 20 types of malignant tumors from 195 countries mentioned here at the bottom. But columns here is a rate of 70 plus. You see, two colors are prevailing, two top colors are prevailing, and they're showing the population which is 50 plus. So the exception are testicular cancers, they're really young males, but the rest are very elderly, 70 plus. And for them, we clearly see almost in any malignancy, we see worsening of 5-year survival and the outcomes, because there are multiple reasons here. So if we talk about the absolute figures, so in our country in 2019, only new cases de novo, almost 650,000 and almost 300,000 of losses. So when we looked at Forbes summing up on 2017, so they identify key areas for oncology development. As we understand it, well, diagnostics, therapeutic approaches, nuances of the therapeutic strategies, but still most important is the assessment of quality of life. That's by the patient's view, and also supply of the best quality of life. So this is what we need to provide, and this is our essential task, because we need to do it, because we cannot cure everyone, but we can provide care to a certain extent. But still, there is no doubt that this duration of life expectancy for all these patients should be of good quality. In order to do it in our country, so national oncology strategy was approved, and combating oncology is becoming very relevant, very important, one of the priorities for the government for 2024. So main objectives here, so increased rate of those patients who are followed up more than 5 years, with a focus that this life should have proper quality. And that is why a PBM project of patient blood management is one of the components to provide this quality of life, and no doubt it should be implemented into practice. But how successful we are in the treatment of our patients? Do you think our patients live longer in those cases where we cure the pathology? So that's also a very valuable publication. This is 45-year follow-up, and the data by 2015. So 5-year cancer survival rate increased from 50% almost to 70%. So the fire rate here is 67 for United States. So very different indications shown here. So they're showing a bit lower or higher rate, but still it is there. So that means we can treat effectively, and we even can cure. Especially it's clear in lymphoproliferative pathology, so for any of these types of tumors. So, and the new drugs, new options, new treatments which are available, they bring us something that we never had before. Let's say the first monoclonal antibody, anti-CD20, so lymphoproliferation, it's actually split the history of treatment into before and after rituximab, in Hodgkin lymphoma. So that's the outcome of the patients. More than 85%, that's the survival. And actually we talked a lot, and we have a lot in common with Dr. Schmakov for many years, because actually we are speaking about the fertility in these patients. We speak about fertility programs for them. In anti-CD20 monoclonal antibodies and Hodgkin lymphomas, we can treat relapses after bone marrow transplantation, after high-dose chemotherapy. We can consolidate the effect we reach. We can treat patients with unfavorable outcomes, unfavorable prognosis. So that's huge achievements in T-cell lymphomas, where actually there was no treatment at all, but now we speak about the improvement of all the outcomes using anti-CD30 options, but the other T-cell skin lymphomas, well, so these are very poor patients. Yes, so the whole skin. So they generalized in skin, so no approaches to treatment, and as a result, we have something new that changes these outcomes. CRC, colorectal cancer. Well, the previous speaker, Alexei, already spoke about it, but I'm speaking about the advanced stages where the primary metastatic colorectal cancer, and again, appreciate it here. So it's, so many arrows, and all of them are new therapeutic options. So we are increasing the overall survival of the patients with the primary metastatic colorectal cancer at any stage. So we can treat them with the first, second, third, and even fourth line of treatment. So in 1/4 of patients, we get positive responses. But what's the price? What is the price of that success? Surely, this is a success in treatment which is associated with particular toxicity, and toxicity could be very different. It could be hematological toxicity, secondary tumors, and sometimes absolutely new types of toxicities. So this is rate of second tumors. It's a particular challenge here for the patients, because we've started with children and we started curing them with Hodgkin lymphoma, for the secondary tumors. Well, acute leukemias, so more frequently now. Also some data from British Columbia, that's about 7% have secondary tumors. And if this is a chemotherapy, so that's one level, but if it's in combination with radiotherapy, so that's twice higher rate, 3.9. And they also showed that this is clearly related to the increase of alkylating doses, so cyclophosphamide specifically. So increase of dose gives increased secondary tumors rate. The other adverse events, so if you appreciate this data from the HRQ, Center for Delivery Organization and Markets Healthcare Cost Assessment and Utilization. So the most important are steroids, then anticoagulants, and then anti-tumor, anti-neoplastic treatments, immunosuppressive treatments. So this is a very high rate of adverse events, very different adverse events in very different situations. So, and definitely it attracts particular attention, and that's another set of data that's about 6.5%. And one of the most frequent situations is exactly what we are talking a lot about today. So this is anemia of different genesis. So we emphasized it here. So let's say, so if we make the diagnosis iron deficient anemia, and then therapeutical tactics should be based on that when it's related to blood losses. But here anemia could be of very different origin, and it is very frequent, from 70 to 80%. In later stages of neoplastic diseases, in solid tumors, that's half of the patient, every second one. A bit lower rate with lymphoproliferative pathologies, but severe life-threatening anemia could be seen in about 16% of the patients, 1/6. And this is a very serious percentage. You pay attention to that. And the rate of that, especially in chemotherapy, radiotherapy, or in combination, that's 54%, again, every second one. And we understand very clearly that this oxygen deficiency, so ischemia of tissues, creates tolerance to radiotherapy, so they become tolerable, and actually we see the reduction of the efficacy of radiotherapy. Moreover, radiotherapy, local radiotherapy, if let's say this is irradiation of bones, especially where we have big mass of bone marrow. So we are losing the option to reproduce because bone marrow is gone. And this is the percentage of the volume of the bone marrow irradiated in a standard radiotherapy. If these are pelvis bones and this is sacrum, and also that's the reason for anemia. So if we speak about the risks related to the anti-neoplastic treatments, so almost 40–45% of patients in complex treatments, we see both drug and radiotherapy, chemo and radiotherapy, with particular risks of complications. And sometimes the reasons of that very different. It may require emergency care, and this is the data I'm ready to share. So for 10 years in the United States, hospitalization of oncology patients to the Department of Emergency Care, ICU, increased 5.5 times. It's very clear that it also influences negatively the oncology patients, mainly due to the fact that we see particular rupture of the rhythm of treatment. So that's American data as well. More than 1.5 million emergency visits to the ER, emergency department, ED. So the most frequent complications that were the reasons of hospitalization, so sometimes unscheduled hospitalization. This is again sepsis, anemia, and neutropenia. So anemia should be identified and treated. And another view, and this is a very big study, please appreciate, again, more than 1,000 patients, and this is North Carolina University, the data for 2010. So they recruited patients with malignancies, those who were getting radiotherapy, and 20% they had not scheduled hospitalization. So most frequently in those cases, if the tumor localized head and neck, lung, or GI tract. And in half of the patients, these are the complications that required hospitalization for about at least 2 weeks. That is why definitely during last historical period, we witnessed already very different methodological approaches to the treatment of anemia. And, well, I'm not going to the depth of that, so we don't need it. But the point is that there is a clear link between the level of hemoglobin and the quality of life. It has already been shown, and we can only confirm it with this or that cohort of patients. And our oncology patients, they are, let's say, very illustrative in this context. So this accumulation of physical weakness due to the disease plus anemia, so that's the situation which definitely requires some correction. So, and I cannot avoid showing these recommendations as more recommendations for how to counteract anemia and iron deficiency in patients suffering from malignancies. So right now, we as oncologists, we understand it all very well. So what do we start doing? And we start doing it due to the initiatives of obstetricians and gynecologists, mainly Tatiana, because actually she is the main locomotor of that. When we are aware of their works, we started dealing with that. And a year ago, we paid attention to the fact that we need to get together. We need to think and resolve, so that the first advisory board here, where we asked our colleagues to join us, specifically Dr. Marty Apro and Professor Axel Hoffman, who helped us and supported us with all these guidelines, and they're already collaborating with us for a number of years. And also all these colleagues shared their experience with Russian experts. So they were from different cities, but here you see that these are leading specialists who could provide their own position about the challenge we are discussing. And then we decided that it should be finished with a particular view, general view, consensus view for PBM in oncology, and also a concept was designed and published. And based upon the global data, this concept again was published the most important reference points where PBM is involved into the oncology strategy Russia is, first of all, correct treatment of anemia that should lead to the improvement of the quality of care, where the authors emphasize that patients with anemia, the efficacy of radiotherapy and chemotherapy is reduced, and that has been already proved. And definitely we need to minimize all possible risks related to transfusions. And those so-called bloody surgeries in oncology, they should be in the frame under the scope of PBM and should be corrected. So that is why in the concept, definitely, we need to add on the standard strategy for treatment of patients with the basics of PBM, which we are aware of. So this document has already been published in Modern Oncology magazine, so you can appreciate it. And we started all together with our colleagues. So we started working all together. So we participated in the first Russian Iron Academy. Yes. We also participated in the 5th International Congress on Menopause. And also we carried out the conference in one of the Moscow clinics. And also we started some data collection on the anemia rate in our patients, actually the baseline level, then peri-op, then post-op. So all these milestones are very important for the proper study. So I believe that we have very good plans for the future, so that, let's say, international congress, that's first international congress we are participating today, so we put it in the schedule and we will speak more about it. So, and actually, this slide, it's not mine. Tatiana shared it with me when she's telling that all specialists should be under the same roof in the National Association of PBM Specialists. Because actually all of the positions, no matter what our specialty is, the challenges are common for all of us. And when we digest them, we need to implement the strategies for the benefits of our patients with help to our healthcare. Thank you very much for your attention. Thank you very much, Irina. And the next presentation about the pre-op preparation of patient, when, how, and who. Sherry Azama, United States of America.
And I am a client delivery lead at Acumen Incorporated, also in the United States. I've been involved in the field of patient blood management for more than 25 years and built and established one of the most well-known patient blood management programs in Englewood, New Jersey at Englewood Health, as well as I am a founding member and, again, current president and board member of SABM. So I'm here to talk to you today about perioperative patient optimization, what to do, how, and when. So the objectives for the next 15 minutes or so that we're together are to discuss the importance of management of anemia in optimal patient blood management, presenting some data on the impact of perioperative patient optimization, review ideal timing for perioperative anemia management, and discuss the connection between peri-op anemia management and improved patient outcomes. So let's start just for a moment with some definitions, and you've probably seen this already during this meeting here, but I'm going to review it one more time. The actual definition of patient blood management, as SABM, as well as IFPBM and NATAN, other patient blood management organizations around the world define it. It's a patient-centered, systematic, evidence-based approach to improving patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. So the focus here really is on the patient's own blood as his or her own liquid organ that we can optimize, particularly in peri-surgical time. So this is a schematic of that idea of patient blood management and its definition, with improved patient outcomes at the center. We may spend a lot of time talking about, over the course of these conferences, transfusion and transfusion avoidance, but really transfusion is not part of the exact definition of patient blood management. It's really about patient-centered care and mitigating risk. So we'll spend some time today talking about optimization and anemia, although patient optimization in the perioperative period also includes things like blood conservation modalities and optimizing coagulation. Because of time, we'll spend most of it on managing anemia, which often we have the most control over. So just for a moment, when we use this word optimize, what is the definition? So this is how Webster's dictionary defines it: an act or process or methodology of making something as fully perfect, functional, or effective as possible. So now back to the surgical setting. Can we make surgery perfect, even with the most skilled surgeons and anesthesiologists and nurses and everyone else? No, it can't be perfect. Can it be more functional or effective for the patient? For sure, yes, it can. So let's talk for a few minutes about how patient blood management and perioperative optimization can contribute to that. So the traditional concept, of course, is that blood products or blood components are an effective therapeutic intervention, but the newer concept is the transfusion of blood components is an undesirable outcome. And really, this gets into the concept of avoidable versus inappropriate. So we spent many years talking about inappropriate transfusion. We're taking this a step earlier to say if we really do the right things for the patient, particularly in the area, for example, of managing anemia in the perioperative period, we can avoid the negative consequence of transfusion and its associated poor outcomes and other poor outcomes for patients. So let's talk just for a moment. Again, this is data that's probably already been presented during this conference or you are familiar with, but the prevalence of anemia here just in the United States, in a developed nation, is about 35 million people, probably an underestimate, but it affects 2 billion, almost 2 billion people around the world, really a quarter of the world's population. And previously undiagnosed anemia is common in elective surgical patients. It affects patients at all stages of their life cycle. And really the most common underlying causes are treatable, and they include at the top, iron deficiency, vitamin B12 deficiency, CKD, chronic inflammatory diseases, folate deficiency, and other conditions in the elderly. So again, this is not news, but this is something that's very, very common that we are going to find in our patients. Just a quick glimpse of the epidemiology. It's a very common complication of common conditions that patients face around the world. So large proportions of patients with inflammatory diseases like rheumatoid arthritis, inflammatory bowel disease, CHF, diabetics without renal failure have anemia. And certainly, as we're well aware, large proportions of patients with chronic kidney disease, if not even higher than listed here, have anemia. So it's a common companion of many diseases in the patients that we take care of. So interestingly, though, maybe because it is so common in so many of our patients, it really is treated as a normalized deviation, at least in many people's minds. It's so common, it seems to be accepted as normal, and even when it's detected, many clinicians see it as relatively harmless, and patients too see it as relatively harmless and easily managed if necessary with a transfusion, which is readily available and perceived to be safe. So transfusion has sat in that position as the default management strategy and seen as low risk and high benefit, even though plenty of evidence, and you're seeing it during this conference, shows that that is not necessarily the case. So again, back to this new paradigm that anemia is a significant modifiable risk. We can do something. Can we make it perfect? Maybe not, but it's a significant modifiable risk for increased perioperative morbidity and mortality, and it should be diagnosed and treated before surgery, and certainly after too, as appropriate. So why should we care more? We said it was a sort of a normalized deviation in many people's minds, both patients and clinical providers, but its value of treating it goes beyond just reducing risks around transfusion. Effective clinical management of anemia improves patient outcomes in patients with heart failure, kidney failure, again, inflammatory diseases, and improves patients' quality of life. Also, anemia may be an indicator of an undiagnosed underlying disease process, for example, iron deficiency, that may suggest occult malignancy in patients. So by looking for it and finding it, we do find more things that we need to address in our patients. So we could show a lot of literature, and probably many of you in the audience are familiar with this literature. I'm pulling just a few powerful examples of why anemia needs to be detected and treated, particularly in our perisurgical patients. So here's a large study by Fowler in the British Journal of Surgery, almost 1 million patients, and looked at 24 studies. And 39 of patients in the study had anemia as per World Health Organization definition, hemoglobin of less than 12 for women and less than 13 for men, although we could argue that it should be, less than 13 for men, although we could argue that it should be the same for both women and men. But in these large numbers of patients in the systematic review of multiple studies, anemia was associated with increased perioperative mortality, increased acute kidney injury, increased infection, increased stroke and cardiac surgery. So some very poor and serious negative outcomes from this excellent paper. Another landmark paper and well-known in Lancet in 2011 by Masalam, looking at the impact of pre-op anemia and post-operative outcomes. This was a non-cardiac surgery population. And along the x-axis of both of these graphs, of course, is a dropping level of hematocrit. The first graph from the paper on mortality and the second on composite morbidity index. And in both cases, as hemoglobin or hematocrit and of course hemoglobin was lower, patients' mortality and morbidity was increased. And to go into more detail on this same study, even mild anemia increased mortality by 1.4%, morbidity by 1.3%, and again, transfusion holding the default position for treating anemia in most settings still, although we are trying to change that, contributed to increased mortality by 2% and morbidity by 1.8%. So the lesson from this, again, important piece of work is that anemia is bad for patient outcomes, and transfusion does not really improve it. It makes it worse. And again, in this particular analysis, 30% of patients were diagnosed with pre-op anemia. Again, probably very typical, or even a low number in many of our patient populations. Another important study by Dr. Ferroni and colleagues in anesthesia and analgesia in 2016 looked at in-hospital mortality in children with and without pre-op anemia and transfused and non-transfused. And again, we see the correlation between anemia, poor outcomes, transfusion, and poor outcomes in this pediatric population. Kevin Trentino was also presenting here at this conference, and no doubt he will present this and his other very powerful data, so I won't go into deep detail, but this interesting paper which looked at the primary outcome measure of incremental cost, actually, evaluated by RBC unit transfusion avoided in treating pre-op anemia and suboptimal iron stores in elective colorectal surgery. Looked at these a significantly large patient population who are screened for pre-op anemia and treated, and essentially showed that lower costs occurred in patients that were screened and treated, significantly lower for anemia and suboptimal stores. So not only are we doing the right thing clinically for patients, which again, many studies show, but economically, the outcomes are also very positive when treating preoperative anemia and optimizing our patients. So part of the intention of this portion of the program was the when. And so in ideal circumstances, we have a decent amount of time to prepare our patients, even weeks ahead of elective surgery. Sometimes we don't. So this was a very important study that many of you probably are familiar with by Dr. Spahn out of Switzerland. And he looked at very short-term treatment in cardiac surgery patients of pre-op anemia with iron replacement and ESA replacement. And again, the conclusion from this study that even when there's very little time to prepare patients for surgery, patients have effective response to both iron and ESA and other hematinic measures in reducing exposure to RBC transfusion, and then again, a contribution to improved patient outcome. So just because we don't have a lot of time doesn't mean we should forget about optimizing our patients. So we're gonna keep it very simple, really. Preoperative anemia management or optimizing our patient, it begins with some simple things, right? Screening our patients, testing our patients, diagnosing our patients, and then treating the underlying causes. Again, for many of these patients, it is iron deficiency. There are other causalities and other pathogenic processes that might be identified along the route. So again, only contributive to better outcomes. So I'm obviously not going to read this all to you, but I would direct your attention, and please, if you have the opportunity, to pull this excellent consensus statement from a number of world leaders, many of whom are presenting also at this conference, from Anesthesia in 2017, which really gave 9 key points on management or optimization of perioperative patients with anemia and iron deficiency. And again, I will not read this all to you, but just to summarize, they considered it a key factor to really consider pre-op anemia and iron deficiency as an indication for a care pathway that goes from the decision to have surgery until complete recovery from surgery. So it's not what happens just in the OR or just a few hours or days before. It's a long pathway. It should be investigated in patients with expected moderate to high blood loss. In this particular study, they call that greater than 500 cc's of blood. And the tests that would determine that would be serum ferritin less than 30, and in the presence of inflammation, accompanied with a transferrin saturation less than 20%. A serum ferritin level less than 100 is indicative of iron deficiency. And again, some newer studies are the CHR or the reticulocyte hemoglobin that is also included for in many centers as available and diagnostic of true activity at the bone marrow level. This is an interesting point in point 4 that major non-urgent surgery should be postponed to allow the diagnosis and treatment of anemia and iron deficiency, the same way that we would postpone surgery for other significant factors that might hinder a patient's good outcome. And, anemia should be taken just as seriously or more seriously in some cases. Oral iron, it can be effective in patients who are scheduled 6 to 8 weeks in time, and really involving even the primary care physician, not just the surgeon. And using alternate day treatment has been shown to be effective for oral iron. Unfortunately, for many patients, oral iron is not well tolerated or compliance can be a problem. So intravenous iron should be considered as point 8 in their consensus statement as a frontline therapy for these patients. And really, this diagnosis and treatment should commence as early as possible in the perioperative period, ideally as soon as the decision to undertake surgery is made. Or we might even argue before that it really should something that's part of essentially population health and something that's happening in primary care as a regular part of life and medical care. So this is just an example taken from a very large U.S. hospital of how they took some of those guidelines and turned them into an institution-wide policy. And this is how they phrase it in their policy, that patients who are having elective surgery with a risk of blood loss greater than 500 cc's are identified 3 to 4 weeks prior to surgery, which allows time to diagnose and manage that anemia and iron deficiency. And then they have included in their policy just some examples of high-risk preoperative patients. Again, a lot has been done in recent years to mitigate some of the risks of bleeding and control that, which is wonderful, with things like antifibrinolytics and other blood conservation techniques. But even so, there are some surgeries, of course, that still are associated with high blood loss. So building this into a normal process for an institution as part of a normal policy and procedure really is key. So part of that is what we recommend is a laboratory testing algorithm, really an algorithm for the entire process, and I'll show you an example of one in just a moment. But in terms of laboratory testing, many institutions, and this is again an example from a large U.S. Health system, allows the diagnosis of these most common causes of anemia and avoids the need for patients to keep coming back for additional testing. And they really do it very simply by obtaining a chemistry tube to hold at the same time as other blood testing. And patients then have reflex lab testing. So if patient's hemoglobin, male or female, is less than 13, additional studies are then performed on the samples in a reflex manner for additional iron studies, reticulocyte hemoglobin, etc. So it makes things efficient for both the patient as well as the care provider. But again, the key really is building this into the part of the normal daily process in an institution. There are many, many examples of these algorithms. You can find this as courtesy of Dr. Warner at the Mayo Clinic here in the United States, which he has shared. You can even just find these if you Google them, but there are multiple published examples in the literature. Many institutions now have these around the world. And it really takes providers through the process of first detecting that anemia, making decisions around it, and then pointing patients in the right direction. Again, in this particular one, I like it because it includes both that TSAT as well as the ferritin levels, but also CHR or reticulocyte hemoglobin as a really good measure in detecting true activity and true iron deficiency. But again, depending on how these results, how they turn out, patients may be pointed towards additional evaluation by hematology providers. They may need to see a nephrologist. They may go right on to replacement of iron or ESAs or other treatment modalities. But again, building this into the way of thinking of the institution as really optimal for all patients undergoing expected high blood loss surgery is ideal. So again, time is short. So just to summarize the points here about patient blood management and patient optimization, I was asked to talk about who, when, and how. So who, really all surgical patients, and I would contend all non-surgical patients. We should also be paying attention certainly to optimizing their health and well-being, but especially those who are anemic, right? Having high expected blood loss surgery and who are iron deficient. When? As early as possible. Again, we would argue that this should be part of primary care in the day-to-day life, even if patients aren't having surgery. But if they are having surgery, 3 to 4 weeks before scheduled surgery, or even more weeks if possible. And just because we don't have that many weeks, we should not give up. Short-term therapy is better than no therapy. And how? Well, really, this could be different in every institution, but we want to make it easy for providers to make the decision to do the right thing. So create easy processes, care pathways, algorithms for both the detection and diagnosis, decision-making, and the treatment of anemia in the perioperative period, thus optimizing our patients' care, their well-being, and contributing to better patient outcomes. So I thank you so much for your attention. For more information and resources, please see our website at savum.org. Thank you.
Thank you very much. And now we go to the final presentation in this session, how to facilitate practical implementation of PBM concept. This is Dr. Palushin. Good afternoon, distinguished colleagues. It's a great pleasure for me to be a part of this conference, and extremely pity that I cannot personally participate in this conference because I believe this topic is extremely interesting and important. So before I answer the question which I was asked by the organizers, how to facilitate the practical implementation of PBM concept, let me first answer the question why we need to do that. I'm pretty sure that you are all aware, specifically from our federal projects that are a part of the National Healthcare Project. You are aware about the tasks that are inside the project. So we need to reduce cardiovascular mortality, oncological mortality, and actually the improvement of the quality of life of the population and the improvement of the efficacy of the healthcare system. So specifically for the surgery, it is also overlapped with new approaches which are implemented by our colleagues that finally lead to so-called fast-track program. So what's the main point here? To reduce the hospitalization duration as much as possible, so fast-track surgery, and then without worsening the clinical outcomes. At the same time, we see and we know that demographic situation is very challenging, and we see that there are more and more people of the elderly employed age, but still we see some other trends which are telling us that the number of patients with comorbid pathologies included the number of patients where we identified anemia. So it's not just reducing, but also increasing, continuously increasing. Well, when we talk about the results of surgical treatments, then we clearly understand that the outcome depends on two components. So first, on the one hand, that's a surgical intervention per se, then trauma rates, especially in oncology patients, is just increasing. And than the capacity of agonism to combat that aggression, that trauma, because surgery is nothing else but trauma. And this contradiction, this aggression versus surgery versus recovery, so that challenges the resources. And resources truly depend as well on the comorbid pathology. That is why today the role of blood-saving technologies is increasing, just increasing, and actually we as professionals should answer the question: can we increase our surgical activities without worsening of outcomes, with limitations of particular blood replacement technologies? And I think this picture is already well known to all the participants of the conference, because actually many specialists are showing that, and I always try to include it. So here you see key options of optimization, blood-saving optimization. So the most important part here is to implement so-called perioperative multidisciplinary, I emphasize that, multidisciplinary patient-oriented approach. And here we can identify three most important pillars that you can appreciate here on the slide. This is optimization of physiological resources, minimization of blood loss, and optimization of the platelets. Speaking about minimization of blood loss, well, this is a very challenging task, and it is resolved not only by anesthetists and ICU people, but also by the whole team, and mainly by the surgical team as well. So today we observe the improvement of surgical methods, new technologies coming to stage. So all that facilitates the reduction of blood loss, although it does not allow fully avoid it. Now about the second block, which is optimization of the physiological resources of the patients. Well, here we actually almost completed any possible debates and rationality and reasoning behind that, limiting tactics. So it creates no doubt here. And actually it is seen in all the documents, both international and national. And last but not least, the third direction here, it could be probably most actively developing, not yet clearly formulated. It is related to the options to influence erythropoiesis, to ensure increased level of HB and erythrocyte rate in pre-op period. So quite recently, we carried out a congress, the third all-Russian congress, relevant issues of critical medicine. And then in the congress, we had a roundtable about the relevance of using and practice of blood-saving technologies. So in that roundtable, we invited surgeons participate, oncosurgeons, cardiosurgeons, so multidisciplinary, again multidisciplinary. And during the discussion and providing position, we found out that our positions are the same, mainly the same, but at the same time, we identify particular aspects that require further clarification and further discussion and overcoming of this. And actually, what's the point of this key issue? So that contradiction that prevents us for our mutual understanding, specifically multidisciplinary. On the one hand, this is a position that anemia should be resolved, and the second is that it should be limited. But how shall we do it? Because anemia should be eradicated, and according to the very recent consensus, the pre-op hemoglobin level should be increased up to 130, 120 gram per liter. But on the other hand, the tactics means totally different target indicators. So in this context, again, we should clearly understand that anemia should be resolved to do what? To do what? In order to increase resources, and transfusions should be limited to do what? To reduce the infection rate and adverse event rate related to tissue. So in this situation, surely, we ask next question, how to count comorbidities, how to supply this compensation delivery of supply, oxygen supply, how to increase oxygen consumption. So in this situation, the issue is about the quality of knowledge. So that should be multidisciplinary consensus. For example, specifically here, looking at this formula, I would like to demonstrate you the effect, how to provide oxygen supply to tissues. On the one hand, we can increase cardiac output, but on the other hand, we can increase saturation also. The other aspect is hemoglobin, and in each specific case, at each stage of treatment, the solution could be very different. If, for example, during anesthesia, we can provide the increased rate due to the cardiac output and increased concentration of oxygen in the blend, then post-op it's already uncontrollable. So there you can look only at HB and then and how and when to increase this hemoglobin and what to do in this specific situation. That's a big question. That's a big question which actually should find proper solution. So when we say what should be done and how it should be done, so we should mainly look at the systemic approaches. And when we talk about the factors that identify the efficacy of using of any technology, then we're always saying who is doing that, and what these people use, and when they use it, and actually whether it was justified or not. And the implementation is identified at least by 3 positions. So these are people and their knowledge, then organization of the hospital, and that's control of execution. So in this very short presentation, definitely I cannot tell more about all these components and blocks, because it is very clear that you can actually set particular tasks, but different executive parties would do that differently. That is why the control over all the participants or the whole flow is a must. It may sound non-democratic, but the organization of hospital, the structure of hospital is also important, because pre-hospital stage, hospital stage, pre-op age, surgical period, post-op period. So all these phases are important, and there are many things which are focused on increasing the resources of the patients that go for complicated surgeries. And definitely here we may not speak only about the hospital, but also pre-hospital stage, the outpatients financing, etc., etc. But now I would like to accentuate your attention to this aspect, specifically knowledge and the staff, and we need to have proper understanding of that. Again, it should be interdisciplinary position. So we understand here. So when we talk about the replacement tactics, then it's not just the anesthesiologists, not only ICU, but also transfusiologists are involved, and also pharmacies and distributors. And when we talk about who we are working with, then we understand that we are working with the graduates of institutions, graduates of residency and fellowship, those who are trained in specialty, master's, post-diploma, continuous medical education. So here there are lots of chairs that are involved, not only anesthesiology or transfusiology chair. So it could be also specialized chairs that deal with replacement. Then starts the system of continuous medical education, and it also can be provided with different efforts, different public organizations, chairs in the institutions, then preceptorship or mentoring practices. So that's multimodal approach, and it doesn't work. So definitely this aspect so we should look not only at the chairs that are implementing, but also the chairs that train these people. And specifically, these are those who trained students or residents or fellows. These are chairs that participate in post-diploma continuous medical education. So extremely important. These aspects are extremely important. That's a quality of training and elimination of, let's say, deviations in informing. Can we effectively overcome that? Yes, we can. And that's the key answer to the questions that were set here. It is feasible, it is possible, so we can do it due to the improvement of the interdisciplinary communication, and also we need to go that way with the design of the interdisciplinary recommendations, clinical recommendations, also carrying out conferences, congresses, and other events, educational events, school roundtables, involving specialists from different areas, different specialties that are following the standardized common ideology, and only then it would be feasible. So, in fact, consensus is important, and only with the help of consensus we can reach our objectives. And again, coming back to the title of my presentation, to the title of this conference, we can clearly see that all that helps us reaching very serious and challenging tasks. Thank you very much for your attention. And once again, I would like to apologize that it is not yet possible to be a part of the conference physically, but if you have any questions, comments, remarks online to me, I would be happy. I would be happy to cover them. Thank you. Thank you very much. Well, distinguished colleagues, so we are wrapping up this part. So we scheduled the discussion, but we're behind the schedule. So we have just two questions to ask. One question is to me. So why do you speak for the inefficiency of IV iron? Because if we count the direct medical costs, IV iron is definitely justified. Well, I totally support it. And actually, that's exactly what I demonstrated in my presentation. So the economic efficacy, the cost effectiveness of using IV iron, because in multiple diseases, unfortunately, the use of IV treatments is not a part of guidelines. So right now, we are designing the standards of care based on clinical guidelines. So if we speak about the hospital stage, so if something is not in clinical guidelines, then the procurement will be done from the different financial sources, because this is not included into the official budget. So in the PBM approach, it's very important to include anemia treatment into clinical guidelines, and then it would be the reason for the reimbursement and procurement, speaking about hospitals. And another question to Susan, but as far as I understand, we have Susan online. Is Susan online? Is she with us? So we have a question.
Hello, Susan. Вопрос.
We have a question. The protocols that you shared, locally obligatory, or they are just recommended, obligatory or recommended? And what happens if some specialists or clinics, if they don't stick to this protocol? So what is the punishment mechanism? Thank you. And if there is any.
Thank you for your question. It's really a pleasure to be here. I hope you can hear me. Thank you for that question about protocols. I'm not exactly sure which protocols you're. Most of these are recommendations, or we call them guidelines to guide care. And it's always up to the individual anesthesiologist, based on the clinical condition of the individual patient, to use these guidelines to guide their care. So they're just recommendations, not protocols, and we're not very rigid in enforcing them. I hope that answers your question.
Thank you very much for the clarification. Well, We are extremely happy that you found time in your busy schedule to join us personally, sir. On behalf of our professional community, we would like to thank you for a brilliant presentation, for a great review that you showed us in pediatric and neonatology practice. Any other questions? Just a second. Two comments. So there is a contradiction for the need to treat anemia and restrictive transfusion tactics. I don't see any contradiction here. I think it all goes online because there are two things. First, erythrocyte transfusion is not a method of treatment of anemia. If we speak about pathophysiological treatment, right? Right. And then erythrocytes of donors and erythrocytes of recipients, fantastic difference, huge difference. It's not the same. And it actually showed that tissue oxygenation after the transfusion of erythrocytes is not linear. And in majority of cases, you don't see it. So you transfuse, but you don't see the increase of oxygen consumption. So all these theoretical understandings of FIC formula is clear, but actually in erythrocyte administration, it's poorly used. That's why the use of erythrocytes or red blood cells cannot be considered as a method of anemia treatment. My second remark about the financial issue, who should pay, because it's not yet in reimbursement. And in any case, whatever we think, so we understand that probably hospitals are not paying now for blood components because that's a different reimbursement scheme. But most important objective of patient blood management is not to reduce the transfusion rate, but increase the quality of life, to make economic savings. So the question you are asking now, so even if we do not have any particular tool of reimbursement or compensation, but if yet we, let's say, spend some budget for particular treatment, but at the end, we will get the reduction of complication rates, so the total costs of the clinic would be more beneficial. That would be lower. That's the true cost efficiency of patient blood management principle. Thank you. Well, thank you very much for the comment, for the add-on. Thank you very much for that. And I'm pretty sure that, and I'm quoting Irina, that tomorrow we will spend the whole day working in sessions according to specialties. So we will dive deep into particular specialties and PBM in specific specialties. And with the request of organizers, keeping in mind that our schedule is very busy. So please welcome back at 1:35 Moscow time.
We are ready to start this session. And the first presentation will be by Professor Michael Auerbach from the United States. Iron deficiency in pregnancy and inflammatory cases.
Hello, my name is Michael Auerbach. I'm going to speak to you today about a new paradigm for the treatment of iron deficiency in pregnancy, which affects the majority of pregnant women in the world. Oral iron has been used for over 500 years. Sydenham first used it around 1500 to treat what was then called the green sickness, later described by Bloud in 1832 as chlorosis. Bloud was the first to use ferrous sulfate, and by 1865, iron was used to treat war wounds in the American Civil War. Today, it is the most common micronutrient deficiency on the planet, estimated to affect greater than 35% of the world's population and greater than 50% of gravidas. It is 100 times more common than all cancer combined, and here we are, more than 500, not 300 years later, using the often ineffective, usually poorly tolerated oral iron as our front line. I am showing you these slides because they basically represent the tests that we use to define iron deficiency. If the ferritin is low, we're in business. If the transferrin saturation is low, we know there is a need for iron. But these three tests take 2 to 3 days in most places to come back, and the new reticulocyte hemoglobin, abbreviated as CHR, comes off the auto analyzer in 40 seconds. We just published a paper in Mayo Clinic Proceedings showing how specific and sensitive the CHR is for defining those who have a need for iron and those who do not. You can see that in this graph. The baseline reticulocyte hemoglobin tells you who needs iron, and more importantly, the response to iron and those who do not need iron at presentation. I am not saying today that oral iron should never be used. There are indications. In the first trimester of pregnancy, there is no safety data. For mild, uncomplicated iron deficiency without active bleeding, oral iron is the frontline choice. And in the second trimester of pregnancy, if the hemoglobin is greater than 10. I will also show you data that giving oral iron every other day is superior to daily, changing the paradigm for oral iron. However, for those intolerant of oral iron, or in the second trimester of pregnancy, if the hemoglobin's less than 10, in the third trimester of pregnancy at any time, because none gets to the baby, after bariatric surgery where it is not absorbed, with abnormal uterine bleeding where it can't keep up with the losses, in inflammatory bowel disease where it makes the disease worse, in angiodysplasia where there is constant bleeding, and any comorbid condition, intravenous iron should be front line. Adverse events occur with both. However, they are enormously more frequent with oral iron. I will show you data that more than 70% of those to whom it is prescribed report significant gastrointestinal perturbation, as you can see on the left. We often don't ask these questions of individuals we give oral iron to. IV iron causes infusion reactions in 1 to 3% of patients. I will show you one. They're self-limited, they never leave a residual, and unfortunately, because of the folklore of severe hypersensitivity with intravenous iron, these minor reactions are often treated with vasopressors and antihistamines, making them worse, making physicians believe that a serious adverse event is present, and they are then ostensibly ascribed to the IV iron. Severe hypersensitivity occurs with any intravenous formulation. It is actually quite rare with intravenous iron, probably less than 1 in 250,000 doses. And subsequently, we are not going to discuss anaphylaxis today because it is incumbent on anyone giving IV iron to know how, IV medicine to know how to deal with it. Here is the graph I told you about. This forest plot is an excellent meta-analysis of more than 10,000 patients who received oral iron who were randomized to either no iron or intravenous iron. And as you can see, all of the gray boxes are to the right of the unity bar favoring toxicity. And in this paper published in PLOS One in 2015, this number approached 75%. I talked to you about alternate day dosing. As you can see here, if you give consecutive dosing for 14 days versus alternate dosing for 28 days, there is approximately a 30 to 40% increment in the net amount of iron absorbed. And the reason for that is that hepcidin levels go up after the administration of iron. There is no question here with a p-value of 0.001 that absorption is better with alternate day therapy. Here are the same patients where hepcidin was measured. And as you can see, the hepcidin goes up shortly after a single oral iron dose, blocking its absorption for the next 24 to 48 hours. The next dose should probably be given at 48 hours, but we don't know whether 48 or 72 is better yet. Hemoglobin outcomes are forthcoming and should be published later this year. I talked to you about the minor infusion reaction. Here it is, just seconds after the IV iron was given. Most of you were taught IV iron is dangerous. And if you see this, and this patient was also complaining of pressure in the chest, you are likely to intervene with epinephrine or diphenhydramine, turning this minor infusion reaction into a hemodynamically significant serious adverse event. Here is the patient just minutes later. Methylprednisolone and famotidine was given intravenously before the same iron that caused this reaction was then re-administered at the full planned dose. This is probably the most important part of this discussion because it is the misinterpretation of this event that mitigates much of the needed intravenous iron in pregnancy, the need for which I will show you shortly. In terms of iron safety overall, this trial this study, a meta-analysis of more than 10,000 patients, of whom 4,000 received oral iron, 1,300 no iron, over 3,300 placebo, and 155 intramuscular iron. Just to take a second, IM iron is painful, stains the buttock, it requires multiple injections, is not safer, is not more efficacious, and should never be given to anyone at any time, anywhere on the planet. Otherwise, I have no opinion. Overall, there was no increase in the risk of serious adverse events compared to any comparator, including placebo. There were infusion reactions. And when the different formulations were evaluated, there was no difference in efficacy or toxicity. So this is very dramatic. This is terrible, isn't it? A 747 on fire, likely to crash. If this was a passenger plane, hundreds of people would die. It would make headlines for days. It would require weeks to even months to investigate what happened. It's a horrible event, and it makes tremendous press. However, this does not make press. 810 women dying during pregnancy and childbirth every day. Almost 300,000 maternal deaths a year. And if you want to look at a parameter associated with poor maternal outcomes, it is anemia. The effects of intrapartum anemia are serious. Children of iron deficient mothers have increased risks of being born iron deficient. We don't screen our newborns, and yet 45% are likely deficient. Non-anemic iron deficient mothers have less severe complications, but still increased morbidity in newborns. Iron deficiency in mothers is associated with increased risk of preterm labor, low birth weight, and child and maternal mortality. And the current American College of Obstetricians and Gynecologists and United States Preventative Services Task Force guidelines ignore these data. In the United States Preventative Services Task Force says there is insufficient evidence that routine screening and supplementation for iron deficiency improves maternal and infant health outcomes. That is true because we don't have outcome data. We are actually doing that study with cord blood iron parameters as a primary outcome. However, there is high quality epidemiologic evidence that these recommendations need revisiting. The American College of Obstetricians and Gynecologists bulletin is outdated and in need of change. They state that intravenous iron is recommended in the rare patient who cannot tolerate or will take modest doses of oral iron, with the caveat that patients with severe malabsorption may benefit. That is patently untrue. 70% of pregnant women can't tolerate oral iron. However, in 2019, the United Kingdom moved forward with far more aggressive recommendations. Parenteral iron should be considered from the second trimester onwards and during the postpartum period for women with confirmed iron deficiency who fail to respond or are intolerant of oral iron. And in the outstanding paper in Blood published by Achebi and Gafter-Gavili, IV iron should be frontline for all oral iron intolerant second or third trimester patients, and for second trimester gravidas with hemoglobins less than 10.5, all in the third trimester because none gets to the baby, and I will show you that. We don't have guidelines for non-anemic pregnant women. These are the iron needs during pregnancy. In the first trimester, they're about the same as the non-gravid state, but in the second and third trimester, as the requirement increases 8 to 10-fold, there is no credible expectation that a formulation with poor absorption and high toxicity is likely to get adequate amounts to the developing fetus who needs it for brain development. Maternal iron deficiency potentially affects fetal, neonatal, and childhood brain growth and development with adverse effects on myelination, neurotransmitters, and brain programming. Children born to iron-deficient mothers demonstrate lower cognitive function, memory, and motor development recognized up to 19 years after iron repletion. Iron deficiency in pregnancy has been associated with increased risks of adverse perinatal outcome, including preterm birth, low birth weight, and small for gestational age infants. There is a reduction in fetal iron status when the mother is iron deficient. And in this study, 2,400 women were given oral iron. The mother's parameters improved, but 45% of the babies were iron deficient at birth. And you can see here that while the mother's ferritin did improve, there was no improvement in the baby's ferritin, despite the fact the mothers were given oral iron. Here is a marvelous graph published by Michael Georgiev in Pediatric Research in 2005, 26 years ago, showing the effect and timing of iron deficiency on brain development of a developing child. And as you can see, from week 32 to 2 weeks postpartum, if iron sufficiency does not occur, all of these changes in behavior, brain development, motor function, language are not reversible and can be measured up to age 19 years. Here was a paper just published in the very high impact journal JAMA Psychiatry showing you that anemia at any week of gestation is associated with a statistically significant increment in both cognitive and behavioral development. These are basically autism spectrum disorders. Infants at risk for iron deficiency are those from iron deficient mothers or previously treated for iron deficiency, underweight or overweight, vegetarians, multiparas, those with inflammatory bowel disease, smokers or HIV, interpartum period of less than 6 months, or with abnormal uterine bleeding. Is there any credible reason not to screen all of our mothers? Here is a paper that we just published in the Journal of Maternal and Fetal Medicine in 2019. We screened all non-anemic, underline that, non-anemic presenting gravidas in the first trimester, and using a ferritin or percent saturation of transferrin that was low, 42% were iron deficient, all of whom would be missed under the current guidelines, which ignore these data. This was data that was just published in Canada, that the prevalence of iron deficiency is extremely high. And as you can see, when screening is done, iron deficiency occurs early, not late. And iron deficiency affects greater than 50% of all pregnancies in Canada. And 25% were severe, and 40% of women were not screened at all. Here are data from Nancy Lozoff published in Pediatrics, showing that the effect of iron deficiency in infancy has long-term complications. The blue line are those with good iron status, but as non-anemic iron deficiency and severe iron deficiency is present, these cognitive composite scores go down and are highly statistically significant. We do have treatment options. Oral iron oral iron is available, but up to 70% report severe gastrointestinal side effects, and the obstetrical literature says that the incidence is unacceptably high. Hundreds of papers report safety and efficacy of IV iron during pregnancy without serious adverse event, but excessive fears mitigate its use. No formulation has been given the highest safety profile, and it is time for us to revisit these data given the absolute lack of significant toxicity when given in the second and third trimester of pregnancy. This was the first prospective study that my group did, published in the American Journal of Medicine. There is no comparator because FDA required oral iron intolerance, but you can see extremely high p-values for TSAT, ferritin, and hemoglobin for iron deficient pregnant women treated in the second and third trimester. There is no expectation you could have done this with oral iron. There are numerous studies that support this with other formulations. Here we use low molecular weight iron dextran as a single 1 hour infusion, but you can give complete replacement doses with ferric dirisommaltose, ferric carboxymaltose, and ferromoxetol that are available in throughout Europe and Asia. What did I tell you today? Oral iron is front line for uncomplicated iron deficiency for those who tolerate it, but that's the minority. High quality evidence suggests alternate day is preferable. For those with abnormal uterine bleeding, late pregnancy, inflammatory bowel disease, and comorbid conditions, intravenous iron should be frontline. The preponderance of evidence suggests that the U.S. Preventative Services Task Force, widely followed around the world, needs revisiting. You have 4 formulations now: low molecular weight iron dextran, ferric carboxymaltose. The World Health Organization mandated a change to dirisommaltose and ferromoxetol that allow you to do a complete replacement dose in 15 to 60 minutes, as opposed to months to a year of oral iron. IV iron should be frontline in all third trimester gravidas. I showed you it doesn't get to the baby, and the same for women with hemoglobins less than 10.5. In the second trimester, IV iron is safer than you were taught and needs to be moved forward in the treatment paradigm. Thank you very much.
Thanks to Professor Michael Auerbach. I would love to remind you that we have possibility to ask questions at the end of the session. We will answer them. And now I pass floor to the next presenter, Ms. Smetanina Natalia, the Deputy Manager of Dmitry Rogachev Institute, Management of the Patients with Anemia and Iron Overloading. Good afternoon, dear colleagues. Thanks for the possibility to share this information with you today. And during the first half of the day, we discussed very important issue: how to say donors' blood components, how to use other modern medical strategies to support normal peripheral blood cell state. I would love to talk about different issue. Yes, most of the problems are associated with iron deficiency. Yes, lots of states we can correct without using donors' blood components, but we should remember that there is a group rare group of hematological diseases that externally, according to the results of the studies, partially it can look like iron deficiency, but these patients, for these patients, the iron medication can be the last drop to finish their life. And general patient blood management is a different one. I would love to remind you that we have lots of anemias that are associated with the risk of secondary overloading with iron. When there is overloading with iron, that will be damaging organs and tissues, leading to irreversible changes of these functions. These are transfusion-dependent anemias. They are acquired, such as immunodysplasia syndrome and dysplastic anemia that can be seen in any age, in adult and in children, and it can be inherited anemia when people can live up to 45, 50 years old. And there are already patients in the United States who are even older than 50-year-olds, and they happily live. They are with inborn anemia, beta thalassemia, that is rare orphan disease. Due to its pathogenesis, patients have excessive iron that deteriorate their life quality, and as the result of the performed their life quality. It can also be inborn sideroblast anemia that looks like iron deficiency anemia, but the patients will die from iron overloading, and they need red transfusions for support of their state. There is also Fanconi anemia, diamond blackfan anemia, that sometimes seen during the first days and weeks of patient's life, and it will be with a patient for the whole his life. And inborn dyserythropoietic anemia that can be seen in any age. And sickle-looking anemia, sickle cell anemia that can be seen. These are very rare diseases, but they require very attentive attitude to manage the state of these patients. I would love to demonstrate to you, to remind you a few things about this disease. Anemia Fanconi is insufficiency of blood marrow and high risk of malignant disease development. Thanks God it's very rare, 1 to 5 cases, 4 million people in the world. There is no advantages in race and nationality. These are usually very small people, sometimes with severe malignancies of skeleton development that can be corrected by reconstructive surgery. Tumors, leukosis, aplastic anemia are very common in these patients. And the main problem is excessive sensitivity of the cells to DNA damaging agents. That's why these patients have all these problems with their health. What can we suggest to these patients to support their hemodynamics, to support their general state of health, so that they can live, so that they can enjoy their life? The only salvage method is hematopoietic stem cell transplantation, but it does not remove all the other problems that are associated with this disease. It's very difficult to find the donor, to find the regimen of transplantation, because they have excessive fragility of chromosomes. Androgen salvage therapy, we can try it, but the toxicity is very high, and complication is liver damage. And there are the last The last way is the transfusion of blood components that can give to them more or less normal quality of life. But iron excessiveness can appear. This patient cannot respond the blood components, they cannot respond to erythropoietic stimulating agents that we can use normally. This patient can never respond. Their state will be only deteriorating. When we arrest anemia symptoms, patients can tolerate hemoglobin 65, 70, but sometimes these numbers can be associated with vessel collapse, with anemic shock. When we see excessive bleeding in thrombocytopenia, we can only add blood components, donor blood components. If we have progressive aplasia of blood production and there is no material to build blood, and that's why we will use donors' blood components. If a patient is not lucky and there is no donor and he is non-responder to other therapeutic options, the only way to continue his life, it is donors' blood components, along with the iron control, and the standard way here is to try to avoid donor blood components, but in rare cases it can cost the patient a life. The next group, diamond-black vein anemia, the state that sometimes is demonstrated from the first days of life, and it is developed in the first 3 months of life. It is also inborn disease that also associated with early erythroid bone marrow predictors, and there is no cells to produce erythrocytes of the peripheral blood. It is also a very rare disease, 5 to 10 cases per 1 million newborns in the world. Same situation in the Russian Federation, and it does not depend on the nationality, on the race. Sometimes there are some deficiencies of the development. Mainly, the prognosis is favorable of these patients. They can live a long-term life if we manage their state correctly. That means if we do not manage to use other medication methods to activate the erythropoietic process, we can only use the donor's transfusion, and we need to extirpate to remove the excessive iron from their organism. That doesn't mean that they need some special approach. For all the countries, approach for these patients would be the same. If we do not reach transfusion independence, we need to provide them good life quality with donors' blood components, control iron, and remove excessive iron from their blood. What can we suggest? Hematopoietic stem cell transplantations with all risks that can be associated with them. Event-free survival is seen in 90% of cases, but there are still 10% of cases who do not survive well. We can try glucocorticosteroids, but efficiency will be seen only in 30% of cases. L-leucine recently demonstrated its efficiency that allows to substitute the rest erythropoietic process in these patients, but the threshold is again 30%. So the rest of 40% of the patients need long life transfusion. Whether it is good or bad, we don't know, but this is the only case for them to live long and happy life, controlling iron and removing it from organism. So when do we transfuse? The tactics differ. When a newborn has this disease, we need to provide this baby with a normal growth rate. That means that during the first year of his life, we have to support normal hemoglobin. Each 3 to 4 weeks, donors' red blood cells should be transfused. Sometimes, if a baby is of low weight with a low pace of growth, we will start transfusion a little bit earlier to give this child possibility to grow. Later on, we will decrease the bar of hemoglobin to have this substitutional transfusion, and the child can continue the transfusions with hemoglobin about 85 to 90. And we will not insist of subnormal and normal meanings of hemoglobin, but it will be when the child is older than 2 years, when the main intensity of physical growth is over. The next disease is beta thalassemia, same as iron deficiency, hyperchrome and hypersaturate anemia, and we will see all hyperchrome reticulocyte. That doesn't mean that there is iron deficiency, and we cannot orient only with this indicator, because we can consider this patient with a severe iron deficiency. We will prescribe iron deficiency, but hemoglobin will never increase, but the whole state of the patient will deteriorate. The liver function will deteriorate, and we will provoke early developing of liver cell insufficiency due to iron overloading. You can see how this patient look like. Mainly, these are patients of transfusion independent form. We have registered about 600 of the patients with thalassemia of different forms, with decrease of hemoglobin to 95 milligrams per liter, and well, it is low boundary of the norm, but they do not have iron deficiency. That's important. And the smaller group, according to our all-Russian study, is about 250 children has transfusion-dependent phenotype. Their own hemoglobin is less than 30 and have hyperchrome reticulocytes that also can be mask of severe iron deficiency anemia, but their serum ferritin will be always increased because the ferrum absorption is increased, and it will be aiming the collection of the absorption, the reserves of iron, and it will be very difficult to increase their hemoglobin in blood. Of course, we can suggest to them only some modification of gene therapy in our country. Only the first version is available, stem cell transplantation or lifelong substitutional transfusions. And if we do everything correctly, the patient can live a long and happy life without any difference in life to you and me. But hemoglobin should not be less than 95 grams per liter. We have to transfuse them in the diapason in the range of 95 to 120 milligrams per liter, thus sparing their organs without any severe complications such as splenomegaly, uterine pseudotumors, and the next type is inborn erythropoietic anemia. It is very, very rare disease, genetics is not clear by far. We have these patients in Russia. These are very rare patients in certain regions, and you see that complications are very different. In general, these patients are lucky because they can have their hemoglobin in normal level from 85 up to subnormal meanings, and in rare cases they need transfusional support. But please pay attention, in 80% of the cases they are overloaded with iron, and we have to remember about the states. And before the decision is made how to support this patient on selective surgery, on childbirth, we need to think what would be the benefit to this patient in substitutional transfusions, or is this a rare case when we can not work without transfusion? To conclude, I would love to draw attention one more time that iron overloading is the state in many inborn anemias with non-efficient erythropoiesis. It can be seen in adult and children. They need lifelong transfusions. Whichever risky this procedure, and inefficient erythropoiesis, such as post-transfusion iron overloading of organs and tissues, lead to life-threatening complication. We should monitor the state, and we should be very careful with iron medications, with iron drugs prescription. And we remember that there are drugs that can remove iron, and thus these patients will live happy and healthy life. Thank you for your kind attention. Thank you so much. We do not see any questions by now, and the next presentation, Professor Pedro Cabrales from the Institute of Bioengineering, California, with his presentation, what are the real data on the oxygen transportation and tissue oxygenation in anemia after blood transfusion?
Hi, my name is Pedro Cabrales, and I would like to thank the organizers for inviting me to attend this virtual Congress. The name of my presentation is Oxygen Transport and Tissue Oxygenation During Anemia and Transfusion. And before I tell you about oxygen transport in the microcirculation, I would like to tell you a little bit about myself. I'm an engineer who, since 2001, has been studying phenomena at the microvascular level at the University of California in San Diego. As you can tell from my accent, I'm originally from Colombia, South America. And what we do in my laboratory is we study the microcirculation. But contrary of all other laboratories, we use a quantitative approach following my engineering training. And the reason that we look at the microcirculation, or we study the microcirculation, is because we believe that the genesis of all cardiovascular diseases or all cardiovascular problems happen at the microvascular level. And these are some of the tools that we implement and utilize in my laboratory to characterize oxygen delivery and microvascular function. Some of the studies that I'm going to describe today were performed using the hamster window chamber, where the animals are awake and we can characterize their microcirculation, the intact microcirculation, and at the same time we can look at their systemic parameters. And the first study that I would like to show you is what happens when we transfuse animals, when we transfuse these hamsters with fresh and stored blood. Stored blood that has been stored follow the same standard as the blood banks use to process the blood, remove the white blood cells, and store in the appropriate additives. And in this case, the blood was stored for 2 weeks to simulate how transfusions are given we induce an anemic state in the animals by exchanging their blood with a plasma expander, with a colloid, to maintain their blood volume. When we reach their critical hematocrit, we transfuse the animals with fresh blood or stored blood and compare the function of the transfused red blood cells. We maintain a hematocrit not sufficient to transport oxygen to the tissue. We have a hematocrit of 18%, equal to a hemoglobin level of 6 grams per deciliter. And the first parameter that we characterized in the microcirculations of these animals was the functional capillary density. And you ask yourself, what is the functional capillary density? The functional capillary density is the numbers of capillaries that are perfused by red blood cells in the intact microcirculations of these animals. And logically, as we decrease the hematocrit and create an anemic state of 18% hematocrit or 6 grams per deciliter, the functional capillary density decreases. And if we transfuse those animals with fresh or stored blood, we are unable to maintain that functional capillary density independent of the fluid that we use in the transfusion. Fresh red blood cells decrease the functional capillary density. However, stored red blood cells severely compromise the functional capillary density and decrease that functional capillary density below 50%. So only a half of the capillaries that were initially perfused with blood remain flowing after a transfusion of stored blood. More importantly, even what is happening with the oxygenation at the level of the microcirculation. So decreasing the hematocrit to induce that anemic state to create the need for the transfusion decreases the oxygen level, but transfusing with fresh blood also decreases that oxygen level, is not able to restore the tissue oxygen level. Worse is when we transfuse the animals with stored blood. At that point, the normal oxygen in the tissue of these animals is around 20 to 21 millimeters of mercury. At that point, when we transfuse the animals with stored blood, the oxygen in their tissue after transfusion with stored blood is only 5 millimeters of mercury. Their tissue is completely anoxic. Their microcirculation does not have sufficient perfusion. Their functional capillary density has decreased. Their blood flow has been severely compromised. And if we calculate the oxygen delivery using the hemodynamic parameters and the tissue oxygen concentration that we are directly measuring from the tissue of these animals, there is a significant decrease in oxygen delivery and consequently the decrease in tissue oxygen. So to summarize this study, obviously we didn't observe any significant drastic change in systemic parameters between when we transfuse the animal with fresh blood and stored blood. But when we look at the microcirculation, we saw drastic changes in tissue oxygenation and, more importantly, in microvascular perfusion, in functional capillary density, which determines the supply of nutrients to the tissue, in addition to the supply of oxygen. There are several parameters that are affected in stored blood. And one of the general observations is that stored blood loses 2,3-DPG and its ability to deliver oxygen or to promptly release oxygen. So we designed a study where we modify in fresh red blood cells, we modify the oxygen affinity using different allosteric effectors, and we introduce these allosteric effectors to increase the affinity of the hemoglobin for oxygen and simulate the effect of losing the 2,3-DPG while preserving all the other properties of the red blood cells. And in order to introduce these allosteric factors, we created a process, or we modify a process called electroporation, where we create micropores on the membrane of the red blood cells using an electric field, and we are able to introduce these allosteric effectors. And we didn't want to create just one version of red blood cells with high affinity to mimic what if they have lost their 2,3-DPG. But in addition, we wanted to create red blood cells that were prone to deliver oxygen affinity, to deliver oxygen by decreasing their oxygen affinity. So we created an array of blood, of different formulation of blood with different affinities for oxygen. We modified what is known the P50 of the blood, the 50% saturation for the 50% saturation with oxygen, the oxygen tension at which 50% of the hemoglobin is saturated with oxygen. And we went from normal P50 of 32 millimeters of mercury to a very high affinity, only 10 millimeters or 11 millimeters of mercury, and up to 60 millimeters of mercury, blood with very low affinity. So we follow a similar protocol as we use with the stored blood. And we observe what happens at the microvascular level when the animals are transfused with blood that have a high affinity, simulating the stored blood, which loses its 2,3-DPG, and blood with very low affinity for oxygen that was willing to release that oxygen. Surprisingly, what we observe is that if the blood that we transfuse in these animals is willing to release oxygen, has a very low affinity for oxygen, what we observe after transfusion in anemic states is that the microcirculation constrict in response to the oversupply of oxygen from the red blood cells with high affinity, where in the red blood cells that are holding the oxygen, that are not releasing the oxygen, that mimic what happens when red cells lose their 2,3-DPG, there is no vasoconstriction, and that vasoconstriction consequently creates decreases in microvascular blood flow and decreases in functional capillary density. As I explained you before, the numbers of capillaries that are perfused with red blood cells. If the red blood has a very low affinity for oxygen, it produces vasoconstriction, and then we also have a decrease in functional capillary density. If we look at the interstitial oxygen levels of blood with all these different oxygen affinities, we also see that we can manipulate the arterial and the venular oxygen levels by changing the affinity for blood. And we can even enhance tissue oxygenation by decreasing the affinity of the hemoglobin for oxygen inside these red blood cells, and we are able to increase tissue oxygen almost to normal level by decreasing that oxygen affinity. However, if we go beyond that point, we create hemodynamic problems like decreases in blood flow that prevent oxygen from being delivered to the tissues. And so if we look at the oxygen delivery, after decreasing the hemoglobin oxygen affinity, we are compromising oxygen delivery and oxygen extraction. And if we increase the oxygen affinity, simulating the conditions what happens with red cells lose the 2,3-DPG, but we maintain all the other properties, the red blood cell, the formability, the everything else in the red blood cells remain intact, but now have a high affinity for oxygen. The oxygen delivery and oxygen extraction is increased, but the tissue oxygen does not necessarily, the tissue oxygen tension does not necessarily reflect that increase in oxygen delivery. So what will be the optimal P50 for a blood transfusion. It may be the opposite of what happens in the blood bank. It may be a blood with a decreased oxygen affinity that is willing to release oxygen, that may have a benefit in tissue oxygenation, but decreasing the oxygen affinity has significant effects in tissue oxygenation, and there is a disconnect between oxygen delivery and tissue at the microvascular tissue oxygen level at the microvascular level. Even if we remove the oxygen carrying capacity in the same animal, in the same model where we transfuse after anemia, and in order to remove the oxygen carrying capacity of the red blood cells, we oxidize the hemoglobin inside the red blood cells by transforming it into methemoglobin, and then we transfuse red blood cells without oxygen carrying capacity, and we compare that to a colloid. Technically, they should not be different. Since there is no oxygen carrying capacity in the red blood cells, they should work very similar. A colloid, the blood will be acting just as a plasma expander. First thing that we observe is when we use red blood cells or red blood cells with no oxygen carrying capacity at all, we are still able to maintain tissue oxygen level to a higher degree than if we use a plasma expander. If we look at the functional capillary density, we are able to, even without oxygen carrying capacity, we are able to maintain a superior function, a superior number of capillaries perfused with red blood cells relative to a colloid, just by having a higher number of red blood cells, just by having a higher viscosity, which is the main difference between a colloid and blood, is the higher viscosity. By increasing the viscosity of the blood, we may achieve similar benefits as increasing oxygen carrying capacity. And so in the case of the red blood cells without oxygen carrying capacity, we observe that their benefits are in terms of maintaining perfusion and maintaining microvascular blood flow come from increasing the viscosity of blood, which maintains the interaction between the flowing blood and the endothelium, which generates shear stress. And that shear stress on the endothelial cells produces relaxation of the smooth muscle and maintains blood flow, opens the blood vessels. And by opening the blood vessels, the blood flow increases, the oxygen delivery increases, and concurrent with that, the flow in the microcirculation. So in summary, we realized that all our studies point out that to maintain microvascular homeostasis, it's not necessarily is derived from the benefits in terms of oxygen carrying capacity that blood transfusions provide, but more is more related to the increases in hematocrit, and that blood transfusion, rather than increasing oxygen delivery, decreases microvascular perfusion, which compromises oxygen delivery at the end. And that overall transfusions don't increase the amount of oxygen in the tissue. They only increase the oxygen carrying capacity. Thank you very much.
Thank you very much. We have two questions. Is there a difference in managing patients, vegetarians and patients who eat meat? It is the question to the first presenter. Probably we can answer the questions at the end. Well, then, Tatiana Kirsanova, obstetrician, gynecologist, nephrologist, hematologist, all in one. Thank you. I'm not gynecologist, but yes, I am nephrologist and therapeutic doctor. And talking about the second question, there was the second question. I can comment on it. The question that is dedicated to why we have hepatoprotectors, I cannot answer for other doctors. I do not have conflict of interest, and I will talk only about scientific factors and probably about some historical issues. As nephrologists, I often go to different, and we always talk about anemia in chronic kidney disease, anemia in chronic kidney disease, but that doesn't happen often because different presentations are about the same anemia. But anemia is a regular friend of chronic kidney disease, and the approach is to correct anemia of paramount importance. And there are a few historic data. For the first time, anemia in chronic kidney disease was described by Richard Bright in 1836. Richard Bright is the father founder of modern nephrology. He described chronic glomerulonephritis, and it was called Bright disease at that time. And for the first time, he described that the patients who have kidney problems, they have anemia, and in long-term perspective, it exists, and dialysis exists for a long time already. This anemia was corrected with different transfusions, and it influenced with iron overburden, and it led to unfavorable outcomes. Anemia in chronic kidney disease is normocytar, nomochrome hyperproliferative, and back 10 years ago, we thought that anemia develops only when eGFR is less than 30 milliliters per minute. We know now that it's not true, because most of the patients, even with minimal kidney function disturbance, already have anemia. With progression of chronic kidney disease, anemia increases, and you see that hematocrit is associated with eGFR. It is logical, and it was demonstrated in a number of studies. So to say, anemia is something that depends on correlation, that has direct correlation to eGFR. And there are situations when we do not have any anemia, but when there is filtration lower than 60, anemia is already observed, and unfortunately, anemia is associated with poor prognosis for the patient. Moreover, there are many of unfavorable financial consequences, because this anemia is characterized with high expenditures for treatment of these patients. Here we see a chart where on the X on the epsilon axis we see different diseases, but we understand that there are different combinations, for example, hypertension and diabetes. When anemia is added, the mortality increases sevenfold. This is a very significant risk factor. When we talk about the general population, here we see cardiovascular mortality. It will increase with age, and a medium patient would, on the program hemodialysis, with lethality results. For a long time, anemia was defined with erythropoietin. It was considered that during many years, this active, massive usage of erythropoietin for all the patients with chronic kidney disease, especially with different therapies, it has led to different unfavorable effects. And there are certain additional factors that we can see. On this slide, I would love to draw your attention to the following fact. These are factor-induced hypoxia that also influences significantly the state of kidneys, and it would moderate the state of erythropoiesis. Kidney anemia is multifactorial. Not only erythropoietin production decreases, but it is absolute and functional iron deficiency. And it is also deficiency of folic acid, vitamin B. And we see also here decrease of the red blood cell life. They goes through hemodynamic filters, and uremia in interdialysis days provokes the suppression of erythropoiesis, and it also provokes the decrease of red blood cell life cycle. And we call it anemia of chronic disease, hemolysis and anemia as the result of the main disease, such as thrombotic angiopathy, and it leads can give the Coombs positive hemolytic anemia. And
these factors should be taken into consideration when we have patients with CKD. Erythropoietin mainly produces in kidneys, and its production is related to the oxygen saturation, and this is oxygen-dependent. Erythropoietin formation actually guides by the tissue tension of oxygen, if we can put it this way. So this cascade launches, supports each other, and actually, if we have a challenge at a particular level, then production of erythropoietin is dramatically reduced. We have to say that gene of erythropoietin is on the chromosome, and it expressed very differently, and the expression is actually regulated by hypoxia induction factor. And the option to influence HIF is the option of treatment which is currently discussed very actively. So in hypoxia, the production of erythropoietin is increased only with a high level. So any hypoxia will provoke high growth of erythropoietin, EPOs. We have to say that without erythropoietin, erythropoiesis is simply not possible, because erythropoietin influences cells' predecessors. And this active influence facilitates further cascade of transformation from pro-erythroblasts into reticulocytes, erythrocytes. So without erythropoietin, the process is not simply feasible. It is also not possible without iron, because without iron there is no erythropoiesis. That's why iron is the key element in the implementation of this erythropoiesis. It is clear that if we replenish the deficiency of erythropoietin just with EPO, plus to that concomitant iron deficiency, so we are not treating these patients, we are just replenishing. So iron deficiency could be absolute and relative. In absolute iron deficiency, the total depot is reduced and simply absent. But a functional deficiency in CKD patients is also frequently seen. So it's related to the fact that this depot is not effectively used. Or, for example, erythropoietin is too much externally, so endogenous, exogenous, and it cannot implement the function because this depot is not enough to organize normal cascade. So we have multiple. So there is renal replacement therapy. So now a few words about the treatment of this condition. So, right now we are welcoming erythropoietins, and this enthusiasm led to the fact that possibly we face the era when it's easiest thing to introduce EPO, and we introduce it very frequently without proper understanding what's behind that. Well, on the one hand, erythropoietin allowed us to get rid of this replacement infusion therapy, which was the standard of practice 20 years ago. Before that, there were heterogeneous options that also helped us somehow to overcome anemia in patients on hemodialysis. But on the other hand, with accumulation of experience, now we have some understanding that situation is not so simple. Here you can appreciate 4 clinical trials, NHCT, COAC, CREATE, and REACH. So they were all focused on the patients with CKD, those who have different anemias, and they checked out the outcomes. So unfortunately, such clinical trials did not show any positive results for the higher level of hemoglobin rates, and some of them were even hazardous. So higher target level of hemoglobin were related to the dramatic rate of adverse events like the vascular thrombosis, strokes, and other cardiovascular events. So it's very difficult to say why all that happened. And we discuss a number of hypotheses, and one of them is actually the fact that the erythropoietin EPO, which comes from the outside, has particular pulsative order. So that means it's either too much or too little. So all that creates vasoconstriction, which is moderated by endothelin, then hypertensive complications, and also there are other hypotheses. So in any case, high rate of erythropoietin as well as high rate of hemoglobin in patients with CKD is not good, and it should be avoided. Well, before we link anemia with CKD, we have to examine the patient, and we have to exclude all previous options of such anemia. So the level of erythropoietin should not be used for differentiation of renal anemia from other reasons, because it can be not sufficient for this level of erythropoiesis, but we do not have this opportunity to say whether erythropoietin is sufficient or not if we check just one parameter. So in any case, it should be complex approach. So what drugs from erythropoietins is shown here? So we have short action, so then recombinant human erythropoietin and garbapoietin alpha, which is the prolonged extension half-life product. So they are more or less equivalent, but garbapoietin has high valency. So pharmacokinetics, pharmacodynamics that allows to moderate the process of erythropoiesis and to stay long in the organism. So the target level should not be higher than 11.5 nanogram per deciliter or 115 gram per liter. So at the same time, we should clearly understand that the so-called terminal and stage renal disease, terminal CKD and stage renal disease, and this level should be varied from 10 to 11.5. So these are very clear levels. So don't reach 13, 14, 15 as sometimes they try to reach to improve the quality of life. And once again, I would like to draw attention to ferritin levels. So sometimes we forget about it in such patients. And all in all, if CKD stage 1 to 4 ferritin is higher than 100 is optimal and sufficient, then in patients with renal replacement therapy, ferritin could be higher than 200 or even higher. And this is not something pathological. This is normal. This is correct. So target levels of iron, so they can vary from these or those situations. But in any case, we can even discuss the replacement intravenous administration of iron in such patients, and it will not be a mistake, because before you treat anemia with erythropoietin, you have to be absolutely sure that there is no iron deficiency. So, and there are special situations when erythropoietin is introduced in higher doses, and KDIGO gives us absence of concentration of hemoglobin after the first months in particular doses. And as far as I understand, we need particular approaches. On the one hand, it can be inflammation. So if we see that hyperreactivity, we have to exclude all previous reasons, anemia, including inflammation, or this relative iron deficiency. So the other factors that can somehow be related to the hyperreactivity presented here, and the cascade here is testosterone deficiency and ACE inhibitors administration that is frequently administered, and there are patients with transplanted organs and they're getting immunosuppressive treatment. that suppresses erythropoiesis. So here there is particular coverage, and for the nephrologists it's okay. And they need to understand what these anemias can be provoked by and why such hyperactivity is supported. Well, here you see new designs. So at this very moment, they're actively implemented into practice. So this is the stabilizers of HIV, IF, and activators of erythropoiesis. So now a few words about the specificity of anemia in different indications. For example, in renal polycystic disease, anemia develops later because the cysts, they are mechanically suppressing the lesions of erythropoiesis, and they give high growth of erythropoietin. Transplantations of kidneys, so that's another area. So we, as a Center of Obstetrics and Gynecology, we managed more than 90 pregnancies in patients after nephrotransplantation. And this is interesting to pay attention to something else. If in general population it is believed that anemia is not related to the negative outcomes, so whatever we try to do in this correlation of anemia and the development of preeclampsia. So, and in this group of patients, we do see this link, and it is pretty clear, and it is characterized by unfavorable gestational processes like preeclampsia. And also it appears to be that in anemia in the second trimester, there is a chance to get worsening of graft rejection and worsening that would influence the outcome. So all in all, anemia in case of CKD, especially in pregnancy, that's an important factor that again requires special attention. Again, it should be properly managed and followed up. Unfortunately, we see very late patients, so they have anemia, they don't pay attention. Because actually we got used to that. This is chronic glomerulonephritis, this is grafts, so we got used to that. So wrapping up, anemia is very frequent complication of CKD and very frequent partner related to high cardiovascular mortality and all-cause mortality. So anemia pathogenesis is multifactorial. So it is not just the monofactor disease. So it's not just the deficiency of erythropoietin. So there could be other mechanisms and influencing factors. And before you administer any treatments that stimulate erythropoiesis, we need first to study and exclude possible curable conditions like iron deficiency or a deficiency of vitamins. Well, thank you very much. So all the questions would be transferred to the end of the session, and now the next presentation will be made by Professor Donat Span. Time matters. Why do we need urgent needs in coagulation management at the point of care? And this is the recording. You're welcome.
Hello, everybody. This is Donat Span from the University Hospital in Zurich, Switzerland. Today I'm talking on the following matters, namely time matters, why there is an urgent need for point-of-care coagulation management, a focus on trauma and cardiac surgery. First of all, I'd like to share with you my conflicts of interest. Better, it's the spectrum of my activities. I do consult companies. I'm the co-chair of the European Trauma Treatment Initiative. I do consult universities, the US Department of Defense, and also the professional societies. In addition, I have lots of interactions with companies and foundations. I have two sections of my presentation. The first is with trauma, and the second one is with cardiac surgery. So the European Trauma Treatment Guidelines, they have been published 5 times already, and we are currently at the 6th edition. And until now, they have been cited in scientific literature more than 2,200 times, and they were downloaded like more than 700,000 times. So these guidelines are very important. And we recommend that routine practice includes the early and repeated monitoring of hemostasis. And this includes traditional laboratory values, including fibrinogen, and or point-of-care devices or methodologies like viscoelastic methods like ROTEM or TEG. So we in Zurich, we use both traditional lab values plus ROTEM. In terms of antifibrinolytics, particularly tranexamic acid, we recommend, and this is one of the few grade 1A recommendations, that tranexamic acid be administered to trauma patients with bleeding as soon as possible and whenever possible within the 3 first hours after injury. The dose is 1 gram and a follow-up infusion of 1 gram over the next 8 hours. And we also recommend that the tranexamic acid is also already given prior to the hospitalization en route to the hospital on the transport or on the scene already. Again, the same doses of 1 gram. And once the patient is in the hospital, in the initial management of the patient, we give the option of 2 potential strategies. One strategy is FFP and RBCs in a blinded version, a ratio 1 FFP to 2 RBCs. And personally, I think this is a lousy version. The second version is much better. Namely, we give fibrinogen concentrate and RBCs, and then we also do initial coagulation monitoring with laboratory tests and the ROTEM, and go from there what we find in an individualized, goal-directed manner. And this recommendation, we recommend the resuscitation measures be continued using a goal-directed strategy, as I said, based on viscoelastic testing and standard laboratory tests. In terms of fibrinogen, because this is a key element in trauma patients, we see that fibrinogen needs to be replaced according to viscoelastic testing, or if you measure it in the laboratory at the concentration below 1.5 grams per liter. So this 1.5 grams per liter is the lowest concentration at which there is no functional fibrinogen deficiency. So what is the outcome if you're doing patient treatment like I described? We did this study in Zurich 2-3 years ago. We compared between the first period where we had a traditional management, which means that everybody did what he or she thought would be right, versus the second period where we had a clear goal-directed coagulation and transfusion protocols. And we looked at the observed versus TASH predicted massive transfusion rate. We looked at transfusions and clinical outcomes. And this was the treatment algorithm. So a low fibrinogen was detected by ROTEM with a FibTem below 7 millimeters. And what did we do? If we did find such a situation, we gave 2 to 4 grams of fibrinogen IV. If we detected fibrinolysis, we gave tranexamic acid. If the bleeding was ongoing in factor 13, this is lab value below 13. The factor 13 was below 60%, then we gave IV factor 13, 15 units per kilo. If we had platelet count, which was too low either in the XSTEM or the platelet counts, we gave platelets. If the INR was higher than 2.3%, we gave 4-factor PCC, and if the factor 5 was below 20%, then we give FFP. So what did we find? So in the first period, where everybody in our center did what he or she thought would be right, we had a TASH prediction of massive transfusion of 12.1%, and effectively, we also had a massive transfusion rate of 12%. Now, in the second period, where we had the algorithm, the expected massive transfusion rate was 7.5%, but we only had 3.7%. So we could reduce massive transfusion by 50%. In terms of transfusion of RBCs, FFP, and platelets, you can see within the first 24 hours, with the protocol, we had 2 RBCs versus 5 before, so much reduced. FFP from 3.4 to 1, and platelets we gave about the same. And more clinical outcomes, you can see here ICU length of stay was tremendously reduced from 10 to 7 days, and also hospital mortality, the ventilatory support was reduced from 7 to 3 days, and all this resulted in an in-hospital mortality reduction from 33 to 22%. So highly successful in trauma. Now, in cardiac surgery, we all know that coagulation is important. Most bleedings, however, postoperatively are not due to coagulopathy, but rather due to a mechanical cause of bleeding, namely a hole somewhere in a vessel. But it needs always to be distinguished between a mechanical reason for bleeding, namely a hole in the vessel, versus coagulopathy. And this was looked at, or it was investigated, of whether such a coagulation algorithm, similar to the one I just presented to you that we used in trauma, whether this was also efficacious in cardiac surgery. And the first important study on this was done already 10 years ago by Klaus Gerlinger, and they also compared a period before the introduction of such an algorithm with the period afterwards, and they looked at transfusion, massive transfusion, re-exploration, and thromboembolic complications. And you see, most is based on the ROTEM analysis. So, for example, if the maximum clot firmness in the FIBTEM is low, then, of course, this indicates that there is still too little fibrinogen, so you should give fibrinogen. If the A10, the XTEM is too low, this is a platelet problem, so you should give platelets. And very important, you know, it's like a cycle. So you do a first ROTEM analysis, you find the different results, you interpret them, and you give whatever this condition requires in the individualized manner, and then you re-examine the ROTEM to check whether the treatment you gave to the patient was successful. You want to give these drugs, be that protamine or fibrinogen or PCC, in the lowest dose possible. So you want to check whether the dose you have chosen was sufficient, or whether you have to repeat the same dose or a lower dose. And in addition, of course, you all know that the situation is very dynamic after cardiopulmonary bypass and cardiac surgery, and therefore also the coagulation may change over time. So you do an analysis, a treatment, and you recheck the result with the same ROTEM as you did before. So the author found that due to this algorithm, any blood products was reduced from 52% to 42%, RBCs were decreased from 50 to 40%, FFP was not given anymore nearly, and there was a few more platelet transfusions necessary. Of course, fibrinogen, they gave much more, and PCC also. Now, in terms of clinical outcomes, massive transfusion was reduced to half, re-exploration was reduced to half, and composite thrombotic adverse events were reduced also nearly to half. So these authors then found in cardiac surgery that following such an algorithm reduced tremendously the number of blood products given and reduced also clinically adverse outcomes. The study was then more or less repeated a year later as a prospective randomized trial at 2 centers, not only in Essen but also in Frankfurt. And they had a conventional coagulation algorithm versus an algorithm that we have seen before, a ROTEM-based algorithm. And the study was planned to be performed in 2 times 100 patients, but it was terminated early after the first 100 patients at the planned interim analysis. So they found in this prospective randomized multicentric study that RBC transfusions, the percent was 98 in conventional, 84 in the ROTEM. The numbers of RBC units given was 5 down to 3, FFA units 5 down to 0. Then platelets were about the same, a little less here. Fibrinogen was the same, and PCC was reduced, was also about the same. Factor 7A was not given anymore nearly in the ROTEM. And interestingly, they also analyzed the cost of chemotherapy, and the cost of chemotherapy was reduced from 3,100 euros down to 1,600 euros. And this, of course, was also highly statistically significant. Now, in addition to this, patients in the point of care group, the algorithm group based on ROTEM, had less postoperative bleeding in the first 6 hours, in the first 12 hours, and in the first 24 hours. And in addition, and more importantly so, survival over 6 months was much higher, significantly higher in those patients treated according to this algorithm based on ROTEM and factor concentrates versus those that were more traditionally treated. This was then also the reason why the IRB stopped the study after 2 times 50 patients, because they said if mortality is different, then we are not allowed to treat the patients on a conventional way anymore. So this is an important meta-analysis of thromboelastometry-based coagulation management in cardiac surgery on 8,000 patients. And they looked at transfusion outcomes, re-exploration, acute kidney injury, postoperative and thromboembolic events, mortality, and length of hospital stay. And you can see here the odds ratio, that's where we look. Let's say, for example, acute kidney injury. This is significantly reduced in those patients treated according to ROTEM-based algorithm. Thromboembolic complications were significantly reduced, namely down to half, if the patients were treated according to ROTEM-based algorithm. Re-exploration rate was also down to about half. Transfusion in general was reduced, RBCs were reduced, FFP was very much reduced, and also platelets were reduced. So these are all benefits of a transfusion algorithm based on ROTEM and coagulation factor-based treatment concepts. Now, length of hospital stay or ICU stay was reduced, but did not achieve statistical significance, but nothing went into the wrong direction. So ROTEM-based and factor concentrate-based coagulation algorithm in cardiac surgery is highly successful. So the conclusions are that coagulopathy is frequent after major trauma and in cardiac surgery, and immediate viscoelastic coagulation monitoring is key for a successful, individualized, goal-directed coagulation algorithms, and treating patients according to viscoelastic coagulation monitoring-based algorithm, rather than relying on a one-to-one treatment, is key to success. And compliance with the European trauma treatment guidelines and or viscoelastic measurement-based coagulation algorithm in cardiac and major surgery improves survival. Thank you so very much for your attention, and I'm looking forward to discussing my presentation with you in the discussion sessions. Thank you very much. Bye-bye.
Спасибо большое. Скажите, а в зале можно?
Thank you very much. Could you please raise your hands who is using TAG or ROTEM? Intra-op, TAG or ROTEM? I'm asking because the next presentation would be done by Dr. Klaus Gerlinger from Germany, who would speak about the treatment of bleeds and coagulopathies. So most probably we will see more details and more algorithms on ROTAM-based approaches. Please start the recording.
Welcome. My name is Klaus Görlinger. I'm from Essen and Munich in Germany. And the topic of my talk is the management of bleeding and coagulopathies. I worked 26 years at the University Hospital of Essen in Germany, and since July 2012, I'm the Global Medical Director of TEM Innovations in Munich, Germany, the company who is producing the ROTAM device. If we have a significant problem, it's very important to ask the proper questions. And that is in bleeding management. First, why does my patient bleed? Second, how to fix it. So first option is just to refill with blood, or the second option, and think the better option, is to close the holes in order to stop the bleed. And third, the question is, why are we performing viscoelastic testing? So we have to understand a ROTAM-guided bleeding management as an important point of the second pillar of patient blood management, which is minimize bleeding and blood loss. And again, patient blood management is an important part of patient safety, which is not a new idea. This was already stated by Hippocrates 2,500 years ago, that besides we want to cure a patient, it's also very important to avoid additional harm. So patient blood management is not about blood transfusion. It's designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in order to improve patient's outcome. And this is also stated in this paper from 2 years ago, that again, patient blood management is not about blood transfusion. It's about patient's own blood and patient's outcome. And it's in particular not just about red blood cell transfusion, because we should also be restrictive with the transfusion of the so-called yellow blood product, which is plasma or platelets. Because we know it's daily practice to substitute yellow blood products without a well-defined clinical indication. So again, a restrictive transfusion also of this blood product is very important, because we know that the inappropriate use of plasma and platelets can increase the risk for allergic and non-allergic serious hazards of transfusion, like TRALI, TACO, and transfusion-associated immunomodulation. So they should be used in a goal-directed way. The goals are transfusing the right blood product at the right time, to the right patient, and for the right indications. And we should definitely limit unnecessary exposure to these blood products in patient blood management. And there are an increasing number of well-published papers that, again, the inappropriate use of blood products here, of plasma transfusion in PPH, is associated with significant adverse outcomes. And we see here what happens if we give plasma transfusion within 60 minutes, 2 hours or 3 hours after the beginning of postpartum hemorrhage. And here we see that if we give it quite early, the odds ratio for composite adverse outcome, which means mortality, hysterectomy, and the need for arterial embolization, is 1.5, so 50% higher in the group with plasma transfusion. If we transfuse it within 2 hours, it even goes up to 1.73, and within 3 hours, it's 2.47, so nearly a 2.5-fold increase in adverse outcome. So this doesn't really support the use of plasma in postpartum hemorrhage. And also when we look at trauma, if we give plasma transfusion in patients who finally don't need a massive transfusion, there's a 12-fold increase in lung injury, a 6-fold increase in multiple organ dysfunction, and a 4-fold increase in pneumonia and sepsis. And when we go to cardiac surgery, there is even a Cochrane analysis based on 15 randomized trials, and the outcome was that transfusion of fresh frozen plasma was inferior to placebo, with a 2.5 times higher need for red blood cell transfusion compared to a patient who did not receive plasma. So what's about platelets? This is a meta-analysis published in Transfusion 2 years ago, looking at several studies. What is the effect on outcome by platelet transfusion in patient with traumatic brain injury and concomitant antiplatelet use? And we see that this was associated with a risk ratio of 1.5 for mortality. So there's an increase in mortality by liberal platelet transfusion. And this was confirmed by the PATCH randomized trial, also looking at platelet transfusion in patient with spontaneous cerebral hemorrhage associated with antiplatelet therapy, where the odds ratio for worse outcome and mortality was 2 times higher in the patient population with platelet transfusion. And we can also move from Lancet now to the New England Journal of Medicine. Again, a randomized trial about platelet transfusion thresholds in neonates, and they compared a liberal threshold transfusing platelets below 50,000 per microliter compared to 25,000 per microliter. And we see again that the odds ratio for mortality was 1.57, so more than 50% increase in mortality in the patient population with a liberal platelet transfusion. So accordingly, the editors came to the conclusion that it's not anymore to say less may be more, we have to say less is more. So a more restrictive transfusion of platelets, and as shown also for plasma, seems to be superior to a liberal transfusion strategy. That means we also decide, do we want to use a one-fits-all approach, or do we have to move to a goal-directed way, which means precision medicine? And the concept of a ROTEM-guided patient blood management, again, is to administer just the right hemostatic drug or intervention in the right dose, the right time, and the right sequence. And we should avoid any inappropriate transfusion, whether it's red blood cells or plasma or platelets, and we can use the very high negative predictive value in ROTEM algorithms, which excludes reasons for bleeding, and we should not treat numbers. So that means if we talk about ROTEM algorithms, we talk about not to do algorithms. So they guide transfusion of blood products or hemostatic interventions in a restrictive way by excluding reasons for bleeding. So this follows the concept of precision medicine, which means we first have to do a diagnosis, but of course we have to do this within a very short time in severe bleeding, so talking about 10 to 15 minutes. Then we should perform a targeted treatment, and then we have also the chance to improve outcome. And already some years ago, there was a consensus meetings here, one about trauma. What is the best way to do the diagnosis and how to link the diagnosis with a therapeutic intervention? And this is also very important, has to be setting specific. So coagulopathies in cardiovascular surgery are not the same as in liver transplant, trauma, or obstetrics. And therefore, the algorithms have a similar concept. But when you look at specific cutoff values or medical decision limits, they are setting specific and not based on reference ranges. They are based on big observational trials with running a ROC curve analysis to see which cutoff value has the highest sensitivity and specificity to predict bleeding and transfusion in this specific setting. And that's just an example. That's our evidence-based ROTEM A5 postpartum hemorrhage algorithm. It starts, like all the algorithms, with the clinical situation. This means if there's no bleeding, we don't have to treat numbers again. Then we check if there is any hyperthrombolysis with a need of administering an antithrombolytic drug. Then we are checking clot firmness, which is mainly based on fibrinogen levels and platelets. And if we detect a low fibrinogen by the combination of a low XTEM and a low FibTEM amplitude, then we can even calculate the amount of fibrinogen concentrate or cryo which we need to reach a specific target. Then we are looking at thrombin generation, which is mainly looking at the extrinsic pathway, but there are also some rare diseases like an acquired hemophilia, which can happen during pregnancy, where we have to consider also the intrinsic pathway. And after each intervention, we give the intervention 10 to 15 minutes time to work. And if there's an ongoing bleeding, we have to take a new blood sample and run the algorithm again. And usually within 1, 2, 3 runs, we can fix the problem. Of course, also in Russia, there are still issues with postpartum hemorrhage, like in nearly every country. And what we see is that the best outcome is in the hospitals, which usually take care for patients with moderate risk, but really high numbers. So nearly 2/3 of all deliveries are managed in this hospital, which results in a relatively low maternal mortality, with about 6 deaths within 100,000 live births. It's not a big surprise that the hospitals who take care for the high-risk pregnancy have some increased mortality. I think this is based on the patient population. But when we look at the hospitals who take care for the deliveries with a low risk, it's even higher, with 11 deaths per 100,000 live births. And this may be due to the fact that postpartum hemorrhage is in 50% without any risk factors. So maybe these hospitals are not so much prepared to deal with this problem and might not even have viscoelastic testing available, or don't have even an algorithm. So what's important? Time management is important. So we need the information in severe bleeding within about 10 to 15 minutes. And that is something important to organize within the hospital. Again, we have to look at fibrolysis management. This is usually quite easily to detect with viscoelastic testing, cannot be detected by standard lab tests. One of the key points is looking at clot firmness management, where the combination of XTEM and FibTEM is very helpful to see that here in this upper case, a low fibrinogen is the main issue, where in the lower version, we see that FibTEM is quite strong, so reduced clot firmness in XTEM must be based on the thrombocytopenia. Thrombin generation is the next step, where we just look at the clotting time in XTEM, and because this is not so often, except in cardiovascular surgery, heparin protein management has to be considered too. But also, finally, we don't want to overtreat our patients, so we don't want to result in a hypercoagulability, because that can be associated also with thromboembolic complication. What we see here would also be a typical pattern of a COVID-19 patient. So what is the evidence telling us? Already in 2016, there was a Cochrane analysis based on 17 randomized trials, including nearly 1,500 patients, showing that viscoelastic testing reduces mortality. And that was in particular true for studies using the ROTEM device. But even if we take TEC and ROTEM together, there's still a nearly 50% reduction in mortality in severely bleeding patients. And this has been confirmed by a new meta-analysis from the last year. Now it's 21 randomized trials and nearly 9,000 patients. And still, again, the TEC studies are borderline, but the ROTEM studies, or the combination of ROTEM TEC, again, has a significant reduction in mortality. When we look at thromboembolic complications, we see that because the algorithms and interpretation are a little bit different, and TEC tech algorithms usually favor plasma and platelet transfusion, there is a trend to increase thromboembolic events, where ROTEM algorithms, which more focus on fibrinogen replacement, antifibrolytic drugs, and maybe even protein complex concentrate, show a trend to reduced thromboembolic events. What may be even more important, in particular for long-term outcome, is that when we look at the incidence of acute kidney injury, we don't see a clear signal in tech studies, where the ROTEM studies show a more than 50% reduction in acute kidney injury, which again is important for long-term outcome. This has been shown here in this study, looking at the relationship between acute kidney injury and long-term outcome in cardiac surgery. And when we look here just at the 5-year survival in the patient population here with the blue line without any acute kidney injury, the 5-year survival is a little bit higher than 90%, but this drops down to 70% if there is any acute kidney injury. So the avoidance of acute kidney injury is very important and makes a difference between 90% and 70%. So 20% of our patients die within the next 5 years if we don't avoid acute kidney injury after cardiac surgery. There are also new data from last year from the Eastern Association for the Surgery of Trauma from the US, did a meta-analysis about the management of trauma-related bleeding. And again, here we see a 25% reduction in mortality in the group with scholastic testing. So what is the precondition of clinical effectiveness of goal-directed therapy? It's good to have a ROTEM available. It's important that the clinicians get the results within 10 to 15 minutes. Of course, there are need for education, how to do the interpretation of the results. And our experience is to implement simple algorithms. This is very effective for decision making. And that, of course, also means we have to change transfusion practice to improve patients' outcome. So the key message is keep calm and stop the bleeding. And thank you for your attention.
Dear colleagues, I'm happy to give the floor to Professor Galstyan. The role of hemostatic control in patient blood management. Good afternoon, distinguished colleagues. Well, it's very difficult to say something new after Klaus, because he is really greatest expert and greatest speaker. And we have very close topics today. I will speak about the role of hemostasis in patient blood management. So PBM, we talk about it all day long. So that's a number of indefinite parameters. And first, our steps reduce blood loss, then improve anemia, and also we have to pay attention to hemostasis. So we are waiting for these parameters and for this time. And I think my presentation is devoted to this today. So that's hemostasis. It was one of the most important approaches in patient blood management. If we speak about the influence to hemostasis, so in the hospital where there are massive surgeries, we can check whatever we like. So in the large cohort study, it was shown that only in 0.48% of cases, they found true changes of hemostasis. And actually, you never check everything. There is always something you miss, or there is something you don't see. So, the stone 14 is never seen. And actually, your 14th stone, like in Kyoto task, would be always like that. And this 14th stone will pull on your head during the surgery. So what we need to do is to do the survey of the patients. So, and this is the data of European Society of Anesthesiologists to prevent hemostatic dysfunction. So one of the important steps is the survey, so a questionnaire of the patient. And it is even more important than simply examine whatever you like. As you can see, first of all, they recommend to use questionnaires. Well, these questionnaires are multiple. So there are very simple things. So Hemstop is one of the popular in Switzerland. So that's how you can easily find any types of bleeds, any menorrhagias, any epistaxis, any postpartum, any bruising, whatever. So, and already it may guide you which hemostatic parameters should be checked properly. So I have to say, by the way, that each of these questions has particular number of consequences. So more than 2%, cutoff more than 2, its sensitivity and specificity more than 90%. And specificity and sensitivity is 89 and 98 correspondingly. But if just APTT or proton beam time, the sensitivity is 26, and there are not few such scales. So this is BAT scale, ISTH BAT. So this is multiple scale, multiple domains that are included. And here you see that with hemostatic disorders versus the large-scale examination. Even if you check the patient, you cannot check everything. So there are particular screening tests. So these are simple things than APTT and PT. So I'm not speaking about platelets now. So depending on what you find, you will be guided by your findings. So normal PT, normal APTT, then normal factor VIII and von Willebrand, then you can check other factors. But if PTT, APTT or PT is not normal, possibly something is changed. Or it could be a lupus anticoagulant or inhibitor of the factor VIII. So it can be normal APTT, but prolonged proton beam time, possible deficiency of vitamin K, or possible renal dysfunction. So this is very simple algorithm, and then finally it may lead you to this or that intervention. Do we need to screen all the patients for all these parameters using VISTA elastography? Well, in fact, yes. Because sometimes it could be very rare conditions, somewhere there, and you think it never comes to you, but it will. So we have normal patient flow, and actually it's easier for us, because normally we deal with the patients with already existing diagnosis, and the biggest challenge happens in the real practice. So you ask, how frequently do you study von Willebrand factor? So they simply don't understand you, because in majority of hospitals they don't check von Willebrand. But simple thing, aortic stenosis, very popular surgery. So the bigger is stenosis, the higher is the probability of von Willebrand syndrome development due to high pressure. There is tension, there is stenotic valve, then multimers are ruined, and we see the deficiency of von Willebrand factor at the end, and then bleeding patients during surgery, if this is aortic stenosis. So they're all with syndrome von Willebrand. It's either cryoprecipitate or factor VIII enriched plus factor von Willebrand. So there is a direct correlation between the severity, let's say aortic gradient, and the concentration of von Willebrand factor. So when I ask how many cases were there, for example, in cardiac surgery, and they say, well, we use plasma, it helps. So that's another case. This is case of Professor Lubnin. So this is a patient, age 51, who was electively hospitalized with a giant meningioma of the nostrils. And actually, it was the fatal outcome. And then we see that during the surgery, there is hemorrhagic syndrome. So patient had von Willebrand disease. And we see such huge hematoma here. And that was a discovery for neuroanesthesiologists, that the prevalence of von Willebrand in the population is 1%. 1%. If today we have 100 people here, one of you has von Willebrand. That's statistics, or maybe two. And these people, they normally underdiagnosed. Or another simple example, elderly patient goes to the underground and there was a compression by door, so huge hematoma. So have a look at that. So that's acquired form of inhibitory hemophilia. So it can be seen in a totally normal elderly patient. So these issues of pre-op diagnosis, they are of extreme importance. So the same here. This is the same patient who comes for surgery because of liver metastasis. And we see prolonged INR 10. You think it's a mistake. So they're asking, will we take for surgery? I'm saying no. We're checking actually elderly patients with cancer, with liver metastasis. But the activity of factors 7.1%. So this is hyperprolactinemia, acquired or congenital. And they exist and they go to normal surgeries. So how do we treat? Definitely in case of blood loss, transfusion can be considered, although Gerlinger was showing us that plasma is bad, but actually the most frequent media which is used is plasma. In massive blood loss, we will try to use particular ratio of platelets, plasma, erythrocytes 1:1:1, but at the same time, we more and more look at the concentrate and targeted treatment, goal-oriented treatment. So it should not be like a sniper's shot, because actually this is an important point, and here it will be more effective. And non-systemic blood transfusion will cover that. So 1 liter, 2 liters of plasma will cover that, but it never happens. So how can we diagnose it? So that's exactly what Klaus said before. That's a point of care. That's portable, next to patient bed. Coagulometer, well, possibly it's a rather big one, but it is in the lab, 3 minutes from the patient bed. So in order to get the response on coagulometer, so it takes 1 hour. So you take this blood, then centrifugation, 15-20 minutes, then you put it in the machine, then you get the result. But in raw term, you see that it's just 23 minutes. So you reduce it twice. It takes 25 minutes. So, and it's important during the bleeding in order to make a decision about this or that type of intervention. What can it give to you? So I'm not speaking about tag and draw terms. So it's the same to me now. But I'm speaking about the point-of-care machines, so it allows us to be there, so improve the results versus traditional approaches. To reduce transfusion rate, again, this is targeted influence here, and the interval of plasma, and then transfusion, then factor concentrate, and then reduction of mortality. As you can see here, that's exactly what he told you. That's a change of the concept using more precise management. And if we see what clearly is ruined, then we can use concentrates of factors, but not plasma administration. Fibrinogen is lost very fast. That's the only factor which is measured gram per liter, not millimole, not micromole, but gram per liter. It's first to be lost. So how we can correct hyperfibrinogenemia? In European guidelines, you just heard it. So that's fresh frozen plasma, cryoprecipitate, and fibrinogen concentrate, and nothing else. So these are the guidelines that we have, and this is the transfusion of in our country, cryoprecipitate. 1 dose of cryo contains about 250 milligrams of fibrinogen, and standard level, if you extract from particular deviations, so it's about every 5 kilos of body weight, 1 dose of cryoprecipitate. In case of coagulation disorder, so this is prolongation of INR. So normally it's recommended prothrombin complex concentrate and vitamin K intravenously, and normally it associated with vitamin K dependent factors in perioperative bleed. So prolongation of INR more than 1.5. So we have 3-component and 4-component prothrombin complex concentrate, PCCs. So we have everything what we like. So here they are. So we have 3-component and 4-component, factor 2, factor 9, factor 10, and others. Tranexamic acid, that has already been mentioned, can be used both preventively and for the therapy. Hyperfibrinolysis currently. So it's used by rotational elastometry and thromboelastography. So that's the most effective way to measure it. And you see that ml more than 3%. And the number of situations you can model, you can simulate the injection of the tranexamic acid in uptime tests. So as soon as you do it, you immediately add on analog. of tranexamic acid, and then you get the prolongation of the amplitude of the clots. So that means that's fibrinolysis, and it allows you to reduce the severity of hemorrhagic syndrome. So this is the way. This is the way. So patients with acute leukemias, so-called bloody leukemias, and this is hyperfibrinolysis, 54 cases. And it has not just theoretical but practical application. So our patients with acute promyelocytic leukemias, CT, you see intrabrain hematoma, and the hemorrhagic content goes into the left ventricle. And prothrombin by quick 55, fibrinogen 0.7. So just fibrinogen and plasma should be corrected, and you see very good outcome. Factor 7. We do not recommend to use recombinant factor 7 activated in preventive purposes because it facilitates the risks of thrombosis with fatal outcome, but it can be used off-label in the treatment of massive blood loss. And actually, if you recollect, in the British guidelines, it's not there. In European guidelines, it's also not there. So it's off-label, completely off-label. But in specific cases, it's not like the first-line treatment, not as prevention, but a resolution. And this is the uncontrolled perioperative bleeding, and you see the use of low-dose recombinant factor 7A for uncontrolled perioperative bleeds. You see low doses were used in 55 patients in China. So the patients with uncontrolled bleeding with a low dose of factor 7 could be used with traditional methods are ineffective. So, and you see here that off-label treatment gave positive outcome. So another story, it's a local use of different factors. So first of all, we speak about tranexamic acid. So here you see this is Cochrane's study about topical application of tranexamic acid for the reduction of bleeds. 29 trials, more than 2,500 patients, local use of tranexamic acid reduced blood loss by 29%. And this is significant. And this is significant. So local use also recommended in cardiac surgery. So this is another area of use. This is recombinant factor 7 locally in bleeds. So this is hemorrhagic syndrome. And this is our experience of using recombinant factors. So all that allows us to resolve the bleed. The same neurosurgeries, and the local use in case of bleeds of fragments and tamponades of the brain. So we can use napkins, and this is international experience, topical application of recombinant activated factor 7 during cesarean delivery for placenta previa. So publication in Obstetrics and Gynecology of 2017, and this is napkins with recombinant factor 7. So again, cardiac surgery, and this is very interesting case. So female, age 90, so aortic valve replacement, and we see that massive blood loss, so couldn't be for taken surgery, then pericardial drain. So we use 20 doses of cryo, 2 doses of fresh frozen plasma, and 1 dose of platelets, non-stable, and then recombinant factor 7A. So implementation of patient blood management in general allowed us, in combination with tranexamic acid, point-of-care methods, that means thromboelastography, thromboviscometry, plus cell savers, all that reduces the risks of transfusions of red blood cells, which is significant. And these are not just the risks of transfusions, it's also cost-effective for major surgeries. Moreover, health economies of patient blood management, this is international data, cost-benefit analysis based on meta-analysis. You see, that's the saving, almost 2 million euros for 100,000 patients. But the most important is the other one. PBM is not about blood transfusion. It's about patients' outcomes. It's about not transfusing, but improving the results of treatment. Thank you very much for your attention. Thank you very much, Gennady. And let me introduce the final part, which is a panel discussion. And James Ibis is our moderator. Do we have enough reasons to consider PBM a new standard of treatment? You are welcome.
It's an honour to speak on this conference. I'm a retired haematologist. To give you an idea of how old I am, first-year medical student when Yuri Gagarin went into space. And it's very clear in my memory. It's quite late in Australia at the moment, and we're just going into winter, but nothing like the winter you'd have in Moscow. So to address this question of do we have enough evidence, being a haematologist, I've always thought the evidence was there. In haematology, we clearly want to identify any problem and manage it, usually with goal-directed therapy. So I don't need any convincing, but I'd like any questions people would like to ask, but I'd first like to ask Michael Auerbach. I think being the only, are you on, Michael? I think he's muted. I was going to say, we don't have a lot of hematologists involved in patient management. It's interesting, most of the practice of patient blood management is done by clinicians in various specialties. So I'd be interested in any of the people's comment about the role of hematology in patient blood management. All quiet. Michael Auerbach. Well, Donna, can you suggest whether you need a haematologist?
James, I'm sorry, the sound quality is really very, very low.
Can you hear me? Can you hear me?
I can hear you well.
Okay, then I'm answering James. I'm having trouble with this.
Okay, Michael, if you could tell us, being the only haematologist talking, do you find the same problem that there are not a lot of haematologists involved in patient blood management?
Most hematologists in the United States are not particularly interested in patient blood management. It's an anesthesia and surgery problem. I became interested with my work with Arius Shander initially, and as a result of the role of intravenous iron, it became a significant part of my work.
So in going back to the question of do we have enough evidence, when we talk about levels of evidence, we tend to be dependent on randomized controlled trials. Yet my view is that most of the problems we're dealing with, there's really deterministic causation, and I get very concerned that people are requiring randomized controlled trials for treating various obvious conditions that we have a very good understanding of. Klaus, you're nodding your head.
Yeah, I think what we need finally is a mixture between randomized trials and big observational trials, because of course the randomized trials can answer a specific question, but I think they are quite often have a lot of inclusion and exclusion criteria, looking very specific at a patient population. I think that the big observational trials, as Donat showed from his hospital, as we did in cardiac, even then show if you can transfer this knowledge into real practice. And I think finally, again, we need a mixture. And we were just looking recently on all the interventional trials done in trauma, for example, with visceral testing and looking at mortality. It's overall in between 22 trials, including nearly 9,000 patients. And quite interesting, even if you separate military trauma and civil trauma, it ends up always with a risk ratio of 0.7 something to reduce mortality. So still, of course, we need more evidence, but it depends also on the setting, how difficult or easy it's to do. Of course, we have the highest evidence in cardiovascular because that's planned procedures. It's much more difficult to do the same as a randomized trial in trauma and obstetrics. But again, I think we have to combine all the evidence based on randomized trials as well as cohort studies, and I think overall the level of evidence is already quite convincing to my point of view.
Bernard, your thoughts?
I completely agree with Klaus. If we would limit our evidence base that guides us to clinical treatment on prospective randomized double-blind trials in these settings, I mean, we would never change our clinical practice. And if we have, studies like Klaus mentioned with nearly 10,000 patients showing a clear benefit, and it's not an outcome benefit of maybe +5 or 10%. So you can say, well, it's kind of questionable. If the difference is like 1 to 2, then there is a difference. And so, why shouldn't we do the better way? And whether the benefit is a reduction of the mortality by 20 or 30 or 50%, I don't care. If I would be an injured patient, I would like to get the best treatment. And if this allows me to survive, I'm very happy with it.
Michael, could I ask you whether you think any of the trials in treating iron deficiency would in fact be ethical? If someone's got proven iron deficiency, my view is that should be treated.
No, I don't agree with your statement at all, because the current area that I'm doing clinical research in is in pregnancy, and the treatment of iron deficiency in pregnancy with oral iron is as close to useless as anything that we do. The overwhelming majority of those to whom it is prescribed are made miserable. And if we don't do a randomized trial between oral and intravenous iron in pregnancy, in women who are not intolerant of oral iron, which means women who have never been given oral iron, we will never get an answer. The neonatology data is rife with the failure of oral iron to get to the baby, to decrease the developmental growth, cognitive and behavioral changes that are a direct result of iron deficiency, the incredible increment in autism spectrum disorders in pregnancies, in the babies of pregnancies associated with iron deficiency. So just treating oral iron deficiency with a proven ineffective modality will leave us in the Middle Ages, which is where we are now in the treatment of anemia in pregnancy. Otherwise, I have no opinion.
Well, perhaps you slightly misunderstood my question. I fully agree with you, actually. But what I'm really asking is that I think there's overwhelming evidence that intravenous iron is the way to be treating it on all the perhaps observational data we've got. And would a trial be ethical, in fact, to compare oral with intravenous?
James, as of this minute, and I forgive me for those of you who do not live in the United States, but we have to deal with guidelines that literally say intravenous iron is indicated for the rare patient who will not tolerate or respond to oral iron. That's today, June 1st, 2021. The British guidelines that were written by Sue Pavord in 2019 are a giant step forward, but doesn't address the issue of the failure of oral iron to work in the second and third trimester. If we don't do this study, it will never get changed. There is a huge bias in favor of oral iron in pregnancy and a misinterpretation of the nature and severity of infusion reactions with intravenous iron.
I like your passion, Michael.
I'm getting old. Now time to get this done.
Are there any questions from the audience? So I think we are a bit behind time. So Does the chairman want to conclude this discussion?
We have a question. We have a question from the audience. We have two questions about the iron medications.
Это вопрос, наверное, к переводчику, который сможет ли перевести нашим коллегам. Есть ли различия в ведении...
Any differences in the management of patients, vegetarians and non-vegetarians? Can you comment on that? Management of iron deficiency in vegetarians versus non-vegetarians. Please speak up, whoever likes.
Michael.
I can give an answer to this. I'd like to, because, you know, we like vegetarians very much because they're very good customers for all of our iron deficiency studies. And vegans are even better. They're even lower in their iron levels. And so they qualify for all iron deficiency studies. But basically, the treatment is the same, just the chances that vegetarians or vegans are iron deficient are much higher as in a normally eating population. That's my personal observation.
I agree with Donat completely. Iron in food is usually present because flour is fortified with iron. There are plenty of non-meat and animal fat formulations which provide adequate iron. But we're largely speaking of people who lose more iron than they can consume. And whether they're vegetarian or meat eaters doesn't make much difference. The human body simply cannot absorb enough iron to keep up with losses. And we have to come up with an appropriate method of replacing it, irrespective of dietary habit.
There's another question from the audience.
Just a second. Second question. What do you think about the combination of iron-based treatments with hepatoprotectors, if they exist in your market? Liver-protecting medicines, hepatoprotectors, iron formulations plus hepatoprotectors. This combination, please comment on that. Thank you.
Not quite what's being referred to there. Combining it with B12 and folate, or?
Hepatoprotectors, liver protecting, liver. Hepatoprotectors.
I'm not quite sure. The only thing I can think of.
Hepatoprotectors, do you know that? Hepatoprotectors, liver protecting medicines.
Never heard of it, and I've also never heard of any hepatotoxicity with the clinical use of intravenous iron.
So I don't think we can. We don't have liver.
Thank you very much. That's great. That's possibly a Russian market full of hepatoprotectors. And this is not what is existing in American or European markets. Thank you very much for this wonderful discussion. I think with that we can wrap up. Thank you very much for joining us, and have a good day and goodbye.
Dear participants, organizers and guests, we're glad to greet you on opening of the first in the Russian Federation International Congress, Patient Blood Management in Clinical Practice. Today's event is dedicated to the great achievements and prospects of development of patient blood management in clinical practice, both in the Russian Federation and overseas. WHO back in 2011 called all the countries to actively implement this approach that is aiming minimizing blood loss in all medical interventions. It can be achieved only by the whole integrated complex of medical steps from preoperative through perioperative to post-operative events. Most actual this approach in surgery, cardiosurgery, traumatology and orthopedic, hematology, oncology, gynecology, and obstetrics. International contracts is a step forward for new horizons in blood transfusion and patient life saving. During the Congress, you will discuss a wide range of topical issues. You will exchange clinical experience and cutting-edge practices. The topics of the day will answer most burning issues and will help to resolve the task of improving quality and safety of medical help for our patients. The exchange of the results of medical service professional discussions during this Congress will allow to shape modern approach to PBM. The result of your work can help to develop further your work in legislation of concept of PBM. Please draw your attention to the fact that from 2022 in the Russian Federation, we will have in force the legislation basis that all the medical help will be provided on the basis of united clinical guidelines developed by professional society. It is important that PBM events are based on expertise of our experts and included in clinical guidelines. Dear participants, we wish a fruitful work during the Congress. The suggestions and recommendations of today's discussion will help for further development of PBM in clinical practice for the specialists of the Russian Federation and international society. Dear colleagues, it was great to hear a few hours ago something wrong with my touch. We visited Mikhail Mishustin, and with him we had Tatiana Golikova, and we had also Olga Vladimirovna, who greeted us, and Mikhail Albertovich, and he passed his excuses that he didn't record his greeting. I usually tell my colleagues on the panel you're so young and you love greetings so much. And I lived a long life already, and I say the less there is congratulation, the more we have confidence is in us. And we are thankful for this confidence. Of course, I know that there were people who are really anxious, and there are ladies in the audience. These were 3 very intense days, but we had very positive results of this visit. And I significantly looking at Sergei here, who is struggling for this year and half, the chief doctor of Sklifosovsky Clinic, our wonderful colleagues here who are helping us for a long, long time already, and all of you who are sitting here in the audience, those who know what is the boundary between the life and death, my best and heartfelt greetings to you. I have 30 minutes for a life, and this is the first slide. The task is very simple. I'm not going to say anything new. You know it without me. It is the first international congress. Back 2 years in 2019, there was some slide. Though I have seen many congresses in our center and with the participation from the center. The professors from Austria and Australia came, and what I saw about blood, I was stunned. What happens to red blood cells after 7 or 14 days of conservation? It turned my understanding upside down. And when they said we need to organize this multidisciplinary team, I said yes, yes, and yes. And I'm happy that Ms. Golikova and the Prime Minister and the Minister understand this. These were 2 great days. Of course, we are sorry that we are not in the big audience, but we have 120 people here together with us, and it is a good step forward to normal life. We will have now opening, and we have great sessions. Oncology, coloproctology, orthopedic, cardiosurgery. Which symposium, which congresses can we see any of these all together on? We are also quite significant people. We're a national center, and we are the only national center. There are 3 oncological national centers, and we're the only gynecology and obstetrics center. And we are responsible for 85 regions. We are an institute of the 1st, 2nd, and 3rd level. We have more than 60,000 beds, more than 36,000 obstetricians and gynecologists. And we have already 6 million relatives. My deputy said that we have 9 million of protectors. And I think I can go to parliament using this support. We have huge society, and it is already today that we felt that there is neurosurgeon, our neurosurgeon, polyfunctional neurosurgery, and our clinic, Sklifosovsky Clinic, and these reproductive issues, childbirth, it is a specific part of our life, and we are very thankful, and we are definitely in certain range of interest. What is a national center today? 10 years ago, we had more than 3,000 patients, and we have lots of cutting-edge modern laboratories. And we should say that we even have laboratory of genome editing, of human genome editing. It is prohibited now. We don't have ethic basis for it. And we opened 8 institutes that you can see here. Mr. Shmakov is in charge of Obstetric Institute. We have here Alexey Viktorovich, who is the head of Anesthesiology and Reanimatology Institute. We're proud of Oncogynecology Institute. I'm sorry that academician Arshafyan is not here yet now. And it was our must, because we have to curate all the 85 regions of our country. We have more than 26,000 really complicated surgery interventions that are combining proctology, oncology, thoracic surgery. On the one hand, it is tumor, and on the other hand, it would be severe endometriosis. And we are proud that during this year, we were higher than Everest, because we had 9,100 births. We have lots of consultations and all of the rest. So we have, and all the regions in the country, and Marina Shuvalova, and we traveled 60 regions, but we were not like KGB officers. We were coming like good friends. We say we're a polyfunctional team, and we want to help all of you with obstetrics, with anesthesiology, neonatology, working with nurse reproduction. And for each region, we can have a doctoral thesis where we can understand how we should act and what is our mission. Recently, not talking about 2020, we have lots of telemedicine consultations within the framework of reproductive. We have more than 3,000 consultations per year. And during 2020, we of course consulted much more people. We also had COVID beds, so we were following all the country, and every morning we got 20 pages about each region, what was happening in each region, how many patients are on the artificial breathing support, how many on lung support, and so on. There were lots of consultations, and of course this is not a match for the different Moscow clinics. These are all very serious results still. We're happy that out of our 800 patients, we found 60 pregnant women, and we help them, and we have not lost any of patients. We got very serious molecular biological results, and we made the most sensitive PCR test for detection of COVID. And we see here that it was done very quickly. It was already in March of 2020 when we had done even more, and we made more than 166,000 studies. Our lab works day and night. We help different clinics, we help different institutes, and 76,000, these are people from different bodies. And these systems, the British strain, and the minister sets the task to create a new testing system, and in a very short term we create and register the first test for British strain. And at the moment, combination of British and Indian strain that infects lots of our patients in Vietnam. COVID changed the work of everybody, but our task was to understand how this virus influences different systems, understanding key role. In hematology, we were dealing with that particular issue, and understanding that post-COVID complications are focused here without any clear time. It is myocarditis, it is central nervous system. These are most dangerous things. We are working actively now. We're working with different markers, and soon we will publish different works, different interesting things. I would love to praise Generum company. It is a team that used in Vladimir region specific place. They invited ladies from the United States. They built a small village, and they are now producing the substance, the vaccine, but they cannot bottle it, and they made the national test. We are talking about humoral immunity all the time, about neutralizing antibodies, but where is immune system? This is the immune system, and they made this TIGRA test that finds T cell immunity for interferon molecule. It is very expensive, but it still exists. There are very strong work, and we understand that all the proteins that we talk about, receptors, ACE2 receptors, these are not the proteins of the spike. Protein is never alone. He has a sweet tooth, and he always put his sprouts into glucose. These are always glycans. So when we define antibodies, it is always glycome. It is not only proteome. And we work in this direction. These are absolutely pioneers' work. When we can check any Western vaccine and say how it works, we can take any plasma and glycome, when we can say that this is plumber number 1, this is plumber number 2 on virus neutralizing antibodies. We have telemedicine center since 20th of March to the 31 or 31st of December in 2020. We performed 5,600 consultations, and we had already lots of COVID pregnancies. You, of course, remember how it started. I remember of December. Our international colleagues, actually, my neurons were infected with the idea of PBM, and I thought that it is crazy when we start transfusing, when our patient has excessive blood losses. And that's why the idea appeared, great idea appeared, to organize the bank of your blood, the bank of your biological fluid. You have to put your stem cells, bone marrow stem cells, when you are 30. If you want to say, I don't want to be a retired person, when you are 30 or 40, when we are 25, 30, 45, we have to leave our microbiome and microbiota and freeze it. And it should be our treasure, because when you are 60, 65 or 70, if you have some tumor or if you have severe sepsis, then you will have your microbiota, young microbiota with positive spectrum, and that would be a great bank. And we have to store your own stem cells and understand that you are really rich, that you are rich indeed. If anything happens, you will have your own stem cells, but the bank should be even more secure than Switzerland bank. That's why I support personally the organization of this type of organization. We see that it's really a multidisciplinary approach. We see that the Ministry of Healthcare and all the societies are participating in this big association. We're happy that we are together, and I think that our friendship will increase and become more fundamental, even more fundamental. Of course, what it gives to us. On the left side, it is the task that we have to do. We have to get efficient and quality therapy. We improve the safety of the therapy, and we have efficient use of our resources. The strategy this strategy is to optimize the quality of RBC. And how can we imagine a life without safe service? And the optimization, and it does not work against allogenic system. We just understand well what the transplantation of allogene cells can give us. We can see how much we can save if we follow these ideas. The implementation of PBM, you see that there are, we can save 7,000 liters and have 200 million to save on money. And this is a result of our center. This is reinfusion, and we've already heard it. And I'm happy that our insurance started reimbursement of births with blood reinfusion. Of course, it is not alternative for allogenic hemotransfusion. It will stay forever. But this is optimal use of blood. This is clinical practice, a new medical paradigm and model. Minimizing of blood loss. You are professionals and you will talk more about it. We know what we need for it. We know that clinical guidelines is a mechanism that protect us. And based on that, standards are created. That's most important. And I'm happy to see first clinical recommendations, clinical guidelines. I will not talk about stopping of bleeding. So we see we had very difficult procedures of women after a few cesarean sections and healthy children and healthy women. And the patient will have to follow these patients. And that's why we had 171 organ sparing procedures. We have absolutely new surgery planning. We have new approaches, embolization, and we had only 2 extirpations. This is our task to change the situation in the regions. You know how it goes in the regions. She has bleeding and extirpation, bleeding and extirpation. Of course, there are lots of schools in our country, and we are very grateful to academician Serov. This guy will be 90 this year, but he's active, he is interested in everything, he's developing. Let's skip these slides and these slides. You know it really well. You should have fundamental knowledge of these disciplines. For our everyday topic, this is clinical embryology, epigenetics. I can talk about epigenetics for hours, but I'm limited on time. I'm talking for 20 minutes already. And these are strategic directions for the implementation of this work. It is analysis of epidemiology, clinical guidelines, audit of recommendations, information systems, because we have vertical work. Without this, we cannot live. And you see, I was absolutely stunned when I thought about oncology, and I thought, what can be comparing? Well, Let's imagine nightclub, projectors, beautiful girl near the pylon, and she takes off her fur coat, she takes off clothes, and then further, further, and further. That's how we see our patient. Well, here we here we set a diagnosis, then Blachin Center, then immunohistochemistry. The patient is sent there, here, but without that we cannot improve our work. And this is an absolutely unique situation. We start with oncology, then we have cardiovascular issues, neurosurgery, and so on and so forth. What I wanted to say about, we really think, what is blood? Well, we take thrombocytes, red blood cells, we freeze them, and I want to say about a wonderful book written by academician Sverdlov. He wrote 2 volumes, Life Through the Window of Genome. And he wrote 2, if you want to understand molecular biology, if you want to understand, we need to read this. We will invite him. It is an absolutely legendary generation. What he's talking about? He is talking about the fact that we have a very complicated biological system. And we have genomes and microorganisms, and we have never noticed them beforehand. We have 30 million pairs of nucleotides that our genome consists of. And when there is exome that is important for us, and we reported to the minister, to the prime minister, that we started first in our country making this exome, because this is our personal genetic Bible, our genome that says that our children will not suffer from monogenic diseases. That's something that explains what drugs we should take. This is a step forward to really personalized medicine. Of course, Mr. Sverdlov refers to many international colleagues, but the idea is that we are very complicated, non-linear, dynamic, stochastic system. And on this example, he says that oncology, cancer, is unconquerable. Each cell gives plus 2 somatic mutations. Distant metastasis often cannot look like a primary source. And when we introduce complicated systems, blood components, or stem cells, progenitor cells, we have new and very, very complicated system. And it's very bizarre to imagine the system. You cannot predict. I love cell technologies, not because we were the first, because if this complicated system is disturbed, we should not use ligands. We should use different philosophy. Our philosophy should be give this system refined, elite cells that have these unique properties. And that's why I wanted to say that this is very important to understand in transphysiology and in our session. These colleagues without whom I would have never demonstrated this slides, and I love this guy who suggested hyperspace, and he suggested also the idea of fourth industrial revolution. Future is already here. It's just not very evenly distributed. Thank you so much. For me, it's honor and pleasure to present the next presentation that is called PBM New Paradigm with the significant influence to clinical practice. Professor Axel Hoffmann from Austria.
It's a real privilege for us and a real honor to welcome you in frame of our Congress. And I was very much impressed during our first meeting, and it was a real reason just to create this new association. And all your activities and experience, it's a real basis for our development and our repeating. Thank you. We are very grateful for all your activities, and we are thanks a lot for all already done by you and your society. Thank you.
Thank you very much, Gennady, and thank you for this kind introduction. It is always a pleasure to see you. Unfortunately, we cannot meet in person this time, but I'm looking forward to post-COVID, and hopefully I can learn more about your impressive visions about your research programs. And I hope that patient blood management will also part of your research agenda for the coming years. So thank you again, Gennady. My topic, patient blood management, a new paradigm with huge clinical and public health implications. Are the slides moving? Okay. So here's my disclaimer. I work with governmental and public institutions, blood services, professional societies and NGOs, and also industry. And because my paradigm, because Thomas Kuhn, in his book, The Structure of Scientific Revolutions, when he coined the term paradigm shift, and he described it as a journey from what is considered normal science, and then through outside influences or inside influences, a model starts drifting. It can drift as much that the model gets into a crisis and finally hits the moment of a model revolution that then leads to a new paradigm. And he says a paradigm shift happens when there is no way to correct something without restructuring the underlying principles. And we will see how this applies to the paradigm of patient blood management. Because there are two paradigms of managing human blood. The old one, which simply says replenish the patient with allogeneic blood, and the new one that says manage and preserve the patient's own blood, or as Gennady said, make your own body your blood bank. The old paradigm, we will soon understand, we call a product focus, whereas the new one we call a patient-focused paradigm. What is important that behind both paradigms, there is a cause or causes, anemia and blood loss. However, in the old paradigm, the relationship between the underlying cause and the actual therapy is kind of loose or not existent, whereas in new paradigm, this connection is essential. So let's look for a moment at the old paradigm. There are so many of your colleagues from hematology to gastroenterology. And what they have been trained for decades is there is a value called the critical hematocrit. And they're all zooming in and think once this is hit, then of course the transfusion medicine department has to come to rescue with mostly 2 units of red blood cells. And I call this a lab result-driven monotherapy, regardless of the underlying cause and or disease. So the question is this wrong? Is something wrong with this old paradigm, or should we continue as we did for decades? Well, the old paradigm poses a significant risk for patient safety and outcomes while consuming billions of dollars that could be more effectively allocated in our resource-constrained healthcare systems. And so I want to walk you through these risk factors. Many, of course, that have seen the graph earlier know what they are, but anyway, let me just take you on your hand and walk you through this process, or this line of thoughts. So I'd like to start with the prevalence and risk of anemia, and want to remind the audience, we heard already that 2.4 billion people were anemic. That was in 2015, of which 1.5 billion were iron deficient anemic. And we should also keep in mind that there are some anemia clusters in the population. The first one is neonates and children, mostly due to iron deficiency. The second peak is women in the reproductive age. On top of the micronutrient deficiencies, we have heavy menstrual bleeding. According to some estimates, there might be more than 400 million women suffering from heavy menstrual bleeding, and women with multiple pregnancies. And then, of course, there's the third group, the elderly, again with micronutrient deficiencies, but many of them are having a state of inflammation, which then impairs the erythropoiesis, and some of them are also bleeding, chronically bleeding, for instance, due to ulcer bleeds and gastrointestinal problems. Now, that is an overview of the general population. What about the surgical and medical patients, the hospitalized patients? And here is an overview of preoperative anemia across different types of surgery, ranging from 24% in gynecology, when excluding the oncology cases, up to about 65% in specific conditions. Every box represents a study looking at the prevalence of anemia in these subpopulations. Or here, iron deficiency in chronic heart failure. You see NIHA class 1 with about 40% IDA, not just iron deficiency with and without anemia, and 60% in NIHA class 4. Or here, a very important slide, I think, because it not only shows us that the anemia in hospitalized and surgical patients increases with the age, but we also have to keep in mind that most societies currently on planet Earth are aging societies. This means we are not only seeing a higher caseload, but we will also see the caseload is going with a higher prevalence of anemia. So the question then is, does at least mild to moderate anemia, does it matter? Everybody would probably agree that profound anemia, of course, matters, but what about mild to moderate anemia? And we have touched on that study already today with 230,000 patients, of which 30% were anemic, and the investigators wanted to understand what the impact of free anemia would be on post-op outcomes in non-cardiac surgical patients. And you can see on the x-axis, there is a drop in hematocrit from borderline anemia with 38% to less than 20% on both slides. And then you see the mortality and morbidity increasing linearly. So you see that even with slight increments of the severity of the anemia, mortality, morbidity are going up. And when you look into the web appendix material of that study, then you see that even with mild anemia, so just below 13 grams or 12 grams for males, females, in hemoglobin concentration, you see that the odds for mortality increases by 40% and for morbidity by 30%. And interestingly, when you add transfusion as a therapy to the picture, in fact, mortality and morbidity get worse. And so one of the important messages to take home is that anemia is bad, but transfusion does not improve the outcome once the patient is anemic. And I think Sheru Ozawa showed that slide already for neonates and children, so we don't have to repeat it. However, here's the same message. Anemia is bad, transfusion does not improve the outcome. So she also showed the meta-analysis from Fowler with the 950,000 patients, so I can also cut short on that one. But I want to remind you, as we saw earlier, these high prevalences in surgical patients between 24 and 65% is also here the case, 39% across all the studies. And we see that the anemia is associated with significantly increased perioperative mortality, almost 3 times, and a lot of other adverse outcomes. And it is a main driver for transfusion, with an odds ratio of 5 times higher compared to the non-anemic patients. So we really deal with a killer when we quote that editorial from Longo, anemia in elderly people, or Guralnik saying that anemia is really a health crisis in hematology. And since I've turned 65 the other week, it's tough to be old and anemic. So, but anemia is not the full story. It's also a problem that we are facing when the patient has isolated iron deficiency. And this is work from the Donald Spahn's group. Iron deficiency is associated with higher mortality in patients undergoing cardiac surgery, where we have 730 patients. And the iron deficiency was defined as a ferritin level of less than 100 nanograms per milliliter, using the WHO cutoff values for anemia to exclude the iron deficiency anemia patients. So just looking at isolated iron deficiency, and you can see that the patient with isolated iron deficiency had a 3.1-fold higher 90-day mortality compared to patients with no anemia and no iron deficiency. The serious adverse events were 2.2-folds higher in the isolated iron deficiency patients, and the major adverse cardiac and cerebrovascular events were 1.6-fold higher. So we can really conclude this piece or this subchapter and say anemia and iron deficiency, they are an independent risk factor for adverse outcomes, including mortality. Now, the question is, what's the next risk factor? Well, it is blood loss. We don't need too much time because it's a no-brainer. We all know that major blood loss and hemorrhage is a potent multiplier of adverse outcomes, including, of course, mortality, major morbidity, ICU and hospital lengths of stay, and transfusion. And I think Klaus Gerlinger recently told me about the study that shows that every 15 minutes in delay of stopping a massive hemorrhage increases the mortality risk by at least 3%. We should also keep in mind that the majority of blood loss is caused by local surgical interruption or vessel interruption. Only the remainder is due to acquired or congenital coagulopathy. So what is probably not on the radar of everyone is blood loss due to phlebotomy. And this is an important piece of work from Colleen Koch from Cleveland Clinic, looking at almost 1,900 patients that underwent cardiac surgery. And she found with her team that they had 221,000 lab tests with an average of 115 tests per patient. And this was mainly for blood gas analyses, coagulation tests, and full blood counts. And this averaged in a loss due to phlebotomy of almost half a liter per hospital stay. And you can see on the left graph here, different percentiles with phlebotomy volumes. taken, and on the y-axis, you see the transfusion rate. So you can see also on the right-hand side, when the patient is about 1 week in the hospital, he got phlebotomized the equivalent of 1 unit, the second week 2 units, and all those who were there more than 15 days had a mean of 3 units in equivalent. And the sad thing is that of the 116 milliliters drawn per draw, 80 milliliters went into the sink. And so Colleen Koch invited other hospitals to have an even broader picture with 190,000 hospitalizations, and the endpoints were mortality, charges, and lengths of hospital stay. And you can see that 74% of these patients acquired either mild, moderate, or severe anemia. And as the severity goes up, you see that mortality, lengths of stay, and charges or cost are increasing significantly. So, as I said, it's very obvious that blood loss and bleeding is a major risk factor for adverse outcomes. And for 70 years, the medical establishment has broadly neglected to routinely manage and preserve the patient's own blood. Instead, in the face of anemia and/or blood loss and bleeding, the default therapy was transfusion, and therefore the US Department of Health and Human Services found in 2011 that transfusion is the most common procedure performed during hospitalizations. Now, transfusion is another multiplier of morbidity and mortality. This is just one of several tables that looks at studies that report a dose response increase in adverse outcomes associated with RBC transfusions. These are studies from 2001 to 2018, and it's basically all studies that report on dose response effects, and they all show adverse effects of different sorts. But you see mortality has been looked at a number of these studies, and it clearly is coherent with the findings in other patient populations. So we are left with the conclusion from 60 or more observational studies, including more than 6.1 million patients, that there is a dose response increase in adverse outcomes associated with red cell transfusion. And these are all the adverse outcomes that are reported in these studies. And it's not only like serious adverse events like stroke, myocardial infarction, of course, mortality, but also endpoints that are of a high economic impact, such as the admission to ICU or admission rate, or the increased length of hospital stay, etc. So you might say, well, don't we have randomized controlled trials showing benefits from transfusion? And the answer is not really. There is this article, Restricted versus Liberal Transfusion Trials. Are they asking the right question? And in fact, they are not answering whether transfusion is beneficial or not. These trials are not testing the efficacy of transfusion, which would be transfusion versus placebo or another intervention. What they are doing, in fact, is testing anemia tolerance at different levels with subsequent transfusion. So they really ask the question, to what extent lowering the hemoglobin threshold for transfusion can be tolerated safely? And here we are back to the old paradigm, to this focus on the critical hematocrit. And so we should just dwell for a moment, or should focus on this topic. In 2013, there was this article by Goodnow and colleagues asking the question and the concepts of transfusion in adults, where is this hemoglobin that is so critical? And there's quite a choice. And you can see there are articles recommending less than 6 grams, others 7 grams, and again, others 8 grams. And you see the difference between 6 and 8 grams is about 2 units of red blood cells. And what do the academics usually, when they face uncertainty, at least in our days, well, they turn to randomized controlled trials. And so we have now more than 20 years and more than 60 randomized controlled trials on restrictive versus liberal transfusion regimens. Well, my esteemed colleagues, mainly Kevin Trentino and Shannon Farmer, but also the other colleagues, together we undertook an overview of systematic reviews. In other words, an overview over all the overviews and on restrictive versus liberal. And here's what we learned. What we learned, number one, by using MSTAR2 rating, there's a separate article on the methodology in the British Medical Journal in relation to our work, was that the methodological quality of these 19 systematic reviews only had 2 with high quality, whereas the rest was moderate, low, or critically low in quality. What we also saw from these 19 systematic reviews that there is in most of them, I think 14 of the 19, that have a huge overlap between the restrictive thresholds and the liberal thresholds that were looked at the very systematic review of each of these authors. And you can see they start at 7 grams and end at about 13 grams per deciliter. So answering the question, even whether restrictive is better than liberal, is a bit hard to answer with this overlap. However, one study stuck out from Salpeter 2014 because you can see there's a distinct delta between restrictive and liberal. And in fact, this meta-analysis looked at 3 famous studies by Paul Hébert, Jacques Lacroix, and Candide Villanueva from Spain. And here the results are quite interesting because the restrictive group with a threshold of less than 7 compared to the ones with more than 9 showed a benefit in terms of in-hospital mortality, total mortality minus 20%, rebleeding minus 36%, acute coronary syndrome minus 56%, pulmonary edema minus 52%, and bacterial or hospital-acquired infections minus 14%. But by all means, because we are having all these data, we might believe, or we might think that this has changed clinical practice and clinicians would adhere to more restrictive. And what is really sobering is to see the work from Jens Meyer when he looked in a prospective observational cohort study with almost 6,000 patients in 126 centers across Europe that received at least 1 unit of red cells intraoperatively. This was done in a cross-sectional analysis over a week. If I take here in dotted lines the transfusion threshold recommended by the American Association of Blood Banks for patients with pre-existing cardiovascular disease and 7 grams without that impairment, and when we compare this with the actual transfusion practice, this tells us there is no adherence to restrictive thresholds. In fact, by far most of the transfusions are administered outside guidelines with increased morbidity, mortality, and cost. And so when we look at this problem in its entity, we have what we call the triad of independent risk factors, where bloodless and bleeding either makes the patient anemic or makes the existing anemia even worse. At a certain threshold, a transfusion is released, and it's at least in gastroenterology patients or patients with gastrointestinal problems, there is evidence of associated rebleeding with transfusion, and therefore we call this a triad of risk factors. And now we want to put this whole problem into a perspective. Transfusion, and this is my own estimate from blood safety and availability from WHO, saying that we have about 118 million transfusions every year just with red cells. Now deduct probably the wastage. We might end up with about 40 to 60 million individuals or patients that get transfused. So that can be helped to a degree with patient blood management. But there is a much bigger group that also can benefit from patient blood management. There are probably 700 million patients or people or more that are either undergoing major surgery or having blood loss in the ICU, both medical and surgical, obstetric patients, women with heavy menstrual bleeding, trauma victims, gastrointestinal bleeders, coagulopathies, phlebotomies that we have seen in globinopathies. And there's an even much bigger group of 2.4 billion patients, as we have seen, that suffer from one or the other form of anemia, including anemia of chronic disease, renal anemia, chemo and radiotherapy-induced anemia, medication-induced anemia, hospital-acquired anemias, just to name the ones with the highest numbers. And so the new paradigm says manage and preserve the patients of the blood of all these patients, and do this by modifying the 3 risk factors that are masked by the old paradigm. This means you start with the optimization of the endogenous red cell mass of the individual to minimize blood loss and bleeding in a systematic way, and to harness and optimize the physiological reserve of it. And this means that you have to overcome a cultural problem, a behavioral challenge, the shift from the old to the new paradigm. Again, this is what we said about it. It's a lab result-driven monotherapy. And so the question, how low can I go before administering a transfusion, has to stop. This is the wrong questions for clinicians to start with. It's an important question, but it's not the question to start with. The correct question is, and you see it on the bottom, what can we do to preempt a situation where we touch on a critical hematic? And so what can I do to minimize or eliminate the underlying causes of anemia and blood loss to improve patient outcomes, even for patients not at risk of transfusion? These many, many more than just the ones who are at risk of transfusion. And you can then break it down in a number of questions. Is there uncorrected micronutrient deficiency somewhere? Is there an uncorrected anemia? Is there permissive surgical blood loss in my institution or operating theater? Is there excessive iatrogenic blood loss as a routine in our hospital? Is there poorly managed disease-related blood loss? Is there poorly managed coagulopathy? And independent of the critical hematocrit, you also have to ask, do we have a behavior-based transfusion practice in our hospital? And if you want to tackle these questions in a constructive way, then you have to insert patient blood management with the 3 pillars. And here you have to fight complacency and ignorance, whereas here you have to educate that there's a lot of missed opportunities. And therefore, the new focus is really on the patient and the underlying cause of the problem. So what's the real-world evidence with PBM showing us? We don't look at single randomized controlled trials on some modalities, although we would have material, but time doesn't allow. So just let me touch on the program in Fubai Hospital. I heard today that the caseload for open heart surgery in Russia is about 50,000 cases a year. Well, Fubai does 15,000 in just one institution every year. They had about 15,000 in 2017, slightly dropped. But you can see also how mortality is down to an amazing 0.44%. You also see that over more than 20 years, the ratio of the elderly patients have risen, has increased due to the aging population. And they have a PBM program, and in fact, every single surgeon in that institution is part of the program. It's a multidisciplinary collaboration, and the specific measures are an anemia treatment program, of course, meticulous surgical hemostasis, the use of antifibrinolytics, cell salvage, a reduced bypass circuits in volume, routine use of viscoelastic testing, restrictive transfusion indication, and the evaluation and the publication of the blood transfusion for single procedure by surgeon and anesthetist. So from this, they do a procedure-based benchmarking evaluation system with bonus award, and they see blood transfusion as a quality control indicator or the level of transfusion reduction in cardiac surgery. Now, this is, as the caseload went up and mortality went down, this is their evolution from more than 70% transfusion rates with red cells in 2008 and about 66 with plasma, with FFP. They came down to 24 for red cells and slightly over 10% with FFP. This is still the average for red cells in the People's Republic of China. And you see here how post-op hospital lengths of stay dropped from 10.5 to 7.5 days, and mortality from 1.2, which is already amazingly low, to 0.4 and now to 0.44. And this is the world's largest study that has been mentioned today. This was our project in Australia with 600,000 patients involved, a full-blown patient blood management program that included all emergency and elective medical patients and surgical patients. And you can see in this ultra-modern healthcare system how in-hospital mortality further increased by 28%, hospital lengths of stay by 15%, infection by 21%, myocardial infarct and stroke by 31%, and readmission, as was said earlier, not anemia related, went up by 6%. You also see a very low anemia rate. This is basically those patients who are there for urgent and emergent treatment, whereas the elective, in the elective, we can almost say that anemia has been eradicated, at least for patients admitted. We reduced transfusion rate by 41%, although when we started, we had already one of the lowest transfusion rates in the Western world, and we adhered even better to a restrictive threshold, 7.3 grams across the entire state, and the single unit transfusion rate jumped from 33 to 64% and reduced the multiple unit transfusion. But also financially, we saved the system at least $80 million in activity-based transfusion cost savings, all the activities related to transfusion, not counting the additional benefits and monetary benefits from significantly reduced complications. So we have shown with this real-world evidence that PBM reduces mortality, morbidity while saving costs. Meanwhile, there are meta-analysis and systematic review of a number of such large studies. Donat Spahn has summarized them and showed this just for the surgical population with about 221,000 patients from several PBM programs, an overall reduction in mortality of 11%, 39% reduction in transfusion, and reduction in a number of major complications. So when we come back to from the beginning, a paradigm shift happens when there's no way to correct something without restructuring the underlying principles. Transfusion used to be a standard of care. It got its first model drift around the hepatitis and HIV crisis. It got into a real trouble when there was a dose response association shown with adverse outcomes and transfusion. And finally, the model revolution happened when PBM was proposed as a cost-effective concept to manage the patient's own blood rather than resorting to someone else's blood. And now we are in that stage where PBM is proposed as a medical model to improve outcomes of billions of patients. And here's therefore the new definition that is used by the largest societies and entities that deal with PBM, and we are all well connected and intertwined. PBM is a patient-centric, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. So our conclusion is very simple. We have something to offer for all these different populations, and we think the benefits are enormous in terms of improved outcomes for surgical, medical, obstetric patients. We think it's a much better safety and quality of care. It improved the patient-centeredness, including patient education, empowerment, and shared decision-making. And it improves the population health status in years with a disability, but also with reduction of neonatal and infant mortality and maternal mortality. And it reduces costs and resource utilization, and it reduces national transfusion dependency. And last but not least, it even improves pandemic response, which we didn't touch on. So Donald Spahn summarizes it by not implementing PBM represents standard of care. Spasiba for your attention.
We are so much impressed by outstanding lecture. And these 30 minutes was a revolution for us, according to your experience, knowledge, and development. But also many thanks to the interpreters. Well, we try to do our best. I hope you can hear him. Thank you.
You too. Thank you very much that you translated and interpreted. Thank you.
Вас это очень интеллигентно, поэтому это нетипично для меня. Я отдаю власть профессору Федоровой.
That's not typical for me, and I give the power now to Professor Fedorova. So we do proceed our opening ceremony, and we're happy to give the floor to Dr. Yuyun Siti Marin Sikh from Switzerland, who is the representative of WHO, and her presentation is devoted to the action plan for 2023 for the implementation and development of PBM programs at the global level. So you're welcome. The floor is yours.
Good morning. Good afternoon and good evening, dear colleagues and attendees of this congress. I'm Dr. Yuyun Marioningsi. I'm a team lead for blood and other products of human origin, Health Product Policy and Standard Department, WHO headquarters. I'm very pleased to be part of the first International Interdisciplinary Congress on Patient Blood Management in Clinical Practice. First of all, on behalf of the World Health Organization, I would like to congratulate Professor Oleg Rogachevsky, the Executive Director of the National Association of Specialists in Patient Blood Management Russia, International Foundation for Patient Blood Management, Western Australia Patient Blood Management Group, and other partners for conducting this important Congress. World Health Assembly resolution in 2010 has urged member states to promote the patient blood management and request the Director General to support the introduction of availability of transfusion alternatives, including, where appropriate, autologous transfusion and patient blood management. And furthermore, through the action framework to advance universal access to safe, effective, and quality-assured blood products 2020 to 2023, WHO reaffirms the importance of implementing effective patient blood management as one of the strategic objectives of global efforts to address present barriers to safe blood. The implementation of patient blood management is expected will reduce dependency on transfusion. It will also contribute to avoiding adverse reaction from transfusion that lead to increased healthcare costs, and also avoiding the inappropriate use of blood products that are already scarce available, especially during emergency situations such as during disease outbreaks, natural disasters, or during man-made disasters. So I hope this Congress will give better understanding on importance of patient blood management, as well as giving update information related to patient blood management in the clinical practice. Finally, I wish you to have a fruitful Congress. And next, I think I will be happy if the organizer can play my recorded presentation. Thank you. Good morning, good afternoon, good evening, everyone. I'm Iryun Maryuningsih. I'm a team lead for blood and other products of human origin, health product policy and standard department, access to medicine and health products division, WHO headquarters. I'm very happy to be part of the NASPBM symposium today, and I will share with you information on the WHO and patient blood management from Resolution WHA 63.12 to the 2020 to 2023 Action Framework for Blood. To start the presentation, I would like to quote the statement from the WHO resolution that excessive and unnecessary use of transfusion, unsafe transfusion practices, and errors seriously compromise patient safety. So to respond to this situation, the WHO resolution 63.12 issued in 2010 urged member states to ensure availability, safety, and quality of blood products. The resolution also urged member states for practicing safe and rational use of blood, minimize transfusion errors, promote patient safety, and patient blood management. However, the Global Database on Blood Safety 2015 identified that implementation of clinical use of blood, hemovigilance system, and patient blood management remains a challenge. WHO response to the patient blood management in the past are development of guidance on the appropriate clinical use of blood in 2002. This document is currently under revise, and also development of guidance on establishment of National Hemovigilance System in 2016. The clinical use of blood and hemovigilance system are really related to patient blood management. Another response from WHO is conducting the workshop, trainings, and country assistance on clinical use of blood. And in 2010, WHO has also conducted the Global Forum on Patient Blood Management, in which this forum gives some recommendations, and one of the recommendations are improvement of transfusion practices and use of blood at the hospitals, strengthening the legal framework on clinical use of blood, including patient blood management and hemovigilance system at national level. And also another recommendation is develop a generic tools on collection of minimum transfusion outcome and patient outcomes data at national level. Countries that implement these resolutions and guidance, which are mostly developed countries, are making progress in providing safe blood and blood products. But progress in establishing and strengthening national blood systems has been slow in many countries. So there is a need to push for implementation of WHO guidance at country level, particularly in low and middle income countries. So that is why the action framework is developed. The aims of this action framework, which was launched on February 17, 2020, is a strategic direction to global efforts to address present barriers to safe blood. This document has also been aligned with 13th WHO General Program of Work and Strategic Plan for Regulatory Support Activities for Health Products 2019 to 2023. The document describes the implementation of resolutions, goals, and strategies. And lastly, the document can also be used to build the partnership and for fundraising. So you can access this document through the link which is provided in this slide. Now I will try to explain the content of the action framework, in which the action framework describes the challenges in blood services based on the Global Database on Blood Safety 2015. The first challenge identified is inadequacy in policy, regulations, governance, and financing, in which the data showed that only 60 to 70% member states with blood policy, legislation, and oversight system. Next challenge is insufficient supply of blood products, in which the data shows that there are still 66 member states with blood donation rate less than 10 per 1,000 population. Deficiencies in safety, effectiveness, and quality is another challenge, in which only 80% of donated blood was tested towards the transfusion-transmitted infections agents in low to medium income countries. Lack of availability of plasma-derived medicinal products, again, is another challenge. This situation can be due to limited use of blood component and low volume, as well as poor quality of plasma to be fractionated. Suboptimal clinical practices, again, is another challenge. This situation can be due to clinical use of blood, hemovigilance system, and patient blood management are not implemented. And the last challenge identified is poor access to blood during emergency situation because no blood supply preparedness systems in place. Now I would like to also inform you the specific challenges on patient blood management field, in which the global database on blood safety 2015 shows that only 40% of countries reported of existence of degree programs in transfusion medicine, either for medical doctor, nurses, midwives, or another healthcare worker in the transfusion medicine field. And only 45% of hospitals reported having transfusion committees, and only 71% of countries has national guidelines on clinical use of blood. And most of member states has no comprehensive hemovigilance system. In this slide, I would like also to show you the table. So from this table, you can see that whole blood still used mostly for transfusion in low-income countries to middle-income countries compared to high-income countries. So all of this situation led to suboptimal clinical practice in transfusion of blood, and finally impacts to patient outcomes and increased healthcare costs. So next slide is to explain about the 6 strategic objectives to respond to the challenges. So the first strategic objectives is structured, well-coordinated, and sustainably resourced national blood systems, followed by appropriate national framework of regulatory controls, functioning and efficient blood services, effective patient blood management, effective surveillance, hemovigilance, and pharmacovigilance. And the last strategic objectives is partnership, collaboration, and information exchange. For this presentation, I will further explain the strategic objective number 3 and 4, which is directly related to patient safety. So the strategic objective 3, functioning and efficiently managed blood services, will have 4 outcomes, which are achievement of 100% voluntary non-remunerated donation, protection of donor, and promotion of repeat donation. The next outcome is a functioning quality system is in place, as well as blood services are efficiently and cost-effectively managed. And the last outcome for this strategic objective is availability of the volume and quality of plasma for plasma-derived medicinal products is increased. Strategic objective number 4 is effective implementation of patient blood management. So the outcome for the strategic objectives are good patient blood management is practiced based on national clinical guidelines and practice standards. And a quality system is in place in hospitals for all pre-transfusion testing. For the strategic objective number 4, I would like to further explain the intermediate outcome to support the high-level outcome of patient blood management is practice. So for the intermediate outcome are good transfusion practices and hospital transfusion committee are in place, adequate blood supply system, patient blood management and clinical use of blood are in place, as well as the clinician and other care providers have better knowledge on transfusion medicine as well as on the patient blood management. So to achieve this outcome, the output or the activity that need to be done is to develop the education module on clinical use of blood, as well as to develop the WHO guidance on patient blood management. The implementation of the action framework has already been started last year, so 2020, and will be ongoing activity to 2023. So from the action framework and from the 6 strategic objectives, we identified that there are around 8 guidance need to be developed by WHO. So last year, as you can see from this slide, we have already developed the guidance on centralization of blood donation testing and processing, and guidance on increasing supply of plasma-derived medicinal products in low to medium income countries through fractionation of domestic plasma. And I would like to inform you that these 2 guidance has already been issued, published, and of course you can access these 2 guidance through the WHO website. So why these 2 guidance has been put in priority to be developed? Because we believe that by centralizing the blood donation testing and processing, the country can standardize the quality and safety of blood, and also the country can provide sufficient volume of quality plasma to be fractionated to become plasma-derived medicinal products. And for this year, we are still working to develop the education module on update clinical use of blood, guidance on implementation of patient blood management into healthcare, and to develop the education training modules on hemovigilance. So specific for working on developing of guidance for implementation of patient blood management into healthcare, I can explain to you that a working group has been established, and we are lucky to have Professor Axel Hoffman, the board member of the International Foundation for Patient Blood Management as to chair this working group. And this working group also will be supported by experts on clinical and or public health expertise in relation to patient blood management. As soon as this document been published, then usually we will conduct the webinar to promote the guidance. And if there is a funding support, then we may also conduct a pilot project on countries' implementation of this guidance. So the aims of the WHO guidance on PBM is to respond to the WHO Resolution 63.12 that urged member states to promote the patient blood management, and WHO to support the introduction of the patient blood management. And of course, this guidance also is to implement the 2020 to 2023 action framework for blood. Another aims of this guidance is to make member states aware of the importance of patient blood management, and also to guide member states to incorporate patient blood management into clinical practices. So to close my presentation, I can say that patient blood management was endorsed by the World Health Assembly in WHA 63.12 resolution issued in 2010. Patient blood management is increasingly recognized as a fundamental element for good clinical practice in transfusion, and also the patient blood management plays a key role in optimizing clinical practice, while reducing transfusion dependency. And lastly, I can say that implementation of robust patient blood management strategies lead to improvements in patient outcomes and reduction in healthcare costs. So thank you for your attention.
Доктор Июн, спасибо.
Thank you so much, Dr. Yuyun, for a magnificent presentation about the development of PBM in the world scale and in the WHO program. We are also a member of this framework on PBM implementation, our association, and we hope to continue our cooperation. Thank you so much. The concluding presentation is mine, and it is called PBM in the Russian Federation, Challenges and Solutions. I suggest that we can have this presentation tomorrow, or I will cut it down. I will just remove the simple slides, and I will talk about the issues that you have on the implementation. Distinguished colleagues, one more time, good afternoon. Thanks for staying here. We will have also a standing buffet with cold champagne, so I will not hold you for a long time. I will be talking about PBM in the Russian Federation, and I think that PBM is good, PBM is resultful, it improves the results of the patient, and all these factors, all these positive factors that we are talking about. PBM is not just an alternative for the transfusion. It is a medical model and justified medical practice. If we need to transfuse blood, then we need to transfuse blood. But if it is not needed, we should not do it, we should not perform it, because we will have more complications than we can have benefits, because all the colleagues that are dealing with the blood transfusion, you know what complication can happen whichever blood component we transfuse. In Russia, so blood-saving technologies are used for a long time already, and one of the books that we use on everyday basis, anesthesiologists, reanimatologists, and transfusiologists know this work. Blood loss and hemotransfusion, principles and methods of bloodless surgery, how to avoid hemotransfusion, what is the substitution for the transfusion, how to get the result that is no worse than components transfusion. When we talk about blood-saving technologies, we talked about blood-saving technologies, and today we talk about PBM. This is that gynecologists and obstetricians were one of the first, Bubakirova, Kulakov, were the first to start blood-saving technologies in obstetrics and gynecology, and the department that was headed by Ms. Abubakirova had one of the tasks to implement blood-saving technologies. And then we have works by Mr. Baranov, by Mr. Rogachevsky, and now we are waiting for doctoral thesis in gynecology on blood saving in different pathologies that women can have. Cardiosurgeons also worked with this topic a lot. They have developed checklists for the blood saving technologies for PBM in cardiosurgery, and we have checklists for treating blood loss with ingrowing placenta. And in this situation, when we have placenta increta, we use also different types of PBM. Great transfusiologists such as Ragimov, Zhiburt, leaders in transfusiology. They wrote the first book on the PBM, and there will be soon the second edition of this book, and I think it will soon appear. In Russia, we're not lagging behind Europe, but certain European countries, Austria, Germany, Australia, they have this on the national level. If the clinic doesn't have PBM certificate, it cannot work. Leading centers work for management blood for PBM, and we understand that we have to have system approach. We have to develop PBM not only in the centers where we work, but in whole Russia. You see the number of initiatives for PBM in the Russian Federation. It increases every year. Obstetricians and gynecologists, anesthesiologists, coloproctologists, transfusiologists are most active. Of course, hematologists are very active, neurosurgeons, orthopedic traumatologists. The head of this committee is Vladimir Shvets, and tomorrow we'll talk about possibilities and perspectives for PBM usage in orthopedic surgery. There are different Russian medical societies, and you know these are different societies of gynecologists, anesthesiologists, hematologists. They try to implement these methods of PBM in their clinical practice. They organize roundtables. They organize different webinars, especially during the last year. We work online all the time last year, and we educate people on PBM. And there are, of course, certain successes. And you can see with the stars I marked the cities that are already advanced in PBM. Tomorrow we will have presentation by Vladislav Glovtsov from Krasnodar. He works pretty actively. In Stavropol they also have work. In Orenburg there are experts for PBM. And of course our Siberia, I've already mentioned that it was quite recently when our colleagues returned from Tyumen, Irkutsk, Khabarovsk. They were given their lectures, they met the ministries of healthcare, they started scientific and practical cooperation for PBM implementation in some hospitals. And we started as pilot study to demonstrate how efficient PBM is after we implement these methods. Everybody talked about it today, what was before and what happened after PBM implementation, how well we can implement it. And what are the issues? There is no systemic approach for perioperative treatment in the way that is presented by European societies, by WHO. I think that is the reason is that we do not have the links between the doctors on different levels. For example, in outpatient, the patient is diagnosed with anemia, and the patient is sent for surgery. And the surgeons say, do everything to operate this patient. And in one day, if we see hypoxia signs, we should perform hemotransfusion. If we have any time on pre-hospital, we can use intravenous iron, we can use oral iron, and we can prepare the patient for operative intervention. So if we have communication between all the doctors on all different levels, we will move forward on PBM implementation in clinical practice. That's why we need United Coordinational Center for PBM. I hope that our association will become such a center around which all the experts will be concentrated, and the legislation basis will improve. We will have educational sites, and we also have to have independent evaluation of PBM for different centers. So when a commission is established and it performs audit whether PBM is implemented efficiently. If it is efficient, then it is certified. and it should be also efficient work with administrators and patients. We can use the results that we already have in Europe. There are things by WHO. There are goods of know-how in Switzerland and Germany and Austria. You have seen and you've heard today Axel Hoffman, who were struggling for implementation of PBM in different countries. So today we are trying to work to become the leading organization for PBM implementation. And for example, we already demonstrated how efficient anemia treatment can be on the preoperative stage in coloproctology, in cardiovascular surgery, in orthopedic surgery. And this is the High Economy School of Economy in the healthcare ministry in the Russian Federation. And we can see how we can save when we treat anemia on preoperative stage. We save 7,500 liters of blood, and we save in money significantly. And we even gain money because we decrease bad days. So the potential economy is more than 1 billion rubles. And when it is presented in different symposia and webinars, the healthcare providers from the Ministry of Healthcare, they said, yes, we will implement it, just say how. And we need to demonstrate to them the plan for PBM implementation, not only for national centers, but for hospitals and different clinics. And you see that there is a lack of interest of surgeons. We should talk about different blood loss when we have perioperative blood loss, and we can demonstrate the benefits on the implementing of PBM. What are the challenges? We got together here, and it seems to us that everybody knows about PBM. But there is lack of knowledge, especially in big clinics. We need to educate doctors. We should talk about it. We should demonstrate these lectures. There is no multidisciplinary approach. When we talk, let's implement PBM, but if there is no money in the hospital, they cannot use intravenous iron. They have self-saver, but they do not have the utility. Same for concentrates of prothrombin complex, 7th factor. They are all expensive factors of PBM. Same for ROTEM, same for thromboelastography. Or sometimes there is ROTEM, but there is no experts to work on it. So there are lots of issues existing in the organization, and they exist in small and big clinics. So today we need to have structural changes in any clinic, and we have to have plan for PBM implementation in each clinic and each department. One thing would be in orthopedic department, and different thing would be in cardiosurgery. There must be leaders for PBM. If there is no leader, nobody will tackle this issue. Nobody will react to the possibilities that PBM have. There must be education of all the employees. There should be monitoring. After we implement PBM, we perform audit. We should understand what are the losses. We have to see that whether the correct development of PBM is in place. If you do not work hardly, there's no effect. If you are purposeful, you will have a good result. That's why the head of the clinic should prepare individual program for each department, but it should be discussed with the doctors, with the nurses of all the specialties. PBM will allow to realize PBM oriented for the patients, and initial success in each clinic and further will be a stimuli for the development of PBM in each clinic. I would love also to mention that education is paramount importance. Education of our young doctors. We should understand the principles of PBM should be implemented while educating students in medical colleges and on medical faculties, so that when they come to work, they already know what is PBM. And we do not have it in high schools, but we have it during the professional trainings, because it's very important. If we educate our experts, we will have stuff what Euro Pollution was talking about. We need to have educated staff, we need to have financing, and then we will reach what we are aiming at. And what I would probably stop here. We have 6-level strategy for PBM implementation that was developed by Professor Hoffman, and it is presented in the resolution of PBM, and he presents their main purposes. It should be efficient structure. There should be efficiency of the processes, practical preparation. There should be scientific basis for PBM and efficiency of treatment. The financing stakeholders should also participate in that, and we should use finances for PBM implementation. Same for patients. They also should know what PBM is, because many patients say, I don't want donor's blood, I will save my own plasma, thrombocytes, and so on. So this 6-level strategy, if we implement it, it will allow us to implement PBM and use it widely. And in this article, on these slides, we have a list. Daria Gromachkova asks who need these materials. If you need, you will get these slides, because it's clearly stated here what should be done to implement these principles: efficiency of structure, efficiency of processes, and efficiency of treatment. And if we all together work on implementation of PBM, we will achieve it, and all together we will do it. Thank you for your kind attention, and I'm sorry to be a little bit late. And now we invite you to have some cool champagne for communication. Let's talk in corridors. Tomorrow we'll start at 9 o'clock Moscow time. In the morning we have a joint communication. There would be a talk about the implementation of PBM in Russia, in different countries. We will talk about issues with PBM in Russia. Ms. Larisa Popovich will talk about pharmacoeconomy in the Russian Federation. And then we will go to different sessions. Everybody has a leader, and they will organize tomorrow the sessions. Thank you for your kind attention, thank you for tolerance, and let's have some champagne.